Okay. Good morning, doctors and FMGE aspirants. This is Dr. 𝗧𝗵𝗶, a general surgery resident from Lady Hardinge Medical College. And today we join the sessions to know this must know and most important topics discussions, which is a brief discussion part. And if you see this discussion, it is one of the gold standard for your upcoming FMGE examination. And if you read this session or if you take this session much interestingly or with much enthusiasm, then you can crack your examination in your very first attempt. Fine. And let me clarify few things from this session. Okay. And whatever comments you have putting up, I'll be reading through this chat box. And if any doubts regarding the sessions, it will be cleared off in the meanwhile. Whereas if you have any doubts regarding your preparation and things, we'll be taking care of this once we have a break or at the end of the session. Okay, this is the main agenda. Then we'll move on like how this session progress. We have all these 19 subjects which are coming up for next 5 days. And this 19 subjects we have segregated in such a manner so that you can study and you can learn and you can revise at the same moment. And each subjects will be having a discussion around 1 hour to 1.5 hours and maximum up to 2 hours. And with this sessions, I guess you will be able to get maximum number of questions in your FMGE examination. And most of the topics we handpicked based on this PVQ experience and based on this recently asked questions in this NEET PG and the INSET examinations even. Fine. And about this PDF part, I want to address you that we'll share you the PDF because we know from Dr. 𝗧𝗵𝗶𝘀 sir's channel, we never leave you empty hand. We'll share you the PDF once the session is done, and we'll share you all the PDF on a daily basis. On daily basis, we'll share you the PDF. That is our assurance. And whatever doubts you have, you can put up in the chat box and we'll help you out. Give me some time to read the chat box. Yeah. Hi, good morning Deepak, good morning Mas Ahmed, good morning Sam, Kunal and Vrinda. Dr. Mohammed Shanwas Khan, good morning. Yeah, I'm good. Dr. Mungo, Dr. Abhay, Dr. Mohammed Ansan, Dr. Trisha. Yeah, all of you guys, very warm good morning. Right? And I told you today this subjects includes anatomy, physiology and biochemistry. And total hours, our expected duration is around 4.5 hours to 5 hours. First, we'll take up anatomy and we'll have a short breaks followed by this physiology and followed by the biochemistry. In between, we are having a short break and a lunch break. Okay, that is the whole agenda of this session. Yeah, good morning, Dr. Abhishek Kumar. And if you have any questions regarding the session, I'll be more happy to answer you during the session. Okay, and don't worry about the PDF. I'll be sharing this PDF for you for sure, and that is my assurance. Fine, guys. I guess I'm clear from my point of view, and with this, we'll move on to the next part. The first subject I'm going to take, it is the anatomy. If you see about this anatomy part, yeah, some will address your queries as I told, like about all this GT ones, about your preparation ones will take up in the meanwhile or during the break sessions, because these sessions will be wholly given for this content for reading and revising. So if you take up some discussions in the middle, it will be pause their things, and we know it is the heart of the preparation time, and you are coming up, your examination is just 40 days away, right? Surya Prakash, we do understand you. Like, it's better you see the PDF from the videos as of now, and once we're done, you just go through with the PDF and we'll share you both of it. Okay, don't worry. Yeah, good morning, Dr. Mohammed Arfat. Fine. I guess, guys, I understand and answered most of your initial queries. And with this, we'll move on to the next part. And guys, be enthusiastic and be repulsive in the chat section. And if you have any questions or if you have any doubts or any something related to the topics, you can answer it out. And once I answer or once I ask a questions, just be with this emotions to understand and answer the questions promptly. Okay. We'll move on to the first part. First one, what they started asking about this embryological arches and derivatives. And if you see about this embryological arches and derivatives, we know there are this first pharyngeal arch, second, third and fourth. Okay, first, second, fourth, third, fourth, and we know the fifth one will regress, and sixth one we means there will be formation of few contents only, but mainly will rely only on first, second, third and fourth. If you see about this one, then we need to know about few things. One is what? One is this nerve supply. Second one, it is the arterial supply. So how will you remember this nerve supply to this pharyngeal arches? So remember, it is, I told, it is what it is. 1, 2, 3 and 4. I told 1, 2, 3 and 4. And remember by this mnemonic 5, 7, 9 and 10. If you see the first arch, it will be supplied by this mandibular branch of trigeminal nerve. Okay, it is what? It is the mandibular, which is the fifth nerve, which is the branch of this trigeminal nerve. It is the mandibular branch of this trigeminal nerve, which will supply the first pharyngeal arch. Okay, the second one, it will be supplied by this facial nerve, and the third one, it will be supplied by the glossopharyngeal nerve. It will be supplied by this glossopharyngeal nerve, and fourth arch, it will be supplied by this superior laryngeal nerve and this recurrent laryngeal nerve, and both of them, they are the branches of the vagus nerve. So remember, it is 5, 7, 9, 10. And now they started asking about this arteries. And in arteries, what they will ask is, in recent FMGE examination, they asked you, there is a child who is presenting with hello guys, yeah, welcome back. I guess we are live again. Yeah, can you please confirm it once? Yeah, thank you, Dr. Shanavas. Thank you, Dr. Mohammed Anash, Dr. Anju Sharma. Yeah, guys, yeah. That is what. Now, in recent FMGE examinations, they asked this question, like, there is a child who is this newborn, who is having these features of continuous murmur. Okay, continuous murmur. Okay, they didn't ask you this diagnosis. You know, if there is a child or an infant or the newborn and is presenting with features of a continuous murmur, what is the first differential diagnosis you will think of? Good morning, Dr. Sagar. First, you will think of patent ductus arteriosus. You know this answer, and they know that you know this answer, but they won't ask you these things. They will, what they will ask you? They will ask you which of the following pharyngeal arch artery does give origin to this patent ductus arteriosus, or the ductus arteriosus is from the which of the following pharyngeal artery. So just remember this patent ductus arteriosus, it is what? It is due to the ductus arteriosus, and this ductus arteriosus, it is what? It is the sixth pharyngeal artery. And they will ask you not just sixth pharyngeal artery, they will ask you which of the following sixth. Is it on the right or is it on the left? You can see it is the left sixth pharyngeal arch which give rise to this ductus arteriosus. So this is how they will ask you. Then next time they can ask you which of the following artery will be supplied for this first pharyngeal arch. It is what? It is the maxillary artery. And if they will ask you the second one, remember for this second one, everything will start or will be having these letters of S. So it is what? It is the stapedial artery. So the second one, it is what? It is the stapedial artery. And third one, if you see, as I told, it will be supplied by the glossopharyngeal nerve. Okay, it will be supplied by the glossopharyngeal nerve. And next, if you see this third alphabet, it is what? It is the C, A, B, C. So remember, the third will be supplied by the internal carotid artery. By the internal carotid artery. Yeah, good Dr. Mohit, good Dr. Medico, good Dr. Anju, and good Dr. Ashwini, good Dr. Himanshu. Yeah, you are getting it correct. You are in pace. Fine. And next one, the final one, if you see these two nerves, SLN and RLN, they are the branch of the vagus nerve. And remember, this fourth arch, it is what? It will give, it will be having this supply from these two arteries. It is what? The subclavian artery, and the next one, it is the arch of aorta. And we know, like they will ask you here, the point of confusion arises here. They will ask you which of the following artery is a derivative of right fourth pharyngeal arch artery. So if they ask you, you need to answer the right one. It is what? It is the subclavian artery. You can see here, it is the ventral aorta, and here you will be able to see this fourth arch arteries on the right side. You will be able to see this is what? This is the right subclavian artery. This is the right subclavian artery. Whereas contrary to this, on the opposite side, it is what? It is the aortic arch. And we know this aortic arch, it is normally situated on the which side? Yeah, guys, it is situated on the left side. It is situated on the left side, guys. Yeah, guys, you are getting it correct. Fine. And next, they will ask you about this. I told you, right? The sixth arch arteries. The sixth arch arteries on the right side and on the left side. On the right side, I told you, it is what? It is the pulmonary artery. It is just this right pulmonary artery. And we know in left side, it will give rise to this pulmonary artery. But along with this pulmonary artery, it will give rise to this one more structure which is known as ductus arteriosus. Ductus arteriosus. Fine. Yeah, good Dr. Medico, good Dr. Anju, and good Dr. something written in Hindi. Yeah, like that is good. Yeah, बहुत बढ़िया चल रहा है. ठीक है. Just keep this hosh alive and we'll moving ahead with the same session. Fine. Yeah, good Dr. Mohd. Then about this pharyngeal arch derivatives. Pharyngeal arches, we know it will give rise to the glands. And if you see about this gland, which is what? Which is this inferior parathyroid gland and superior parathyroid gland. So just remember, if you see here this image, these are the few derivatives you need to know from the arches. If you see about this first arch, it will give rise to this bone, which is this malleus incus, and this Meckel's cartilage, which will give rise to the mandible. Okay, so the first one, it will give rise to the alum. Okay, and it will be supplied by the 𝗵, which is the mandibular branch of trigeminal nerve, which is this fifth nerve. Fine, that is the fifth nerve, V5-1. Next, if you see about this second arch, it will be having this all S structures, the stapes, the styloid process, and the hyoid bone will be having this two structures. The two horns, one is this lesser horn and another one is the greater horn. So remember, as I told you, the second one will be having this S sounds. So if you see the artery supply, it is what? It is the stapedial artery, and the derivative here, it also will be having this letter S. So one is what? One is the stapes, then the styloid process, then this lesser. So two S are there. So the second arch will give rise to this lesser horn of the hyoid bone. Lesser horn of the hyoid bone. Okay. And about this third arch, it will give rise to this greater horn of the hyoid bone. So third arch will give rise to this greater horn of the thyroid bone and hyoid bone, sorry. And the fourth arch, it will give rise to this cricoid cartilages and the thyroid cartilages. Cricoid and the thyroid cartilages. Okay, fine. And these are these arch derivatives that you should know for must for this pharyngeal arches. And as I told you, these are the two parathyroid glands. They will get origin from this third and the fourth pharyngeal arches. But what is the catch here? If you see about this third, see, it is the third one which is giving rise to this inferior parathyroid. It is not the superior one. So if you see in usual settings, the first one above this thyroid gland, we know there is this parathyroid glands, there is the superior parathyroid gland and the inferior parathyroid gland. There are the superior parathyroid gland and the inferior parathyroid gland. So if you see by nomenclature or by sequence, what should be there? This superior one will be origin from which of the following? Yeah, Dr. Muhammad Anas. Yeah. Like if you see here, the superior one, usually it should be from the third one, right? But here, the catch is what? If you see this catch, this third arch will give rise to this inferior parathyroid. It will give rise to which one? It will give rise to this inferior parathyroid glands. Whereas the superior one, it will give rise to the, it will be given by the fourth pharyngeal arch. So fourth one will be given by the superior parathyroid. Fine. So that is the catch here. So third one, the inferior parathyroid glands, it will be from the third arch, whereas the superior parathyroid glands, it will be from the fourth arch. And as I told you, the mnemonic, all the S things, fine, all the S things. Yes, Dr. Navas, all the S things. If you see about this, all the S things like stapedial artery, lesser horn of the hyoid bone, then the stapes, okay. Then another one S, which is what? Which is this styloid process. All of this, it will be derived from the second arch. But just remember this another S1, which is what? Which is this sphenomandibular ligament. This sphenomandibular ligament, it is not derived from this second pharyngeal arch. It will be derived from the first pharyngeal arch. First pharyngeal arch. So, as a point of conclusion, you need to know about these arches: the first arch, second arch, third arch, and fourth arch. And about the dose supply, remember 5, 7, 9, 10. Okay, it is the 5, 7, 9, and 10. Okay, it is the 5, 7, and 9, 10. Okay, and about these arteries, you need to know first one, it is what? It is the maxillary artery, and the second one, it is the S artery, which is what? Which is this stapedial artery, and third one, it is the third alphabet, it is what? It is the internal carotid artery, and fourth one, it is what? It is the subclavian artery and arch of aorta. On right side, it is the subclavian artery, and left side, it is what? It is the arch of aorta. And for the sixth arch arteries, it includes two arteries. As I told you, it is what? It is this pulmonary artery on this right and left side, and on left side especially, we have this ductus arteriosus. Fine. On left side, it is what? It is the ductus arteriosus. So these are the pharyngeal artery derivatives you should remember of. Next, we'll move on to the muscular part. So if you are able to remember about these muscles, it's well and good. If not, just remember by their nerve supply. Nerve supply. Like, so how will you remember? Like, if you know this muscles of mastication, like remember, it is the muscles of mastication. Yeah, good Dr. 𝗃𝗏𝗀𝗀𝗀. If you see about this muscles of mastications, we know this will be supplied by the trigeminal nerve. Trigeminal nerve, which one? The mandibular branch of this trigeminal nerve. So see, all of the muscles of the mastications will be supplied by this trigeminal nerve, and it will be derived from the first pharyngeal. Okay, it will be derived from this first pharyngeal arch derivatives. And second, if you see about the second one, this it will be supplied by the facial nerve. So the muscles of this facial expressions, it will be supplied by the facial nerve. And here you need to see and you need to focus on these two muscles, which is what? Which is this anterior belly of digastric and the posterior belly of digastric muscle. Yeah, good Dr. 𝗵𝗶𝗀𝗀𝗀. If you see about this anterior belly of this digastric muscle, okay, it will be supplied by the mandibular branch of this trigeminal nerve, and it will be from the first arch. Whereas this posterior belly, it will be supplied by the what? It will be supplied by the facial nerve, and it will be from the second arch, right? And thus third arch, it will be giving rise to this muscle, which is what? Which is this stylopharyngeus muscle. Which is what? Which is this stylopharyngeus muscle. And as I told you, this fourth arch, it will lead to the formation of this pharyngeal muscle. Pharyngeal muscles. That's why our pharyngeal reflex, it will lies on the 10th cranial nerve. Yeah, guys, I hope we are going well and good. If any, if you feel this like what I am telling is it's in a bit faster pace, please let me know so that I can reduce the pace. Fine. Final point to note, you just remember this ductus arteriosus, it is from this left sixth pharyngeal arch derivative. Okay. And next, we'll see about the neural tube defects. And it is one of the most important topic, and it is being repeated in all of the examinations. If you see about the neural tube, they told you it is what? It is the tube. So, if you see any tube, for example, take this pencil, okay? Imagine it is a tube. It will be having these two ends. One is this anterior end and the posterior end. Okay, one is this anterior end and another one is the posterior end. At some point of time, this neural tube should close. This anterior part also should close, and this posterior part of the should close. So if it doesn't close, then it will remain as hollow. Okay, it will remain as a hollow space. So remember. So usually this anterior neuropore, it will closes by the day of 25th day. Fine. And the posterior neuropore, it will closes at the day of 28th. So remember, anteriorly it will close first at the 25th day, whereas this posteriorly it will close by 28th day. And there is some conditions in which this anterior neuropore will fail to close, and there will be few more conditions in which this posterior neuropore, it will be failed to close. And what are the conditions which is happening because of this anterior neuropore failure of fusion? If you see this anterior neuropore failure of fusion, it will lead to this condition which is known as anencephaly. If you see, this is what? This is the anencephaly. They asked in this FMGE the question like, which of the following neural tube defects which happens due to the failure of closure of this anterior neuropore at 25th day? What will be your answer? Yeah, Dr. Anju Tojo and Dr. Shanwas Khan were correct. It is what? It is the anencephaly. It is the anencephaly. Yeah, fine. It is what it is, anencephaly. And good, Dr. Gautam. Good, Dr. Adi. And next, if you see this anencephaly, I told it is the failure of closure of this anterior neuropore, and we know this anterior neuropore, it will also consisting of the skull. So in this, the brain will be exposed to the outside. And if you see the one more resemblant condition, which looks almost similar to this anencephaly, but it will be happening at the midline. It will be happening if there is any failure of closure at the midline level. It will be of two conditions. One is known as cranioschisis, and another one is brachycephalitis. Okay. If you see this cranio, means in cranial cavity, if there is no midline closure, so we'll call them as cranioschisis. Whereas if there is any failure of closure at this midline level in the spine, we'll call them as brachycephalitis. Okay, fine. Just remember. And next about this posterior tube, like posterior pore, it also should close at some day, right? This posterior pore will usually close by the 28th day, and we know this posterior neuropore, if there is any failure of closure, it leads to this condition which is known as spina bifida. Okay, this condition which is known as spina bifida, and this spina bifida, it can be of different types. Either this spina bifida, it will be consisting either of just the meninges, or it will be having this meninges along with this nerves, or the spinal cord derivatives, or just having a tuft of hair. So these are the three specifications or three subdivisions this spina bifida must have. Okay, so if you see, if there is any failure of closure of posterior neuropore at 28th day, it will result into this spina bifida. So the spina bifida can be spina bifida occulta or spina bifida which causing these two conditions which is known as meningocele and myelomeningocele. If you see, if there is just only meninges, so it is what it is, the meningocele. It is the meningocele. Whereas if you see there is this presence of meninges along with this some spinal cord derivatives or nerves are present, so it is known as myelomeningocele. Yeah, it will be available after live, Dr. Ujjwal Kumar. Yeah, good Dr. Anju Tojo, good Dr. Kwanin, and good Dr. Rohit, and good Dr. Gatu, and good Dr. Anju. Fine. Yeah, I guess you are getting this answers correct. I hope these questions will be repeated in your examination as well, and you are making it correct too. Fine. And next, I told you there is no any outside defect. There is no any outside defect. But if you are able to see this type of tuft of hair in the sacral regions or around the sacral regions and the posterior aspect, so it is what it is, the spina bifida occulta. Okay, and this is how this meningocele and myelomeningocele occurs. Like if there is any nerves present, it is known as myelomeningocele, and if there is no nerves, it is known as what? Meningocele. Just remember. Next, about one more condition which is more interesting one. These are like if there is any anterior neuropore defect and if there is any posterior neuropore defect, what will happen? But in some conditions, you see this anterior neuropore closes well and posterior neuropore also closes well, whereas there is this absence of neck. So remember, if there is absence of neck, remember this IN for absence of neck. So if there is absence of neck, it is known as anencephaly. So in a case of anencephaly, there will be no neck present. Right? And there are few more conditions which is occurs in a case of brain. If there is no rugosities, see this is how this normal brain which is having this rugosities, like this sulcus and gyrus. So if there is no sulcus and gyrus, it is known as lyssencephaly. It is known as lyssencephaly. Okay, and we know this brain, it is consisting of two halves, the right half and the left half. And remember, if there is any no half separation, if the brain instead of separating into right and left half, if it remains as a single part, we'll call them as holoprosencephaly. We'll call them as holoprosencephaly. Just remember. Fine. And see and tell me, it is related to this one condition. Can you tell me what is this condition in which this lip is not fused in the midline? Yeah guys, yeah, good Dr. Mohammed Anash, Shanaz Khan, Gautam, yeah, you have answered well in previous questions. Yeah, good. Yeah, good Dr. Anju. It is what? It is the cleft lip. It is the cleft lip. Yeah. And if you are able to see this kind of holoprosencephaly, cleft lip and all these midline defects, because if you see, there is no separation, there is no midline in the brain. That's why there is no right and left. There is just one brain. And here there is this midline fusion defect, which leading to this cleft lip. And both of these things, along with the features of rocker bottom foot, will be classical for a chromosomal anomaly. Can anyone tell me which of the following chromosomal anomaly will have this? Yeah, good, Dr. Mohammed Anash, you read very well. It is what? It is the Птау syndrome. It is the Птау syndrome. It is the Птау syndrome which will have this association. So remember, Edwards syndrome, no, Edwards syndrome, it is the trisomy 18 and it won't have this central defects. It will be having this elongated fingers along with the features of elongated kidney, which is what? Which is this Harshu kidney. We'll see them in the pathology aspect. Okay, good. I like that you have this thing, like at least you have this motto of being answering. That's really well. Just keep this Josh alive for a few more days. Okay. Then we'll move on to the next part about this epithelium. Okay, about this epithelium, they are started asking in all the examinations, in the NEET PG as well, in the INSET as well, and in the FMGE examination as well. What they give is, they will give you this some slide. They will give this slides, and they will ask you which of the following epithelium is this, or which of the following organ is this. Okay, sometimes they can give you this slides of this pancreas, about this beta cells of the pancreas, and they will ask you which of the following organ is this. It is what? It is the pancreas. Whereas sometimes what they will give is, they will give this sphere. We know this is simple. Simple means it is a single layer flat cells. It is what? It is the simple squamous epithelium. And we know this simple squamous epithelium, it is present in what? In the alveoli. Yeah, good, Dr. Deep. Fine, good. Yeah. Next one, if you see, next one, it is what? It is the transitional epithelium. Transitional means it is what? It is the changing epithelium. Once under stress or under increase in volume, this transitional epithelium, it will change its shape. So this type of transitional epithelium, it will be seen in a case of bladder. In bladder, you will see this transitional epithelium. And next we will see this cuboidal epithelium. Means this cuboidal epithelium, which help in this filtration process, it will be seen in a case of, there will be these cubes. You can be able to see some of these cubes, because the image is bit unclear. So if you are able to see this type of cube shaped cells and the central nuclei, so it is what? It is this cuboidal epithelium. One of the example of this cuboidal epithelium, it is what? It is the kidney. Next, about where there is this absorption along with this secretion takes place. So it will lead to this type of epithelium where this epithelium presents, and here you will be able to see this nuclei at the base. So it is what? It is the columnar epithelium, and this columnar epithelium will be present in the stomach and in our intestine. And next you will be able to see this type of epithelium. As I told you, there is this different shapes, and based on the stretch, they will stretch out, they will become elongated. So it is what? It is the transitional epithelium. And we know when a bladder start filling, initially the bladder volume will be like this, and when it start filling, this need to be stretched out, right? And when it starts stretching, this epithelium also stretch. So it is what? It is the transitional epithelium, which will be seen in a case of bladder. Yeah, good, Dr. Mohammed Shanwaz Khan. Yeah, that's why we see one of the common cancers in bladder. It is what? It is the transitional cancer in the bladder. Fine. And next, about the stratified squamous epithelium. As I told you, the simple squamous means it is one layer of cells. Whereas in the case of stratified squamous epithelium, the stratified means there is a multiple layer. It will be having this multiple layers. And we know, if there is any multiple layer of the cells, it is known as stratified epithelium. And if there is multiple layer of this type of flat cells, so it is known as stratified squamous epithelium. And we know this stratified squamous epithelium, it will lines this esophagus. And in esophagus itself, there is a question which is known as metaplasia. Normal lining of this esophagus, it is what? It is the stratified squamous epithelium. As I told you, in stomach, there will be this acid secretions in stomach. So there will be having this columnar epithelium. Okay. Any external opening? Yeah, any external opening to withstand the stress and things will be having this squamous epithelium, like around this oral cavity and the vaginal orifices. All of this will be having this squamous cells, and in skin will be having this keratinized form of this squamous epithelium. Right? Yeah, good, Dr. Anirudh. Yeah, good, Dr. Abhay, good, Dr. Adi, good, Dr. Gautam. Yeah, you are getting it into the mark. So it is what? It is this columnar epithelium which is being changed from the squamous epithelium. So it is what? It is known as metaplasia. It is known as metaplasia. And we know this metaplasia, which is known as Barrett's esophagus. And remember one thing, it is not just this columnar epithelium, it is also presence of which cell? It is also presence of which cell? It is also presence of this goblet cells, which is this mucus secreting cell. So this columnar epithelium along with this presence of this goblet cell will call them as intestinal metaplasia. Okay, we'll call them as intestinal cells and intestinal metaplasia. Yeah, good guys. Yeah, good Dr. Anju, good Dr. Muhammad Anash, good Dr. Aishi. Right? And so that is this Barrett's esophagus, and we know what is the name of the stain which we'll use for this Barrett's esophagus to see these goblet cells. Guys, any idea? That is what it is, the Alcian blue. It is the Alcian blue stain which will use for staining this goblet cells, which will be containing this acidic mucin. Yeah, good Dr. Mohammad Shanwas Khan, good Dr. Quinine. Yeah, that's really absolutely awesome. Good Dr. Aishi Chowdhury, I'm really very happy with it. Yeah, good Dr. Anirudh. Fine. Yeah, good Dr. Mohammad, she told even the pH itself. Yeah, that's really well. Fine. Next, about this hemorrhoepithelium, this stratified or multi-layered cuboidal will be seen in a case of sweat glands, whereas this stratified columnar, this multi-layered columnar will be seen in a case of salivary glands. Next, about this one, which is having this cilia. So we know this respiratory tract, it will be having the cilia. So in respiratory tract, there will be presence of this epithelium along with the cilia. So it is what it is, the pseudo-stratified ciliated columnar epithelium. Okay, so actually it is a single layer, but it will be appearing as a multiple layer. And we know one more thing, that in a case of metaplasia in the respiratory tract, will it be a squamous metaplasia or a columnar metaplasia? Yeah guys, a good Dr. Shanwas Khan, Dr. Anju. Yeah guys, answer for this question. What is the name of the metaplasia you will see in a case of trachea? That is what it is, the squamous metaplasia. It is the squamous metaplasia which you will see in a case of trachea. Okay, so normally the respiratory tract will be having this pseudo-stratified ciliated columnar epithelium. Good guys, good Dr. Trisha and good doctor. Next, about the joints. ठीक है, अब joints पे चलते हैं. ठीक है, about this joints आपको कुछ चीजों याद रखना है. Means you should know few things for must while solving the joints. First one, they will mostly test about this primary and secondary cartilaginous joints. Okay, if you know anything, if you don't know anything, just remember this one thing, this about this cartilaginous joints, this primary and secondary cartilaginous joints. Remember about this secondary, remember secondary for center. So whatever joints in the center, it will be having this secondary cartilaginous joints. Secondary will be this center, secondary cartilaginous joints. It will be in the center. So what are the joints which present in the center? For example, our pubic symphysis, and then our this xiphisternal joints, all the sternal joints, like especially on the center, like the xiphisternal joints, and our vertebral discs, this intervertebral discs. All of this, they will lie in this central point. So they are what? They are this secondary cartilaginous joint. Right? And about this around or adjacent to the centers, you will be able to see this is what? This is the costosternal joints. All of these sternocostal joints, it will be what? It will be primary in nature. And sometimes they will ask you, what is the difference between this primary and this secondary cartilaginous joints? If you see about this primary one, you will be able to see there is the only presence of this hyaline cartilage, okay. Whereas the secondary, there will be a hyaline, but there is a person, okay, beach mein. There is a person in between this hyaline, okay, in the center or in between these two hyaline cartilages, there is one cartilage which is what? Whether this fibrocartilage present. That's why it is known as secondary cartilage. So remember, secondary cartilage, it will be having these two cartilages, which will be this hyaline cartilage and this fibrous cartilage. Right? And there is one more fixed fibrous joint which include this 𝗵𝗿𝗆𝗃 joints and this sutures. So they will ask you, 𝗵𝗿𝗆𝗃 is which type of joint? Whether this is a fibrous joint or a synovial joint. What will be your answer? Yeah, good Dr. Mohammad Ansh, good Dr. Hari Krishnan, hi Dr. Hari Krishnan, good Dr. Chowdhury. 𝗏𝗏𝗀𝗃𝗃 and good Dr. 𝗵𝗵𝗶𝘀. Yeah, good Dr. Rohit. Yeah, it is what it is, the fibrous joints. Good guys. And next about the synovial joints. The synovial joints mainly it is what it is, the movements. So in synovial joints you'll be having ample of movements. So you will able to do maximum movements in which joint? It's the synovial joint. And in synovial joint there is a presence of this fluid which is known as synovial fluid. And this synovial joints which will be having this synovial fluid will be of different types. For example, if you see this our shoulder joint, which will be able to perform this multi-axial movements. It is what it is, this ball and socket joint. Okay, one is this shoulder joint and another is the hip joint. Can anyone tell me what is the one more ball and socket joint? Guys, waiting for your answers in the comment section. Yeah, hip, yeah, 𝗵𝗵𝗀𝗀𝗃, yeah, in ear, yeah, in ear. There is two joints in here. There is, yeah, there is two joints. Yeah, guys, you are getting it correct. Good, Dr. Saloni. Yeah, good, Dr. 𝗵𝗵𝗀𝗀𝗀, Anju, Adi. Yeah, good, Ritika. Okay, yeah. See, in ear there will be two joints. They will make the point of confusion in here only. So see, there are two joints in here. Remember as 𝗵 and 𝗵. Okay, remember 𝗵 and 𝗵. So if you see this first joint, which is this, between this malleus and incus, it is what? It is saddle joint. It is the saddle joint. Whereas if you see next joint, which is this 𝗵𝗵𝗀𝗃𝗃𝗃. Okay, 𝗵𝗵𝗃𝗃𝗃𝗃, it is what it is, the ball and socket joint. It is the ball and socket joint. Yeah, good Dr. Rohit. Yeah, good Dr. 𝗵𝗵𝗀𝗀𝗀 for you. Yeah, it's for me. Yeah, and Dr. Quinen and Dr. Ritika. Yeah, Rohit. Yeah, you are absolutely awesome. Like you are exploding with answers like बहुत बढ़िया, बहुत अच्छा चल रहा है. Okay, just keep this josh alive for next more 40 days. Just I hope like and I will wish that you will pass this examination and come out with flying colors. Okay, बस बहुत बढ़िया. So they will ask you this point of confusion. When there is two point of confusion, they will ask you a question. So this malleus and incus joints, it will be this type of joint which is known as saddle joints, whereas this ball and socket joints, which is this 𝗵𝗵𝗀𝗃𝗃𝗃𝗃 joint. Okay, remember. Yeah, good guys. Next, if you see, they will mark this first metacarpophalangeal joints, and they will ask you which type of joint is this. Then you need to tell it is what it is, the saddle joint. So if you see, it is the between this carpal and metacarpal. And next about this pivot joints, you need to know about the first. Okay, see, first for everything you will try to say yes, but later on you realize the thing, no, it is not for me. So then you will tell no. So remember the first joint, it is what it is, this atlanto-occipital joint. It is what it is used to help to tell this yes. Whereas the second joint, which is this no joint, which is this between this atlas and axis, it is a type of pivot joint. So remember, it is the no joint. So initially you will tell, means because you are a bit immature, so you will tell yes to everything in the life. But later on you realize no, ये मेरी बस की चीज नहीं है. तो इसीलिए then what you will do, you will say no, it is not for me. So you will tell no and you will avoid this unfortunate circumstances. Okay, फिर उसके बाद आगे बढ़ते हैं. As I told about this ball and socket joints. Next about this hinge joint, like example of this hinge joint, where there is usually this uniaxial flexion and extension takes place. For example, your elbow joint, your knee joint. So it is a type of hinge joint, right? And about this ellipsoidal joint, these are the joints between this radius and this carpal bones, especially this wrist joints. And about this temporomandibular joints, these are the type of ellipsoidal joints. These are the type of ellipsoidal joints. Next, they will ask you, means like this, they will mark and ask you which of the following joint is this. As I told you, it is what it is at the level of knee, so it is what it is, the hinge joint. So you know it, guys, you better. Fine. Yeah, good Dr. 𝗵𝗵𝗀𝗀𝗀𝗃, good Dr. Shamaskhan, fine, good Dr. Aishi. Wow, like very well done. Then with this understanding, we'll move on to the next part. ठीक है, आगे बढ़ते हैं. अगर आगे बढ़ेंगे तो this recently they will ask you these questions, like they will point some point in your examination. They will point some point, like for example, they will keep this finger or this point around this jugular notch, and they will ask you at which vertebral level this point lies. Okay, remember this jugular notch, it will lie at the level of T2 to T3. This jugular notch, it will lie at the level of T2 to T3. Like for example, there will be this sternum and there will be this jugular notch. They will keep or point this arrow, and they will ask you which of the following vertebral level does this exist. So it is at the level of T2 to T3. And next about this diaphragm. and they will mark around this diaphragm. Around this diaphragm they will mark, and they will ask you at which vertebral level it is. It is at the level of T9 to T10. And here the point of confusion next. See, about this umbilicus, you know, this dermatomal supply, it is what? It is the T10. So it is not same. So remember, it is not dermatomal supply they are asking. They are asking you what? They are asking you the topographical level or which vertebra lies behind it. So remember, about around the umbilicus, it is what? It is the L3 and L4. If you want to choose, or if you are opted between choose one, choose L3. Okay, choose L3, because mostly they will lie around or over this L3 in most commonly. A good Dr. 𝗚𝗍𝗍𝗀𝗃, good Dr. Ritika, good Dr. 𝗧𝗵𝗶𝗀𝗀, a good Dr. Anirudh. Fine. If they put some line, mostly in recent examination, they asked a line which is passing above this umbilicus. So in such conditions, you try to answer it as L3, but if not, mostly they will give this ranges or give this intervertebral disc level between this L3 and L4. Okay. Next, about this axis, it is what? It is this anterior superior iliac spine. So remember about this anterior superior iliac spine. How will you remember this? The name itself tells. Remember S1. So it is the S1 level. And on the posterior aspect, they will ask you, like, there is a patient who is presenting with features of pleural effusion. Now you plan to do a pleural tapping. Okay. Now you plan to do a pleural tapping. You make the patient to sit, and you are percussing, and you got the dullness. Now you want to do this pleurocentesis. Now you need to locate the scapula. They will ask you at which level this scapular inferior border located. So the inferior border of the scapula, it is located at the level of T7. It is located at the level of which level? It is located at the level of T7. Okay, it is located at the level of T7. Just remember this, guys. And about this next point, now you are in your OBG posting, or it will be your anesthesia question. You got a patient who will be posted for this cesarean section. Now you plan to do a spinal anesthesia, and for spinal anesthesia, you are putting two hands on the patient's back. Okay, and you are palpating the highest point of the iliac crest. You are palpating the highest point of the iliac crest, and you are seeing your thumb, means you kept one hand here, and you see this, your fingers will be meeting at the level. So they will ask you at which level the highest point of iliac crest lies in, or at which level you will give this spinal anesthesia. The one answer, it is what? It is the L4. Wow, good, best Dr. Anirudh. It is what? It is the 𝗵𝗵𝗀𝗀 line. So this line, it is known as 𝗵𝗵𝗀𝗀𝗀 line. 𝗵𝗵𝗀𝗀𝗀 line. Okay. As I told you, as it is at the level of S1. So remember, don't confuse for this posterior superior iliac spine also. It is what? It is the S2. Okay, so just remember the anterior and forget about the posterior. If you know this anterior, you will make sure you will make this thing correct. So anterior superior iliac spine, it is SI, looking like a S1. So it is the S1. Okay. Yeah, good Dr. 𝗀𝗀𝗀𝗀. It is what, like, mostly will do at the level of L3 to L4. So to locate this, we'll use this vertebra. So you will see this L4 vertebra, and we'll just go ahead and we'll able to palpate this intervertebral disc, okay, which is a secondary cartilaginous joints, and there we'll put up the needle. Fine. And sometimes they will give you this point. Okay, they will give this point, and they will ask you about this lines. If you see, if there is a line which is being transversed around this pylorus of the stomach, if there is a line which is transferring this pylorus of the stomach, it is at the level of which level? It is at the level of L1. It is at the level of L1. Yeah, wow, Dr. 𝗧𝗵𝗶𝗀𝗀𝗀, yeah, patriation is tough, like labor is very tough procedure, so it is what? It is 𝗵𝗵𝗀𝗀𝗀𝗀 line. Yeah, good, like great mnemonic, Dr. 𝗧𝗵𝗶𝗀𝗀𝗀. Yeah, that's really good. Yeah, good, Dr. Ritika Satach. So it is what? It is the transpyloric plane, which is at the level of L1, which is at the level of L1. Next, if you see the next one, below this coastal, so this subcostal line, it is at the level of L3. As I told you, this is our umbilicus, and around the umbilicus, you will be having this L3. And if they are asking at the level of disc, it is this between this L3 and L4. So this L3, which is this subcostal plane, which is at the level of L3. And there is one more thing which is known as supracrystal plane. It is at the level of L4. Supracrystal plane, it is the level of L4. And final one, it is the intertubercular plane. And this between this tubercle, it is at the level of L5. Okay, this tubercular plane, it is lies at the level of L5. So remember, this transpyloric plane, it is at the level of L1. Okay, and next about this subcostal plane, it is at the level of L3, and supracrystal plane, it is the level of L4. Fine, and intertubercular plane, it is the level of L5. Okay, don't forget this umbilicus one. The dermatomal supply, it is T10, it is not the vertebral level. So the vertebral level, it is what it is between this L3 and L4. Okay, it is between this L3 and L4. Good Dr. Varun, good Dr. Anirudh, good Dr. 𝗚𝗫𝗁𝗀. You are doing absolutely awesome. Right? With this understanding, we'll move on to the next part. A good Dr. Rohit. Next, the most important part. Okay, why it is most important? Because there is this 3 subjects integration. It will be asked in your surgery part, your ortho part, or from this anatomy part. You cannot tell this is anatomy questions. I didn't read it. Okay, it is the integrated questions. So अगर पूछेगा तो मैं जवाब देना पड़ेगा. Because this is the exam where you cannot tell any reason in your life. Because everyone will be having some part of problem. सबको कोई ना कोई दिक्कत तो रहता है. लेकिन जो भी होता है, जो भी आगे बढ़ता है, वो दिक्कत के साथ, वो he will be progressing ahead in his life along with these problems. अगर problem नहीं होता, वो chill रहता है, बंदा बिंदास रहता है. So make sure you are having the problems. Yeah, I know that you are having the problem, but make sure you are coming out of this examination with the problem and you are solving the problem after it. Okay, don't try to solve the problem now. The problem will get solved once you pass the examination. Okay, that is my kind of motivation. So just push yourself for next few more days and you will be coming out with flying colors. Fine. उसके बाद आगे बढ़ते हैं. Then if you see this first one, it is what? This type of scapula, which is known as winging of scapula. And we know this winging of scapula, it is due to the injury of nerve of bulb. A good Dr. Anirudh. So it is what? It is the injury to this nerve of bulb, which is also known as injury to long thoracic nerve. And we know this nerve, which is most oftenly injured during this mastectomy procedures or any lymph node biopsy, are also known as sentinel lymph node biopsy procedures. Okay, so during these procedures, this long thoracic nerve or this nerve to bulb will get injured and it will lead to this condition, which is known as winging of scapula. And we know this long thoracic nerve, it will be supplying this muscle. What is the name of the muscle? Can you guess? Which is known as Box's muscle. Wow, like good Dr. Shanwas Khan, but 𝗚𝗫𝗁𝗀 की तरफ you should go ahead. Yeah, fine. Yeah, good Dr. Anirudh, good Dr. Adi Ujjwal. Yeah, wow, good Dr. Ritika, good Dr. Ram Prasad. Yeah, that's correct. Yeah, let success make the noise. Like for sure we'll come out with success, but once we get the success, we'll make a loud, right? And we'll make us proud. Good. And if you see this long thoracic nerve, it will be supplying this muscle, which is what? Which is this serratus anterior. And if there is any damage to this muscle, which is the serratus anterior, which will lead to this phenomena, when you tell the patient to push your hand, you will be able to see this type of scapula, which is known as winging of scapula. Okay, फिर उसके बाद आगे बढ़ते हैं. Next, if you see this 𝗚𝗨𝐶, which is known as 𝗵𝗄𝐵, which is known as what? Which is known as 𝗵𝗄𝐵. And we know 𝗵𝗄𝐵, it is damage to the upper tract. Remember, and it is the level of C5 to C6. Okay, we know the muscle which is causing this abduction of the shoulder till 90 degree. What is the name of the muscle which causes abduction of this shoulder from 15 to 90 degrees? Yeah, good Dr. Kilshit. Yeah, good Dr. Rohit. So it is what? It is the deltoid muscle. So if there is any damage to this deltoid muscle, then there will be no abduction. So the arm will remain adducted. Then we know the flexors of this component. It is what? It is the biceps. So if there is any damage to the biceps, then we cannot flex it. Then the hand will remain in the extensor position. And we know one more thing, the biceps, it is what? Is it a pronator or a supinator? A good Dr. Sartaj and good Dr. Gattu? It is what? It is a supinator. So if the biceps is gone or the nerve supply to the biceps is gone, which is this musculocutaneous nerve, which is a branch from this C5 C6 trunk, then the patient cannot supinate the arm. So the arm will remain pronated. So remember, the arm is adducted and the arm is extended and the arm is what? The arm is pronated. Okay, and the arm is pronated because it is not supinated because there is no biceps muscle acting. So the arm will be adducted, then the biceps will be gone, so it will be extended and it will be in pronated position. And remember, and it also will be in internal rotation. It will be internal rotation. There will be this internal rotation, extension, and along with this pronation, and finally flexion at the flexion. Okay, finally flexion at this elbow level. So all of this thing, it is what it is known as 𝗵𝗵𝗀𝗀 palsy. Okay, it is known as 𝗵𝗵𝗀𝗀 palsy, and during labor or delivery, when you apply the forceps, then at this moments, if you damage this brachial plexus, it will lead to this type of palsy, which is known as 𝗵𝗵𝗀𝗀𝗀 palsy. Yeah, good guys. It is known as what? It is known as policeman hip deformity. Okay, deformity, and it is also known as 𝗬𝗃's tip or 𝗬𝗃's hand. Okay, it is also known as 𝗬𝗃's tip or this 𝗬𝗃's hand. A good Dr. Shanwas Khan, good Dr. Anirudh Sharma, and Dr. Ashish Chowmi and Sadaj. Good, बढ़िया बढ़िया, बहुत बढ़िया. Okay, a good Dr. Anju. Right? फिर उसके बाद आगे बढ़ते हैं. So one of the most important picture from the anatomy and the orthopedics. If you see this first point, there will be few arteries and the nerves which will be in relation to the humerus. First artery which we need to see, it is what it is, this posterior circumflex humeral artery. So we know this is the humerus bone. So if you don't know, just remember it is the humerus bone. Okay, and in humerus bone there is multiple relations. Okay, it is like a best friend of us because it gives pass to the multiple nerves and the multiple vessels, and most often they get injured. And once they get injured, what they will do? They will ask questions in your examination. So these two things will do. Once they get injured during a fracture, they will ask you this question, like in this fracture, which of the following nerve or this artery will be involved? Yeah, good guys. First, if you see around this surgical neck, there will be one artery which is what? Which is this posterior circumflex humeral artery, which is encircling this surgical neck, and there will be one more nerve, which is what? Which is this axillary nerve. And two of these structures will be damaged during the fracture of the surgical neck. There will be damage to this axillary artery and this posterior circumflex humeral artery. Next, around this shaft of humerus, we know there is a groove which is known as a radial groove, which passes to this radial artery and this deep part of this bronchus artery. Deep part of this are profunda bronchi artery. So this structure will be damaged when there is a mid-shaft fracture. So if there is a mid-shaft fracture, it will lead to this damage to this radial nerve, good Dr. Aishi, and damage to this profunda bronchi artery. Right? And next, about these two important nerves, one is the median nerve and the ulnar nerve. Remember, this ulnar nerve, it will supply this medial aspect of your hand. So remember, it is around the medial epicondyle. So remember, when you sometimes when you touch or when you put a knock over this medial epicondyle, you will see some tingling sensations, right? It is because of the involvement of this ulnar nerve. In examination, they will mark you this structure. Which of the following nerve will be in close relation to this structure? So it is what? It is the ulnar nerve. Next one, there is this above this epicondyle, if there is any fracture occurs, we'll call them as supracondylar fracture. This is known as supracondylar fracture. And in supracondylar fracture, there is two structures will get involved. One is this structure which is known as median nerve. Okay, median nerve. If they given you this option as anterior introitious nerve, then you should choose anterior introitious nerve more than this median nerve. Okay. Then about the artery which is what? Which is this brachial artery. And all of these things. So remember, this surgical neck of humerus, it is this axillary nerve along with this posterior circumflex humeral artery, and in the shaft, it is what? It is this radial nerve, and there is this profunda bronchi artery, and around this supracondylar, you will able to see there is a median nerve on this brachial artery, and around this medial epicondyle, you will able to see there is a nerve which is what? Which is this ulnar nerve. Okay, so if there is any damage or if there is any fracture, all of these nerves or this vascular structures will be impaired. Fine. With this understanding, we'll move on to this individual nerves. First one, as I told you, axillary nerve. We know this axillary nerve will supply two muscles. What are the two muscles which will be supplied by this axillary nerve? Yeah, guys, fatafat. Yeah, Rahul, that gunstock deformity will study in orthopedics. Yeah, one is good Dr. Ritika, one is this deltoid, and another one is what? It is the teres major or minor. Yeah, good Dr. Quinen, good Dr. Shanwas Khan, Saloni, Trisha, Pratap, again, yeah, good. No, see. Wow. This is the point of confusion. We know there is one muscle which is the deltoid. The second muscle, it is what? It is the teres minor. It is the teres minor. It is not the teres major. It is the teres minor. And there is one more point of confusion. There is two muscles will be supplied by this spinal accessory nerve. This spinal accessory nerve, or this 11th cranial nerve, will supply two muscles. What are the two muscles? One is this sternocleidomastoid and the trapezius. Okay, I guess you won't forget Dr. Ritika. Okay, you won't forget this question. Like spinal accessory nerve will supply two muscles, which is this sternocleidomastoid and the trapezius one. Whereas this axillary nerve will supply two muscles, which is this deltoid muscles and the teres minor. And this axillary nerve will supply around this region of this deltoid region. So if there is any deltoid muscle palsy, then this shoulder counter will be lost at this region. So there is this loss of shoulder counter, and there will be this anesthesia. So this anesthesia, which is known as regimental, are also known as regimental anesthesia. Fine. And next about this ulnar nerve. Okay, is ulnar nerve is known as musician's nerve, or also known as Leber's nerve. Is ulnar nerve is a musician nerve or a Leber's nerve? Yeah, guys. A good Dr. Aishi, good Dr. Rohit, good Dr. Anirudh. Yeah, it is the classical claw hand. Yeah, good. Okay, but focus on what I'm asking. It is not wrist drop, it is the claw hand. Okay, it is first, let me tell you, it is the claw hand. Okay, and before that, what I asked you. Yeah, so remember, ulnar nerve, it will supply this fine movements. Okay, it will be responsible for this fine movements. So it will supply this intrinsic muscles of the hands. So since it supplies these intrinsic muscles of the hands, which will responsible for your fine movements, so this is what this is known as musicians nerve. Musicians nerve, like you know, right? Musicians cotton, like so. This is what this is. This musicians nerve, fine. And this musicians nerve, it also will be responsible for this flexions, the flexions at the level of fingers. Okay, and it will helpful for this adduction of the hand and this abduction of the hand. So if there is any damage to this ulnar nerve, then there will be damage to this all of the following structures. Fine. So if there is any damage to this ulnar nerve along with this sympathetic trunk, so ulnar nerve along with this sympathetic trunk, or this claw hand along with this sympathetic trunk involved, we call them as 𝗵𝗶𝗀𝗀𝗃 palsy. We call them as 𝗵𝗵𝗃𝗀𝗃 palsy. And next, it is just this claw hand. If there is just ulnar nerve involved, okay, it will lead to this type of claw hand, which is partial claw hand. So it is the claw hand. So as I told you, this ulnar, remember this ulnar, there is a L. Okay, there is a L. Okay, there is a L in ulnar. So it will make L. Okay, so remember, it will cause flexion. It will cause flexion at the level of this joint, which is this metacarpophalangeal joint, and here it will cause extension. Whereas if there is no ulnar nerve, then it will lead to this type of hand, which is known as claw hand. So this type of joints, which is known as claw hand. So ulnar L, so it will make this L. So it is this function of this ulnar nerve. Then if there is no function of this ulnar nerve, if there is any damage, it will lead to the formation of this hand, which is known as claw hand. Fine. And to test this ulnar nerve, good Dr. Anju Tojo, that is the correct explanation for this claw hand. Good Dr. Aishi, good Dr. Merabi, that is like if there is only involvement of the sympathetic trunk, then it is what? Then it is the Horner syndrome. Yeah, good. Yeah, then to test this viability of this nerve, we'll use some test. As I told you, it will supply this hand muscles, so it will cause adduction. So introchet, which will causing this adduction. So to test this, we'll use this card, which is known as card test, which we use for adductors. Okay, adductors. So remember, that is the pad and dab. So palmar interrogae will help in this adduction. So we'll test with the test which is known as card test. फिर उसके बाद आके next test. Then this dorsal interrogae क्या करता है? It will help in this abduction. It will help in this abduction of these fingers. It will help in the abduction of the fingers. So if we want to test this abduction, we'll give a special name to this, which is known as 𝗍𝗓 test. Okay, we'll given this special name which is known as 𝗍𝗓 test. फिर उसके बाद आगे चलते हैं this test. If you see this test, like हमने तो पूरा हिस्सा means whatever the हिस्सा of this hand we have given to the ulnar nerve. because it will supply this intrinsic muscles of the hand. लेकिन हमने क्या किया, means we did something to the median nerve, means we given some favor to this median nerve. This region which is this thenar or this muscles which is supplying the thumb, it will be supplied by the median nerve. But we know this is dominated, or this hand muscles will be dominated by this ulnar nerve. So हमने क्या किया, we given one muscle supply, just one muscle supply to this thenar muscle. Okay, so the one thenar muscle which is having this ulnar nerve supply, कौन सा वो? A good Dr. Anuj. So it is what? It is the Fromm's test. It is the Fromm test. But कौन सा muscle है? Is it adductor pollicis or the abductor pollicis? A good Dr. Ritika, good Dr. Anuj, good Dr. Gautam. It is what? It is the adductor pollicis. It is the adductor pollicis. It is the adductor pollicis. So if you want to check this function of this adductor pollicis, you will give a card or this book test. We'll call them as Pharma's test. Okay, so when you tell them to hold this book in this position, the patient usually hold like this. But if there is damage to this nerve, then the patient will held by flexion. So because of the flexion, if they held, it is due to the damage of this ulnar nerve, the adductor is not working properly. Okay, you just remember. Okay, I hope this test of this ulnar nerve will help you out. And remember one more thing, this ulnar nerve ऊपर से जाता है. Ulnar nerve will goes superficial to this retinaculum, superficial to the flexor retinaculum. ठीक है, so you know this mnemonic, ulnar nerve ऊपर से, ulnar ऊपर, ulnar ऊपर. So ulnar nerve, it will go superficial to this flexor retinaculum, whereas this median nerve, it will pass through this flexor retinaculum. ठीक है, इतना याद रखना. फिर उसके बाद आगे बढ़ते हैं median nerve की तरफ. As I told you, this median nerve, it is what? It is one of the nerve which supplies this major muscles of the forearm. So median nerve, it is also known as labrous nerve. Q labrous nerve, because labrs, they will hold these things, right? So to holding these things, you need the flexion action. So this median nerve, it is also known as labrous nerve. Anirudh. In TNR, there is a supply of median nerve. Why we do format test in ulnar nerve? Yeah, Dr. Anirudh. See, like in a case of like if there is any proper adductor function, then the hand will look like this. Fine, it will be this normal side. Okay, because there are other muscles or other branches of the ulnar nerve which will be helpful for this adduction and abduction of this palm, whereas this only one muscle, because rest are supplied by the median nerve. So you want to check only one muscle whether this is working, this ulnar nerve is working or not. You can check with this one test, which is what was this Fromm's test. Okay, because it will supply which muscle? It will supply the adductor muscle. So if the adductor is working, then ulnar nerve is well and good. If it is not working, if it is compensated by this flexion, then it is what? Then it is not working, it is being damaged. Okay, that is the reason we do, Dr. Anirudh. Okay, I hope it will address your query. Next, फिर उसके बाद आते हैं कि median nerve. So median nerve, it will helpful for this flexion of your hands and along with this forearms and the wrist. Okay, and this damage to this median nerve will lead to this type of hand, like this type of hand. Okay, this type of hand, which is known as which hand? Benedict's hand. And remember, this type of hand, which is known as Benedict hand, it will happen when you make flexion. When you make flexion, it is known as what? It is known as Benedict's hand. Next one, if you are able to see this type of index finger, this is known as pointing index. This is known as what? This is known as pointing index. So because this flexion will be done by this median nerve. So if there is any damage to this median nerve, okay, this lead to this type of feature which is known as pointing index. Yeah, good Dr. Rohit. Yeah, good Dr. Pratap. Good Dr. Anirudh. Yeah, Rohit. Yeah, good. Well, fine. And next, as we saw, this adductor will use for ulnar, whereas this abductor, to test this thenar abductor pollicis, will use this test which is known as pen test, and pen test will use for this abductors. Yeah, good Dr. Quenan. Good. Next, there is, as I told you, right, in supracondylar fracture of this humerus, the nerve which is involved, it is what? It is the median nerve and a branch of median nerve which is known as anterior introsus nerve. In some situations, this anterior introsus nerve may get damaged. So in such situations, what he will do a test you will tell the patient to make okay, so that you can see the patient is okay or not. So you will tell the patient to make this okay sign. Okay, you will tell the patient to make this okay sign to see whether the patient is okay or not. Okay, so if the patient is making like this, then his anterior introitious nerve is well and good. If he is making this weak okay sign, then his anterior introitious nerve is damaged. A good Dr. Amal and good Dr. 𝗚𝗍𝗶𝗀𝗃. Fine. And next one, if you're able to see, this is our classical wrist drop. We know this radial nerve, it will supply this extensors of this wrist. So if there is no extensors, then there will be this wrist drop. Okay, there will be this wrist drop along with this finger top. So remember, radial nerve injury, it lead to this wrist drop. And about this sensory supplies, we know this is the palmar aspect, and we know the medial side of this palmar aspect, it will be supplied by this ulnar nerve. Okay, and lateral side it will be supplied by the median nerve. Whereas on the posterior aspect, if you see here also, it will be supplied by this ulnar nerve, whereas this around this fingertips, it will be supplied by the median nerve, and this posterior aspect of this 2.5 fingers, it will be supplied by this radial nerve. It will be supplied by this radial nerve. Good Dr. Anuj, good Dr. Rohit, yeah, you are getting it correct. I hope we are in pace, we are going very good, very well. Okay, if you have any doubts, please post it, we'll help you out. Yeah, good Dr. 𝗓𝗵𝗶𝗀𝗀. Fine, I guess I'm not going very much fast. I guess I'm in a ample of pace so that you can follow it up. So this is kind of revision session, so that you already compiled your knowledge. You need something or some source to come out or to push up that, or you can make this as a revision source, like 1.5 hours full anatomy is done, or what you need for the examination, because you are reading everything else, like everything of anatomy, but you don't know what is needed for anatomy. Then what is the mean of reading it? So if you see this session of this all 19 subjects, you know what is being asked in the examination, and if you read or revise this session itself, then you will pass the examination for sure. That is my guarantee. Okay. Then if you see about this tendons of the forearm, they will mark you, means they will show this flexed hand and they will ask you which of the following tendon is this. So sometimes it will be very or bit confusing for you. So yeah, thank you Dr. Anirudh, thank you Dr. 𝗓𝗔𝗃. This make me to motivate and do better things for you. Okay, thank you guys. No, like Rahul, the anatomy is like that. Anatomy is it is like that. It is very volatile. Okay, it is volatile like a petrol. If you keep, it will be volatile. So don't worry about anatomy. If you're able to do these sessions, it will be helpful, and you will be able to get at least 15 or at least 10 questions from this session. Okay, that will be there. Yeah, आपकी पर 200 के ऊपर. Okay, it's not 200 पर, it is 200 के ऊपर. Okay, just remember. Yeah, good doctor, good spirit, Dr. 𝗓𝗔𝗃, and good doctor. Yeah, thank you Anirudh, I hope so. Yeah, fine, thank you. Then there will be this tendons you need to know. So you know this ulnar means what are the muscles are this on the medial aspect, it will be the ulnar. So see this one which is around this medial aspect, it is what it is, the flexor carpi ulnaris. So the tendon which is on this medial most aspect, it is what it is, this flexor carpi ulnaris. फिर उसके बाद since there is the superficial tendon, this is the superficial tendon. Okay, fine. So it is what it is, this flexor digitorum superficialis. We have two flexor tendons, flexor digitorum superficialis and flexor deep tendons, and this flexor digitorum superficialis will be seen superficially because it is superficial. फिर उसके बाद आगे बढ़ते हैं. As I told you then about this part which is this, which is causing the flexion around this radial joint. So it is what it is, this flexor carpi radialis tendon. So it is the tendon of this flexor carpi radialis. So remember this 3-1, flexor carpi ulnaris and flexor carpi radialis. Fine. Lady finger side ulnaris. Yeah, fine. Yeah, lady finger side are the medial aspect. Yeah, good to mnemonic, right? Or on the medial side, it is what it is, the ulnar. Fine. And next about this anatomical stomach box. You can, means there are two things you can do. You cannot forget your passport or your documents and you cannot enter the examinations, or else if you don't study the anatomical stuff box, or if you don't know, like it is not to enter the examinations, or like it is not a demotivating way. I will tell you, like this is that much important. I don't know why they are snuffing from the snuff box. They will ask this examination, these questions in most of these examinations or every alternate examination. So make sure you are doing this topic of anatomical snuff box for sure. Fine. The first one, there are two borders. One is this medial one and another one, it is the lateral one. See, if someone is medial to you, so there are two guys who are standing. There are three fellows who are standing. If you see Who is the strongest? If car come and hits, okay, if this is, imagine this is a car, if car come and hits, it will come and hit the lateral person, okay, if flight come and crashes, okay, it will come and hit the lateral person. So the medial person, it is always safe, so he will be always safe. So remember about this medial border, it will be having just one tendon, it will be having this one tendon, whereas this lateral, it will be having this two tendons, okay. So two tendons of extensor pollicis brevis and abductor pollicis longus, okay, extensor pollicis brevis and abductor pollicis brevis. In both of them, it will be having this extensor component. So remember, this is medial. So medial one is, as he is being protected. If you are having a single sister and two brothers, you will be always protecting, and you want to make her to live long. So remember, this extensor pollicis, it is the longest tendon. It is the longest because it is single, so you want to make them to live longer because of your protection. And you know, with protection, you will live longer. So remember, this medial aspect, it will be having this extensor pollicis longus, whereas this lateral aspect will be having this extensor pollicis brevis one, brevis, and this abductor pollicis longus, okay. If you know, well and good. Fine. Then they will ask you about this content. The content, it is what? It is the radial artery. And sometimes they will ask you, there is a patient who is presenting to you with following a push injury, or there is a injury which is happening in RTA. Then now patient is complaining of pain over this anatomical snuff box. Which of the following bone will be fractured? Yeah guys, which of the following bone will be fractured? Yeah, good Dr. 𝗏𝗏𝗀𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏 It is what? It is the scaphoid bone fracture. Scaphoid bone fracture. It is the scaphoid bone fracture, remember. Fine. Next about this question, they will ask you, yeah, good Dr. Muhammad Ali, yeah, good Dr. Rahul, Aishi, Gatu, Rohit, Anash, I love cricket, I do, Dr. Anirudh and Rituraj, yeah, good Dr. Rituraj. So it is what? It is the scaphoid bone. Next, if you see this next topic, it is also one of the most important one. Here you need to remember two things. One is what? This superior gluteal nerve. Superior, remember, superior gluteal nerve, it will supply gluteus medius and minimus. It will supply two muscles, which is this gluteus medius and gluteus minimus. Okay, it will supply gluteus medius and gluteus minimus, and both of them, they are what? They are the abductors of hip. Okay, both of them, they are the abductors of hip. So superior gluteal nerve, it will supply gluteus medius and gluteus minimus, and they are the abductors. And you remember this one slogan. Okay, one slogan: normal side think, normal side think, normal side thinks. Okay, normal side thinks. Okay, that's it. Okay, it is, if you know this two one, they will ask you the right side. If you see this is the normal one. If you see, the patient is sitting like me, so the patient's right is this, left is this. If you see the left side, the pelvis is dropping. Okay, if the patient's left side pelvis is dropping. Okay, so the normal one, it is the left side. So the damaged one, it is what? It is the right superior gluteal nerve damage. Okay, it is the right superior gluteal nerve. This that easy, because student, they will means like they'll make unnecessary confusion in it. Okay, remember, superior gluteal nerve supplies gluteus medius and minimus. They are the abductors and normal side sink. Okay, here the normal side is the left, so left side is sinking, so right side is affected, so right superior gluteal nerve is affected. Okay, that's it. Okay, that's it. Okay, yeah, Dr. SK, that is more than enough. Yeah, that is more than enough. Like, but you make sure you are doing question from it and you are doing these topics in depth. Okay, fine. Then about, sometimes they will give you this image and they will ask you, if you see, this is the gluteus maximus and this is the gluteus medius, and the small one, it is the gluteus minimus. Okay, just remember. And if there is any damage to this superior gluteal nerve, it will lead to this type of gait, which is known as Sunderland-Berg gait. And next image. Okay, and this image is being very less commonly tested in FMGE section, but it is very more prevalent, or more prevalent in 𝗵𝗵𝗀𝗀 aspect. But 𝗵𝗵𝗀𝗀 and FMGE, they are the brotherhoods, so they can ask the same in your FMGE examination as well. This one, Dr. Anand Mishra, like about this once more, like see, usually the hip will be having this abductors. So when you stand, the opposite side will tilt, or means when you stand, means the side will try to drop. So it will be it will be maintained by this opposite side abductors. This opposite side abductors, they will pull and they will make them into straight. Okay, but if this, imagine this is the same patient which is being standing here, the same patient which is being standing here. This when he's keeping the steps, okay, when he's tipping the steps, this left side is dropping. Now what need to be done? Then his right side abductor should work and this hip should not tilt, it should be in normal position. Okay, it should be in normal position, whereas here the abductors is not working, so this tilted hip, it is remaining as tilted. Okay, it is remained as tilted, whereas in normal situation it should come like this, whereas here it is tilted, so the normal side it is being dropped. Okay, this is the thing. Okay, so I guess this is the concept behind this Trendelenburg gate. I hope this thing solve your query. Like if you have more queries, just make sure you are asking in at the end of the session or between our breaks. Fine. Just a few more slides. Like then we'll have a chai break. Okay. Yeah. That's the thing, Dr. SK. So this session is for around 5 hours. Yeah, like there will be a breaks. There will be a chai break after anatomy, and there will be lunch break after our physiology. Okay, just remember. And like mostly we'll finish up around like 3, like before 3. If we take a long lunch break, then we'll finish around 4:30. Okay, that is our main motto. Okay, at the end of the day, it is not how long it is how long you are persisting and how long you are suffering and how long you will able to withstand this FMG preparation, and with this only you can able to clear this examination. That is the main motto of the session. Okay, it is more than enough, Dr. Novik Ghosh. Okay, if you read once, then you are doing this revision, it is more than enough. Okay, then we'll see about this phenomena. This first phenomena, it is not first phenomena, it is what it is, the olfactory nerve passage. It is this. Yeah, thank you, Dr. Gautam. So first one, it is this olfactory nerve passage. Then if you see, this is what? This is the optic canal. It is the optic canal which will give passage to this optic nerve. A good doctor. This is this optic nerve. And next, this is the most important part. Why it is most important? Because most of our extraocular muscles, nerve sensations will be carried through this. So it is what it is, this superior orbital fissure. This is superior orbital fissure. We know this extraocular muscles, it will be supplied by this 3. Okay, it will be supplied by this 3rd cranial nerve, then 4th cranial nerve, and the 6th cranial nerve. Okay, fine. It is 3, 4, and 6. And this nerve sensations, this ophthalmic branch of this trigeminal nerve. Okay, V1 will be passing through this superior orbital fissure. Okay, and next about this 3 phenomena which is in an arc fissure. Okay, like an arc, you know, like this arc. Okay, like this arc, like remember it is ROS, rose. Okay, rose to yaad hoga na? Yeah, rose. So it is what it is, this foramen rotundum, oval, and spinosum. Okay, and if you see, first we saw this first branch of this trigeminal nerve, it is being passed through this superior orbital fissure. Rotundum, it will give rise to this second part of the trigeminal nerve, which is this V2, and oval will give rise to this or give passage to this third part of the trigeminal nerve. Okay, which is this mandibular branch. Next about the spinosum. The spinosum, it is very important. Okay, they will give you this image of an extradural hemorrhage or an epidural hemorrhage, and they will ask you which of this following artery is responsible for this. Then your answer should be medial meningeal artery. Now they will ask you in which of the following foraminal trauma this artery may get ruptured. So remember this foraminal spinosum, it will give rise to this middle meningeal artery. So if there is any damage to this foraminal spinosum, then there will be damage to this middle meningeal artery, and there will be damage and causing this epidural hemorrhage. Okay, yeah, good Dr. Anju, good Dr. Anirudh. Yeah, you are in pace. Good. Yeah, sure, Dr. Muhammad Ali. I told you about this PDF. Don't have any doubt about this thing. I will share you this PDF. That is my responsibility. Okay. Next about this structure which is known as foramen of Lacerum. Okay. Sorry, this spine of some is marked here. Oval and spinosum. This is the spinosum, which have this medial meningeal artery. Okay. And next, if you see, This is this internal acoustic canal, and we know this internal acoustic canal which will give rise to this or give passage to the 7th and 8th cranial nerve. And next one, which is this jugular foramen, and here you will be able to see a canal which is known as what? Hypoglossal canal. And this is our main foramen, which is what? Which is this? What is the name of this foramen, guys? The big foramen. Yeah, good, Dr. Anirudh. Yeah, guys, it is what it is, the foramen of magnum. It is the magnum, the biggest one. Yeah, good, Dr. Shanavas, Rituraj, Shefali, Kishai, Novik, Anand. Yeah, good, that absolutely awesome. Fine. So these are this foramina. We know this jugular foramen, it will give passage to this glossopharyngeal nerve, 9th and 10th, and some part of accessory. And we know there are two parts of accessory nerve. One is this cranial and this spinal part. The spinal part will be passing through this foramen of magnum. Okay, spinal accessory nerve. Spinal accessory nerve. Yeah, good, Dr. Anirudh. Next, this axial CT sections, they are being asked in recent years. If you see, mostly they will roam around few asked topics. So if you see this one, this is a T2 weighted MRI. It is a T2 weighted MRI because you will be able to see this water is white on MRI. Fine. And here you will be able to see these are this ventricles. These are the ventricles. Okay. This is the lateral ventricle, especially this is the lateral ventricles. Okay. And next, as I told, this is this lateral ventricles, frontal horn of the lateral ventricles. Fine. And next, if you see around the lateral ventricles, you will be able to see this nucleus. Okay, this nucleus. It is what it is, the caudate nucleus. Okay. And in medicine, they will ask you questions. A patient is presenting with this coriform movement. Which of the following nucleus will be damaged? So in this, if there is any damage to this caudate nucleus, it will lead to the formation of chorea. A good Dr. Amils or good Dr. Anirudh. Fine. And next, if you are able to see this structure, which is lens shaped, this lens shaped one. Okay, lens shaped one. This is what it is, the lentiform nucleus. Okay, and we know this lentiform nucleus will be having these two components, which is this globus pallidus and the foramen. Okay, foramen. Yeah, good, Dr. Koinian, Anirudh, Shanvas Khan. Yeah, well, yeah, really well. Fine. Next, if you're able to see this one, means if you able to this block one, right? Fine. I guess you will be able to see this one, like this black one. This black one, right? This is what this is, this internal capsule. So this is the internal capsule. There are this internal capsule. There will be two limbs, this anterior limb and a posterior limb. So this is the anterior limb of internal capsule and this is the posterior limb of this internal capsule. Fine. And about this, around this third ventricle, you will be able to see one more nucleus, which is known as what? It is the thalamus. So remember, T for thalamus. Thalamus at the level of third ventricle. At the level of third ventricle. Okay. Yeah, good, Dr. Ansh Sartaj. Yeah, well played. Fine. Next, about this ventricles. So remember, we know the CSF will be formed from this lateral ventricle. So with the help of this lateral ventricles, then it will come down. How it will come down? By this foramen of Monroe. Okay. Or this, then followed by this, it will come to this third ventricle. Yeah, it will be produced from this choroid plexus of this lateral ventricle, then followed by this cerebral aqueduct, and followed by the it will pass to this ventricle, which is this fourth ventricle. Once it's get into the fourth ventricle, then it will give passage or it will pass into this subarachnoid space. There are two foramens. Okay, what are the two foramens, guys? The medial one and the lateral one. Medial one and the lateral one. So the lateral one, it is known as foramen of Luschka. Lateral for Luschka. And the medial one, it is known as foramen of Magendie. Okay, it is known as foramen of Magendie. It is known as foramen of Magendie. Okay, and it will pass into this subarachnoid space or the spinal space. Okay. I guess, yeah, good Dr. Amal, good Dr. Rohit, good Dr. Anand. Yeah, you are getting it correct. Fine. And these are the things you need to remember. And if there is any damage to any part, it will lead to this formation of hydrocephalus, fine. And next about the stomach blood supply, mostly they will ask you about the celiac plexus. Okay, the celiac plexus, remember the celiac plexus, they will be divided at the level of T12, and the celiac plexus, it will be having these three artery branches. One is this direct left gastric artery, and next one it is this splenic artery, and one the common hepatic artery, fine. And remember about, like mostly remember about this splenic artery. The splenic artery give two arterial branches. One is this short gastric artery, and this, remember, it is the left. We know the spleen is on which side? The spleen is on the left side, so it will give rise to this left gastro-epiploic artery. Okay. Yeah, good, Dr. Anar. Okay. Right. Then about this right side, this common hepatic artery. This common hepatic artery will give rise to this proper hepatic and the gastroduodenal artery. Previously, this right gastric artery. So I have given this image because so that you won't confuse in the examination. So previously it was a part of common hepatic artery, but now this proper hepatic artery give rise to the branch of right gastric artery. So remember, this left gastric artery, it is a direct branch of celiac plexus, whereas this right gastric artery, it is a branch of proper hepatic artery. Okay, and this short gastric arteries and this left gastroepiploic artery, these are the branches of this splenic artery, whereas this right gastroepiploic artery, it is a branch of this pancreatoduodenal artery. It is a branch of this pancreaticoduodenal artery. Yeah, good Dr. Anar, good Dr. Rohit, good Dr. Anirudh. So they will ask you this question, and you should not make mistake in it, because I have repeated this so much times, so don't make mistake, right? And about this muscles of mastication, as I told you, these muscles of mastications, they are derived from this first pharyngeal arch. Okay, and these muscles include this temporalis muscle, this masseter muscles, and two pterygoids, this lateral pterygoid and the medial pterygoid. This lateral pterygoid and the medial pterygoid. Fine. These are the muscles of this mastication, and the nerve supply of this muscles, it is what? We know this first pharyngeal arch, it will be supplied by which nerve? Yeah, guys? It is the fifth cranial nerve. It is the fifth cranial nerve. Okay. What is the mandibular nerve? Mandibular part of the trigeminal nerve. Next one, it is derived from the first pharyngeal arch. It is derived from the first pharyngeal arch. And about the tongue, in tongue, you need to know about this nerve supply. The nerve supply, you just remember the same, like here 5, 9, 10. Here 9 and 10, it will remain constant. For general sensation itself and taste sensations, both of them, it will be carried by this 9th and 10th on this posterior aspect and the posterior 1/3 of the tongue. Okay, yeah, good Dr. Mohammed Anash. Right. Whereas this taste sensations, okay, the taste sensations, it will be carried by this facial nerve, which is part which is known as 𝗏𝗏 tympani nerve. Whereas this general sensation, it will be carried by this lingual nerve. Okay, lingual nerve, which is a part of this trigeminal nerve, it will carry this general sensation. So remember, for general sensation, it is what? It is the 5, 9, 10. Whereas for special sensation, it is the 7, 9, 10. It is the 7, 9, 10. Remember. And okay, and so they will mark you this anterior 1/3 of this tongue, and they will ask you which of the following carries the general sensations. Can you answer in the comment section? Yeah, sure, doctor. I will try to write whatever I say. I do say. Fine. Yeah, I'll try to write it. Okay. So this anterior part, yeah, if there is general sensation, it will be carried by this fifth cranial nerve. Whereas the special sensations, it will be carried by this 𝗏𝗏 tympani. Fine. Then this glossopharyngeal nerve, it will supply this posterior 1/3 for this both taste sensation and the general sensation. Good Dr. Aishi, good Dr. Shanwas Khan. Fine. Then about this posterior most, it will be supplied by this both 10th cranial nerve. Fine. And about these muscles, you need to, if you can, just remember about these intrinsic muscles, which include this 4 pairs. The superior longitudinal, inferior longitudinal, transverse muscles, and the vertical muscles. If you unable to remember, just remember about this extrinsic muscles. And this extrinsic muscles itself, you need to remember about this fan-shaped muscle. It is what? It is the genioglossus. This genioglossus, it is what? It is this fan-shaped muscle. It will be supplied by this 12th cranial nerve. Okay, remember. Okay, and there is 2 more muscles, this styloglossus and palatoglossus and hyoglossus. Okay. The papillae, it's mainly for the differentiation, guys, right? And next about this esophageal constriction levels. This will be asked in both anatomy and as well the surgical perspective. They will ask you the question. Now, you are planning to do an endoscopy to your patients. Now, you started doing endoscopy. Now, you are feeling a constriction, or this endoscopy is facing some kind of resistance while passing it. And this resistance happens at a level of 25 centimeter from the incisor tooth. So, this will be mentioned at this one. And they will ask you which of the following constriction or which of the following structure will be responsible for this difficulty in passage, or which are this difficulty. Okay, they will ask you this question. So if you see, if there is resistance at the level of 25, it is mainly because of this arch of aorta. So this esophagus will be having this different constriction. The first constriction is at the level of 15 centimeter from this incisor tooth. It is because of this trachopharynx. Yeah, good Dr. Anash, good Dr. Gatu Kritika, okay, good Dr. 𝗵𝗵𝗀𝗀𝗀𝗀 and Anju, fine, yeah, good, fine. And means around the level of 25 centimeter, there will be two ones. Like first one, it is the arch of aorta, which is on the left side. And remember, as arch of aorta is also on the left side, remember there is this left principal bronchus. It is the left main bronchus or this left principal bronchus which is causing this constriction around the level of 25, but sometimes we refer it as 28 centimeter. Okay. And finally, the third constriction, when it enters the diaphragm, it is at the level of 40 centimeter. It is at the level of 14 centimeter, 40 centimeter. Yeah, good guys. Yeah, good Dr. Anar and prototype. Yeah, good Dr. 𝗵𝗶𝗀𝗀𝗀𝗀. Fine. And in few examinations from anatomy perspective, they will give this image and which of the following will cause this constriction. Okay, we know this arch of aorta. First one at 25 centimeter, and this left main bronchus at the level of 28 centimeter, and there is one more indentation. You know the posterior most chamber of the heart. It is which chamber? Yeah, guys, waiting for your answers. Which one you want to repeat, Dr. Ambika? If you see, there are four constrictions. Cricopharynx at the level of 15 centimeter. If they are telling that while passing the endoscope at 15 centimeter having resistance, it is because of this cricopharynx. And followed by this, there is this arch of aorta at 25 centimeter, and followed by this left main bronchus at 28 centimeter, and followed by this at the diaphragm at the level of 40 centimeter. This is one. Okay. Yeah, distance counted from incisor tooth. Yeah, correct. Yeah. Remember, yeah, don't confusion. Yeah, it is what it is not right. It is what it is, the left atrium. So see, the left atrium, it is the posterior most chamber. So if there is any changes into this left atrium or left atrial hypertrophy, it will cause indentation to the esophagus. So this indentation, which is pathological, it is due to the left atrial hypertrophy. Okay, remember. Fine. And next about this opening of the diaphragm. Okay, we have 3 more slides left in anatomy. Then after that we'll have a short break. Fine. See, about this openings of the diaphragm, there is this central tendon opening which is at the level of T8. So which opening is this, guys? That is what it is, the vena cava opening. Vena cava opening at level of T10. It is what it is, the esophagus opening. And at the level of T12, it is the aorta opening. Aorta opening. Yeah, good. Yeah, you can remember this by a mnemonic which is known as voice of America. Okay, voice of America. Fine. And this is the, if there is an opening at the level of central tendon of the diaphragm, it is what it is, the vena cava, and followed by which you will having this muscular opening which is by or for this esophagus, and finally this aorta which is adjacent to the opening around this vertebra. So it is the opening of this aorta. Okay. Yeah, good Dr. 𝗪𝗀, Gatu, Mohammed Anash, Anar and Rahul Singh. Yeah, good. Fine. Then we'll see about what are the structures which are passing. We know obviously if there is vena cava opening, vena cava will pass. But they will ask you what are the other structure which will be passing through this vena cava opening. So you can remember by this mnemonic of RIP. Okay, it is what it is, the right phrenic nerve and this inferior vena cava. Right phrenic nerve and this inferior vena cava. It will be passed through this vena cava opening. Whereas this esophageal opening, in the esophageal opening, remember esophagus and vagus. So esophagus and vagus, ये दोनों T10 पे पास होता है. So remember this esophageal opening at the level of T10, and it will give passage to this esophagus and vagus. Yeah, good Dr. Pratap, Anuch, correct. Fine. And about this aortic opening, remember aorta, aorta. Okay, aorta, aorta. Okay, so aorta will pass through this, will give passes through these three structures, which is this aorta, and then this thoracic duct, and this azygous vein, azygous vein. Okay, so aorta, thoracic duct, and the azygous vein. Fine. Yeah, good, Dr. Rohit. Good, Dr. 𝗃𝗀𝗀𝗀𝗀. Okay, fine. With this understanding, we'll move on to this TS of this thorax and the abdomen. Like mostly they will ask about this cadaveric images, so make sure you are seeing this image before going to your examination part. So most of our subjects, it will be consisting of only 20 to 21 pages. Okay, and if you read this 21 pages before your examination, it is the high yield point and it is the high yield revision that you can have for your FMGE examination. Right? As I told you, the most anterior most chamber, it is what? It is the right ventricle. Whereas this most posterior most chamber, it is the left atrium. So the most posterior most, it is the left atrium, whereas the anterior most, it is the right ventricle. Right? It is the right ventricle. So they will ask you these two questions. If there is any changes in the left atrium, which is the posterior most chamber, it will cause changes over the esophagus. Whereas if there is any right ventricular hypertrophy, or if there is any bullet injury on the anterior aspect, the first thing which will be damaging it is the right ventricle. Okay. Yeah, base forms the left atrium. Yeah, good guys. Good, Dr. Anna. Then if you're able to see these structures, the structure which is being adjacent to this vertebra, it is what? It is this aorta. Is it ascending aorta or descending aorta? So see guys, this ascending aorta, it is ascending from the heart, so it will ascend very less and it will form the arch and it will descend down adjacent to the vertebra. So the artery which is adjacent to the vertebra, it is what? It is the descending aorta. It is the descending aorta. Yeah, good, Nash, Gatu, Rohit. Just I guess you have a bit confusion. Okay, see Dr. Anju, Novik, Quenin. So you are getting it correct. So remember, the aorta which is adjacent to the vertebra, it is what? It is the descending aorta. Okay, fine. Whereas ascending aorta, it is a very small point. Okay, now that is the random question. At which level or at which level from the incisor this aortic arch happens? Yeah guys, or which centimeter? PDF मिल जाएगा कंद्रेश, चिंता मत करो. Yeah, good, Dr. Anju. It is what? It is from the 25 centimeter from the incisors. There is this presence of this constriction because of this arch of aorta. Yeah, good, Dr. Amal. Wow, बढ़िया, बहुत बढ़िया. Okay, then see, these are this pulmonary arteries, two pulmonary arteries. Okay, these are the two pulmonary arteries. Okay, listen. And about this thorax and abdomen one, this is the thorax one. And about this abdomen one, if you see, this is the air-filled stomach, and this is our gallbladder, and this is our liver. Fine. And this is our duodenum part. And next, if you see this muscular structure, it is what? It is the inferior vena cava. And as I told you, the structure which is adjacent to the vertebra, it is what? It is the aorta. It is the aorta. Okay. And this one, which is on the left side, it is what? It is the splenic tissue. Okay, good guys. So just see this image before going to your examination part. And this is, sometimes they give you this CT image and they will ask you A, B, C, D, like that. Okay, so see, this is this liver part, and below this liver, this is the gallbladder, and this is the vertebra. And as I told you, adjacent to the vertebra, it is what? It is the aorta. Next, this is the pancreas part, and next, these are the two kidneys, and on the left side you will be able to see this small structure which is the spleen. Okay, and this is the pancreas part, as I told you, and the air-filled structure which is what? Which is this stomach. Right? Good guys. Then about this femoral triangle, you need to know about this arrangement. This arrangement is naval arrangement. There will be this lymph node around here. Okay, there will be one lymph node around here. Okay, so this is this nerve, artery and vein arrangement. And just see, this medial border, it is formed by this adductor longus, and the lateral border, it will be formed by this sartorius. So medial border, it will be formed by this adductor longus, and the lateral border, it will be by this sartorius. And remember one more thing, both of this sartorius and adductor longus, both of their medial border will form their medial and lateral border. So let me clarify you. So the medial border of the femoral triangle, it will be formed by the medial border of adductor longus, whereas this is the lateral border. Okay, lateral border. Okay, whereas this will be formed by this medial border of. So there is a point of confusion. See, there is a muscle. Okay, if you see, this is the medial, this is one muscle, it will be having the two structures. This is the medial part of a muscle, this is the lateral part of the muscle. So see here, the medial part of the muscle, it will be forming the lateral border. Okay, this medial part will be forming the lateral border. Just have this in mind. Okay, and we'll move on to this larynx anatomy part. You know, this leaf-shaped cartilage, it is what it is, the epiglottis, and we know all of the following cartilages, they can undergo calcification, but except epiglottis. Okay, except epiglottis, it won't undergo calcification. There are these unpaired cartilages like this thyroid and cricoid cartilages and this epiglottis, whereas rest small cartilages and arytenoid, corniculate, cuneiforms, all of them they are paired cartilages. Fine. And one more question I want to ask you. This is this thyrohyoid membrane. Between this thyroid cartilage and this hyoid bone, there is this membrane which is known as thyrohyoid membrane, and one nerve which goes passing through this membrane, which is this internal branch of laryngeal nerve. So internal branch of laryngeal nerve will be passing through this thyrohyoid membrane. And one more condition which occurs in this trump blowers. In a case of trump blowers, you will be able to see swelling over here, and the swelling, it is what it is, the which condition, guys? It is the laryngocele. It is a laryngocele, and this laryngocele even it will pass through this thyrohyoid membrane. Okay, and this laryngocele will mostly occurs in a trumpet blowers or who are putting pressure on their mouth. Okay, so this will be what this is, the laryngocele. Yeah, good Dr. Prototype, good Dr. Rohit, and good Dr. Anju. Okay, and we know there is a sign which is known as laryngocele which produces this sign. It is known as Bryce sign. Okay, you know it is air filled structure. So once you press it, this air will come out. So it is known as Bryce sign. Okay, yeah, good Dr. Rahul, good Dr. Shanvas Khan. Yeah, good, fine. Then about a few important points. Okay, few important points about this vocal cords. If you see, there are many adductors. So many adductors. Okay, but only one abductor. So the adductors include lateral cricothyroid, interarytenoid, thyroarytenoid. Okay, whereas this only one abductor, it is what it is, the posterior cricoarytenoid. Posterior cricoarytenoid. Okay, posterior cricoarytenoid. Just remember this only one abductor. It is what it is, the posterior cricoarytenoid. Okay, posterior cricoarytenoid. Just remember. Next about the tensors. Now in NEET PG examination they asked you, there is a patient who is presenting with loss of pitch. Okay, there is a loss of pitch, and on evaluation you will be able to see bowing of this vocal cord. Bowing of the vocal cord. Okay, yeah, good Dr. Diana Murugesan. Yeah, you will be able to see it. Yeah, good Dr. Anand Sharma. Yeah, so if you are able to see, there is this bowing of this vocal cord. This too will be because of the damage to this muscle, which is this cricothyroid muscles, which is this cricothyroid muscle. Just remember one thing, they will give this, there is a patient who is presented with features of loss of pitch, and on evaluation you will be able to see there is a bowing of this vocal cord, and in which of the muscles will be damaged in this condition. It is what is the cricothyroid muscle. Fine. And about this type of cartilages, they will give this image and they will ask you, if you see this fibrocartilages, they are what? They are very regular, means they are arranged in a single line because they have this lot of restrictions. They have this lot of restrictions because of this fiber. So it is what it is, this fibers present, then it is fibrous cartilage. But you see, there is this fibers, but they are elastic. Okay, they are elastic fibers. Okay, if you see this kind of elastic fibers, it is what it is, the elastic cartilage. Whereas there is no fibers, it is clear, there is no fibers. Okay, they will trust you with the clear heart. So it is what it is, this hyaline cartilage. Hyaline cartilage. Okay, see most of them, this fibrocartilage, they are single. So single. Here also they are single. Whereas if you see this hyaline cartilage, it is mingled or it is in pairs because they have this trust, they have this transparency. There is no elasticity, there is no fibers. So this is transparent. That is what this is, hyaline cartilage. That's why they are paired. They are transparent in their heart. Just remember. Next about, we saw this cleft lip. If there is any unilateral cleft lip, it is due to the non-fusion of this medial. Remember, it is the medial nasal process and this maxillary process. Because of this non-fusion of this medial nasal process and this adjacent maxillary process. Right? And finally, this final slide for the day, means like not for the day, for anatomy. So if you see this palpation of these arteries, if you see around this medial, about this medial malleolus, it is what it is, this posterior tibial artery palpation, and around this base of this first one, around this base of this first metatarsal, it is what it is, this dorsalis pedis artery, and behind this knee, it is what it is, this popliteal artery. Behind this one, it is the popliteal artery. So these are the few arteries you should remember. So
other arteries you know, right? This is the radial artery. If they're palpating here, it is the radial artery. And if they're palpating near this thyroid cartilage, if they are palpating near it, is what it is the carotid. And if they're keeping hand near to the femoral region and they're palpating, it is the femoral artery palpation. Fine. And this about this one, which syndrome, which is this hemisection of this spinal cord. And the hemisection of the spinal cord, it is also known as Brown-Séquard syndrome. Brown-Séquard syndrome. And in Brown-Séquard syndrome, you remember only one thing. Okay, only one thing. Okay, there is this ipsilateral pain and temperature. There is the loss of ipsilateral pain and temperature. Okay, don't remember multiple things and forget the necessary things. Okay, make sure you are remembering the important things. So in the case of Brown-Séquard syndrome, remember there is this ipsilateral pain and temperature deficits, whereas on the opposite side there will be what? There will be the motor movements and the vibration. Okay, the everything. Okay, sorry, I made it wrong. So sorry. Remember this contralateral one. So this pain and temperature, it will be on the contralateral sides. Okay, sorry from my end. So pain and temperature, it will be on the contralateral. So remember this pain and temperature contralateral, pain and temperature contralateral, pain and temperature contralateral seen in a case of Brown-Séquard syndrome. Okay, okay, it is mostly that is below the level. Mostly they won't ask you about at the level. Mostly they will ask you about the below the level. Okay, so pain and temperature loss at the contralateral. If it is on the right side, it will be on the left side. Right? Then there will be motor and vibrations, it will be on the same side, right? So see here this side there is this transaction, and on same side you will able to see there is this fine touch and vibration, and along with this motor functions which is being damaged, whereas on the opposite side you will able to see there is a damage and which will lead to this pain and temperature sensations, because we know there is thing which is known as decussation. Okay, बस इतना याद रखो Brown-Séquard syndrome के लिए, और वो पूछेंगे. Okay, and you should be ready to answer it. And about this auscultatory points, just remember by this alphabetic order. AP, first one. If you see on this right side, like whatever we want, we start on the right side, right? So on the second intercostal space on the right side, you will able to see or hear the auscultation for this aortic valve. Fine. Whereas on the left side, it is for the P. So remember A, P. Okay, AP. Okay, so P for the pulmonary on the second intercostal space. Right? Whereas for this tricuspid valve, it is the fourth intercostal space around the parasternal, which is what it's adjacent to the sternum. It is the parasternal line, and around this midline, around this mid clavicular line, on this here you will be able to see this mitral valve. Okay, around this mid clavicular line, you will be able to see this mitral valve, and between this second and this fourth, there is this third intercostal space which is known as what? Which is known as Earth's point, where you can hear this S1 and S2 simultaneously. Okay. Yeah, there is good mnemonic, Dr. Shanwas Khan. All physicians work money. Okay. Remember, it will go here, it will go alphabetically, it is A and P, followed by this tricuspid valve and followed by this mitral valve. So remember this sequence, and they will ask you which of, they will mark and they will ask you which of the valve will be heard at this position. Okay, so all of this thing about this anatomy part, and we'll have a short break for 20 minutes. Okay, we'll have a short break for 20 minutes, and the time is 11:53. Okay, it is, we consider 12 12, so will join us around 12:15 p.m. Okay, around 12:15 will join. Then our physiology part, physiology will be very less, and we'll able to complete it in an hour. Okay, after that we'll have a big lunch break. Fine, and after that we'll conclude with biochemistry. If you have any doubts, you put up in the chat section. I will have a chai and I will see your chats, and whatever your questions you have, I will answer you after the sessions or once the sessions resumes. Okay, our session resumes at 12:15. Okay, and just a small motivation to you. I know it is a bit difficult at this moment because you read everything and things looks like you are forgetting everything, but don't worry. Whatever you read, it won't go into the air. It will get into your subconscious mind. Okay, और होगा, सब कुछ होगा, time पे होगा, बस आपको मेहनत करते रहना है. Everything will happen on time. You should keep on motivated and you should keep on doing things and you should be consistent. If you have all these three qualities, you will be able to clear this examination with flying colors. Okay, that's it guys. We'll meet up around 12:15 p.m. and we'll catch up. Okay, if you have any doubts, please put up in the chat box and I'll love to hear you. Fine. Thank you guys. Ready. Hello doctors, welcome back to the session. Like, I hope I'm audible. Hey guys, am I audible? Could you please reply in the chat section? Yeah, about your doubts, like this session, and if you attend all of this PVQ part, then you will be able to score at least a mark of 150. That is the assurance. But make sure you are solving these questions along with the session, and you are revised with it. Okay, if you revise this, and if you solve questions, and if you know like how to solve the MCQs along with this session, then it is more than enough to get this 150 score. Thank you, Gautam. Thank you, Gunan, Preeti, and Raja, Muhammad, and Dr. Ajay Soni, Dr. Mohammad Anash, prototype 5S Kanra. Thank you for your confirmation, guys. Like, we'll move ahead with our session, and let me tell you how this session progresses. As I told you, this session, it is consisting of 5 days, and first day, it's today. It will be having this anatomy, physiology, and biochemistry. And we have our other sessions which are being scheduled in the upcoming days. For example, this is our first day one. Then we have other next subjects, which is from this patho, micro, and pharma, which is scheduled tomorrow. And likewise, we have for 5 days schedule. Next, we have our subjects of FMT, ENT, PSM, and ophthalmology. Then our important medicine, surgery, and obstetrics and gynecology. Then all of our short subjects in the final day. So if you read this all 19 subjects, and if you follow up with this schedule, then you can able to clear this examination with flying colors. Okay, that is your assumption. Okay? I guess there is no lagging, like, because I'm able to see the other screen with well and good clarity. If you have any lagging, kindly make sure you are in line, and make sure you are connected to a proper internet. Okay, if you have done these 2 things, I hope it won't be any lag. Okay, I guess it's not lagging, right? Can you please reply in the chat section, guys? Thank you, Dr. Sadaf Khan. Dilip Joshi lagging. What is the lag? Can you check? Is there any lag? In between, and some sound issues. Like, sound is fine, right? Yeah, fine. Yeah, sorry guys, like there might be small glitches. I hope I confirmed with my team, like they told there is no or less problems with our end. So hopefully we won't have any problems in our future sessions as well. Okay, if you have any problems or if you have any something, just make sure to check your internet connection before like while joining the session, and make sure you are in the live. Okay, if you watch this session with bit past, it will be bit late to you. So just do these 2 things, and sometimes there will be a lag based on your end and our end, and we are making sure from our end there will be no lag. Okay, that is our promise. Fine. Some sound issues. Is there any? The sound quality is good. Yeah, I guess the sound quality is good, guys. Like, okay, fine. With this, all these things, we'll move ahead with this game changer session, physiology part. Fine. In physiology, what do you know? In physiology, there will be questions from 8 to 10 questions. Okay, if you read physiology, well and good. If not, just try to watch the videos of rapid revision and watch this must-know topics and read this must-know topics for one more time and put up the PVQs. That is more than enough for physiology, right? And first, we'll see about this receptors. We see about this receptors and transport mechanisms. The main focus is on this transport mechanisms. There are different types of transport. One of them is what it is this active transport. It is what it is this active. Just a second. Sound is coming. No, wait. Just a second. Just sound थोड़ा late आ रहा है. उसको एक बार देखो. Like sorry guys. Just let me check it once. लाइक मैं जो बोल रहा हूँ और उसका जो साउंड आ रहा है उसका थोड़ा लैग हो रहा है. आप एक बार चेक करो. इस बोथ आर इन सिंक. Yeah guys, we got the issue. We are just trying to rectify it. Just be patient and be with us, right? I hope you understand. अभी ठीक है? ठीक है. Hello, check. Live. Yeah, fine. Hello guys, I guess we are back. Can you please confirm me whether the audio and video are being synchronized? And thank you ODC Sync for your kind thing. Okay, fine. Like we restarted the system and I guess things are well now. Yeah, sure, Dr. 𝗬𝗵𝗶𝘀, that's we told, like the PDF isn't an issue. I will share you the pre-annotated PDF mostly before the session as possible, and once the session ends, I'll share you back. Okay, there is no any like I won't keep it with me. I will share, and that's our motto. Fine. Still delay, sir? Still lagging? Can you please confirm about the lag?
Hello, check. Hello. Hello, check. Hello. Is there any lag? Welcome back. I guess there is no lag, right? Wait, yeah. Yeah, thank you. Now good. Yeah, fine. Yeah, that's what we need. Like in sometimes or in some part of life, we should be patient and we should let it go the way as it goes. And because there will be some unfortunate situations and there will be some troubles before something good happens. So don't worry if something is happening or some lag is there. Like just it meant for you. Just you need some break for it. So that's why you got the break. Okay. Yeah. That's it, guys. With the same motivation, I guess we are back again. And with this, we'll start with the physiology part. And exactly, it will take around an hour or around 45 to an hour. Like it's based on your interest. If you're interested more, we'll cover up with more enthusiasm and we'll include more important things as well. Okay. And we'll have this break around 1:15 or 1:30. That is our mean time. Okay. Or 1:40. It's the max. Okay. Yeah, if you ask me, is this enough? Like if you read physio once and if you did PVQ, then if you read this, then that is enough. Okay. If you ask me whether things are enough, nothing is enough in this world except the food you get. Okay. So this is enough to score 150. Okay. In physio, there will be around 8 to 10 questions, out of which 5 to 8 questions will be from this period. Okay. That is my. Fine, guys, we'll move ahead with the physiology part. In physiology part, we need to see the first one, which is this intracellular receptors and its transport mechanisms. The main one, it is the transport mechanism. If you see about this receptors and transport mechanism, first about this transport mechanism, if you see, there are different types of transports. One is this active transport, another one is the passive transport. What does this active transport looks like? Yeah, thank you, Dr. Harsh. Fine. Thank you, Dr. Anand. Okay, fine. Like whatever PVQs you want to do, just do for 5 years either FMG. First complete FMG. Okay, don't go to the other plate before completing your plate. Okay, so just complete FMG PVQs of 5 years before jumping into 𝗏𝗏𝗏𝗏, because you know FMG is being conducted twice a year and it has questions of 300. So 300 for 2 sessions it is 600 per year, and for 5 years it is how much? 3000 FMGE questions and 3000 FMGE topics. Okay, that is how more it is. Okay, so just do your FMG PVQs at least 2 days, and once you are done with it, once you know things better, then move ahead with 𝗏𝗏𝗏𝗏 part. Okay, that is my point of correlation, and it is how I will approach if I am writing this attempt. Okay, as I have been done with my FMG, so I cannot mince. So I can guide you with the same thing, like just do FMG PVQs, then move ahead with 𝗏𝗏𝗏𝗏 part. Fine. Next. yeah, we'll move ahead with the topic part. First one, it is the active. So remember, A for active, it is against the concentrated gradient. So it is the low to the highest, like it is the flow from the low to the highest point of gradient. And remember, A for A, it is what? It uses energy in the form of ATP. So it uses energy. It uses the energy. So this is this active transport. And there are different types of active transport. They might use energy, either they may use or their friend may use. For example, in a case of primary active transport, the channel itself or the pump itself uses energy. For example, our hydrogen, potassium, ATPase pump. It uses direct energy or it uses direct ATP and do its work. So it is the primary active transport. And the next one, it is the secondary active transport. Means your friend will eat but you will grow. Okay, this is how it is. Right? This is how it is. So first, secondary active transport, it will be coupled pumps. For example, in a case of like sodium amino acids import or any other import which is having sodium in link, and other SGLTs, like for example sodium glutamate transporters for glucose, like sodium related glucose transporters. Fine. So these are all the secondary active transport. So they use ATP but not directly. They will utilize the work from the ATP one. Okay. Yeah, I guess things are well. Yeah, good Dr. Gautam and good Dr. Shanavas Khan. And yeah, that's it. I guess Dr. Anand. Fine.
Okay guys, next about diffusion part. Like there are few transport mechanism. One is this diffusion. If you see this diffusion, there will be the simple diffusion. You know, this alveoli. Alveoli are lined by which of the following type of epithelium? Can you tell the answer in the chat box? Alveolar are lined by which type of epithelium, guys? Alveolar, they are lined by the simple squamous epithelium. Alveoli, it has this simple squamous epithelium. That's we studied in this one. Yeah, good, Dr. Gautam, Dr. Rituraj, Dr. Muhammad Anash. Yeah, good. That well said. Good, Dr. Anju. Good, Dr. Trisha. Yeah, good, Dr. Rohit also. Fine. This is the simple squamous epithelium, and we know the gaseous exchange in the case of lungs, it will takes place in the alveoli. So there is a simple diffusion. So this oxygen and CO2 diffusion in the lungs, it will be what? It will be the simple diffusion. Whereas in the case of facilitated diffusion, means you need a carrier, means you cannot just go simple. You need a carrier, you need a transport mechanism, you need a metro train, you need a bus to transport this thing. So it is what it is the glut. Okay, it is what it is the glut transporters. Okay, and we know like if it is diffusing, if you are going randomly, you can go. Whereas we know there is a metro capacity and we know the capacity of a bus. So we know this facilitated transport or this facilitated diffusion will be having a transport maximum. So remember, it will be having a transport mechanism. For example, if it is a small box, it can accommodate only 25 people. 50 people cannot sit. Okay, okay, so that is known as what? That is known as transport maximum in a case of facilitated diffusion. Okay. Then about this glut, you need to know this glut where it is present. First, you need to know it is glut1. It is the 1, remember. Okay, it is present in most of the cells and it is helpful for this basal uptake. So the basal uptake, it will be done by the glut1. Okay, glut1, it will be for the basal uptake. Whereas in glut2, remember that is 2. That is the second alphabet. It is the beta cells of pancreas. It is the beta cells of pancreas. Yeah, good, Dr. Prajapati. Yeah. So it is the beta cells of the pancreas which has this glut2. We know when there is increased glucose, the insulin will be released, and the increased glucose will be sensed by these glut2 channels, and this causes the release of insulin, and these are present in this pancreas beta cell. Okay, and next one, it is the glut3, which is the neurons which is having this highest affinity. Okay, it has the high affinity for glucose, and you remember this first 3 or not, but you should remember this glut4. If you see this glut4, okay, this glut4, it is what? It is insulin dependent. If there is presence of insulin, then only this glut4 will work. Okay, if there is no insulin, there is no ID card, this glut4 won't work. So it is what? It is this insulin dependent glut transporter. It's what? It is the insulin dependent glut transporter, and this will be present in this skeletal muscle, cardiac muscle, and the adipose tissues. Skeletal muscle, cardiac muscle, and the adipose tissues. Fine. And the fifth one, glut5, it will be present in the sperms, which is especially for this fructose transport, that is fructose uptake. And we know the sperms, they need to motile, right? They should be motile. And for motility of the sperms, it needs some energy. It will get from the fructose. So this sperms, it will use this glut5 to get the fructose. And in intestine as well, so we'll use glut5 to get the fructose. Fine. And about this SGLT, as I told you, we already discussed SGLT. They are what? They are this secondary active transporters. Secondary active transporters. And this SGLT are different types. We need to know just SGLT1 and SGLT2. Remember, we have only one gut. Means like this gut is in one entire length, right? Like means there may be small intestine, large intestine, but we know the small intestine has also 3 parts. But it is in one entire length. It's not like duodenum is half cut. Then after this cutting, jejunum starts. No, we just named it. So this one entire gut. So one gut. So it is what? It is the SGLT1. Okay. So it will be present mainly in the intestine part. It is mainly present in the intestine part. It can be seen in kidneys. But in kidneys, you know, we have how many kidneys? We have 2 kidneys. So remember, 2 kidneys. So SGLT2 will be present in kidneys. We know this SGLT2 in kidneys. Okay. No, glut is a facilitated diffusion. Means glut, it is the facilitated diffusion. Just remember. I have written it right. So glut, it is a facilitated diffusion, guys. Okay, don't confuse it. Whereas SGLT, it is what? It is the secondary active transport. Fine. And next about this junctions. If you see about these junctions, why it is like, for example, if you are holding someone's hands for the first time, then what it will do? Means you will hold very tight. You won't even get this passage of gas even. So it is what it is, the tight junction. So remember, you are occluding it. So remember, the tight junction, it is made up of two things, two proteins, which is this occludin and clodin. Okay, you are occluding the gap. So it is what it is, this tight junction. Very tightly you are holding. These tight junctions that will be present in this barriers like blood-brain barrier and the blood-testis barrier, or other barriers where you cannot allow passage of the E substances. So it is what it is, this tight junctions. Whereas this junction, which is this gap junction, where there is a lot of gap, okay, here there is no gap. So it is what it is, this gap junction. And if sorry guys, and if there is any gap, so it is what it is the gap junction. And gap junctions, they are usually made up of connexons. And remember one thing, if there is any mutation in this connexon, it can lead to a disease which is known as Charcot-Marie-Tooth disease. Okay, remember one thing, if there is any mutation to this, can lead to this Charcot-Marie-Tooth disease. A good Dr. 𝗵𝗵𝗀𝗀 and good Dr. 𝗧𝗵𝗶𝗀𝗀. Got fine. Next, about few more things about this hemidesmosomes. They are present in the basal cells. Okay, these are this basal lamina, which will be consisting of this hemidesmosomes. Okay, whereas this intermediate filaments, it will be made up of this desmosomes. So remember, this tight junction, it will be made up of occludin and clodin proteins. Gap junctions, it is made up of connexons. Whereas this basal lamina, you will be able to see this hemidesmosomes. Whereas this intermediate filaments will be seen in a case of desmosomes. Okay, these are the few molecules you need to remember. They will ask in question like gap junctions, they are made up of occludin and clodin proteins. Is it true? Guys, is it true statement? It is asked in NEET PG 2024. Waiting for your answers, guys. हिंदी प्लीज, हाँ बिल्कुल, हिंदी हम बात करेंगे. अगर आपको कुछ समझ में नहीं आ रहा आप पूछ सकते हैं, हम हिंदी में बात कर सकते हैं, लेकिन एक थोड़ा यूनिवर्सल रहना चाहिए, तो इसीलिए हम अंग्रेजी में बात कर रहे हैं. ठीक है, हमारा मकसद ये है कि ये जो भी हम पढ़ा रहे हैं वो सबको समझ में आनी चाहिए और ये सबके पास ये जो नॉलेज है वो पहुंचनी चाहिए. बस इतनी बात है. ठीक है, अगर आपको कोई भी दिक्कत है आप हिंदी में पूछ सकते हो, मैं उसका जवाब दे दूंगा, आप उसका चिंता मत करो. अगर बीच बीच में हो सकता है तो मैं हिंदी का इस्तेमाल कर सकता हूँ. ठीक है, दैट इज माई मेन मोटिव. Okay, Patel, fine. Yeah, I guess, yeah, no, yeah, it is false. It is the false statement. So if you see this gap junctions, it will be made up of this connexins. Whereas tight junctions, it will be made up of this occludin and clodin proteins. Good Dr. 𝗵𝗵𝗀𝗀, Anju, Rahul and 𝗧𝗵𝗶𝗀𝗀. Right? With this understanding, we'll move on to the next part. Yeah, ठीक है ना, थोड़ा बहुत मिक्स करके बात करेंगे. ठीक है, then if you able to see this action potential and cardiac action potential, इसमें क्या डिफरेंस है? अगर आप देखोगे, so this action potential, it will be almost similar to all of these action potentials. लेकिन बस एक फर्क है. There is only one organ or this only one part of this organ which is having a different action potential. उसमें क्या different है? So if you see, for every stimulus, there will be a threshold. For example, if someone is keep on mocking you, like first initial days, will keep or you will let it go. Okay? தமிழ் தெலுங்கு பேசலாம், ஒன்றும் பிரச்சனை கிடையாது, பட் எல்லாருக்கும் புரியணும். ஓகேங்களா? So problem ledu, like thing is that we should be more universal, right? So if you see, if you keep on mocking someone, okay, there will be this sub threshold stimulus. So at certain point, like your brother or sister, they will get angry. So that point where they get angry, or at that point where this stimulus will execute as an action potential, it is known as threshold points. It is known as what? It is known as threshold point. About this stimulus, there are like few different points. Okay, for example, it will be having this few different points. Once this stimulus get executed, it will be having this phases like depolarization, followed by this there will be this repolarization, and there will be this hyperpolarization. So what is the universal thing? If you see this depolarization, it will be because of this sodium ions. So it is because of this inward movement of this sodium ions. Fine. Then about this repolarization, it's mainly because of this potassium. Okay, so remember it is like, so whatever we write, so it is the sodium potassium. So whatever we write sodium first, right? So it is what sodium is the one which is causing depolarization. So sodium, it causes depolarization, whereas potassium, it causes repolarization. Okay, yeah, fine. Yeah, okay, Dr. Amal Sharif, like mostly well try it off. Okay, don't worry. Okay, take it. फिर आगे बढ़ते हैं. So if you move ahead, you will able to see the next phase, which is this hyperpolarization. Okay, the initial phases, it will be depolarization, followed by this repolarization, which is because of this potassium ion out, and followed by this there will be more potassium will come out, so it will lead to this phenomenon which is known as hyperpolarization, and finally it come into the resting state. And once it comes to the resting state, then it will start. There will be this small sub-threshold stimulus. Once your brother get angry, it will lead to this action potential which is causing this depolarization. Right? Okay, yeah, बढ़िया. So remember the first ion it is क्या? So it is what? It is the sodium. Okay. Then about this potassium, it will be causing this repolarization. Okay. So just go to the pattern. Then we'll move ahead. Then if you see about this potential graph, this is way different. Why it is different? As I told you, this depolarization, it is because of sodium. Whereas in a case of SA node, there is a difference. There is a difference. What is the difference? This depolarization, it is because of this influx of calcium. So in a SA node, the depolarization, okay, the depolarization in a case of SA node, it is because of this calcium. So इसीलिए अगर if there is any atrial arrhythmias, तो हम तब क्या ऐसे दे सकते हैं? If there is any atrial deep means atrial problems, then we can give calcium blockers if there is any atrial arrhythmias. Yeah, the hyperpolarization in a case of nerve, it is because of this excessive potassium efflux. Yeah guys, correct. Arrhythmia. Okay. Then about this repolarization, it is universal phenomena. I told you it is because of the potassium. It is because of the potassium. Okay. And this happens in the SA node. So in SA node, they will ask you which of the following ion is responsible for this depolarization, and the answer is what? It is the calcium. Right. And next about this ventricles. In ventricles, the same repeats about like that. Like we see nerves. Like if you see, there is this phase 0. Phase 0 is actually what? It is this sodium influx, which is causing the depolarization. Okay. And next one, it is the, once it causes this depolarization, when it causes this positive peak, then it will start to depolarize. And when it start to depolarize, the starting, it is because of this potassium efflux. Okay, potassium efflux. But the calcium, it won't let it to happen. So at the same time of potassium coming out, the calcium tells no, I will equalize it by coming in. So the potassium will go out and calcium will come in. So it will lead to this phase, which is known as plateau phase. So they will mark you this point, which of the following ion is responsible for this plateau phase. Okay, because we know the potassium is already going out, but this calcium influx, it is responsible for this plateau phase. Okay. Then we'll move on with the phase 3. If you see this phase 3, it is what? It is the repolarization. और हमें पता है this repolarization, it is because of the potassium efflux. And after followed by this repolarization, it is what? It is this resting potential. So remember one thing, that depolarization is anywhere, it is because of the sodium, and in SA node, it is what? It is the calcium. Whereas the depolarization in anywhere means in most of the tissues, it is what? It is sodium, whereas in a case of SA node, it is calcium. Whereas depolarization everywhere, it is what? It is the potassium. It is the potassium. Okay, remember. Yeah guys, I hope you are getting it correct. Yeah, good Dr. Ritika, good Dr. Nash, good Dr. Rohit, good Dr. Vinci. Right. What is the reason for the AV nodal delay? Now, like about this conductive pathway, like we'll discuss in a further sessions. Like mainly it is because of these windings that there is this AV nodal delay happen. Okay, and main thing is that we need to suppress this atrial contractions, and means we need to suppress or we need to delay this atrial contraction to the ventricular contraction so that the blood can pass. That is the reason for this AV nodal delay. And this AV nodal, they will be having this leaky channel so that it will leak and it will have a delay. Okay, that is the superficial overview of it. And if you want in depth, like we'll discuss later. Right, that is the thing. Next about this lung volumes and curve. Okay, and about this lung volumes and curve, you need to know about this first ratio, which is this FEV1 by FVC ratio. Right, if it is normal, then it should be 80%. So first in the question it will be written, a patient, yes, yeah, like yeah, a 55-year-old smoker. Remember, it is a 55-year-old male smoker. Okay, the gender bias. The male smoker presents with complaints of shortness of breath, and now you plan to do an investigation which is known as spirometry. And on spirometry, you will be able to see his FEV1 by FVC ratio is 63%. What is the disease you will think of? Is it a restrictive disease or an obstructive lung disease? Yeah, guys. Yeah, Shavas Khan, it is a like it can be COPD, which is an obstructive type of disease. Yeah, good. Yeah, other guys, like what do you think? Is it a restrictive type of disease or an obstructive type of disease? Yeah, doctors. Yeah, good, Dr. Quinin, Dr. Gautam, Dr. Anju, Dr. Ritika, Dr. Rohit. Wow, well. It is what well played. So it is what it is this. It is the COPD which is what? Which is this obstructive type. So remember, with this FEV1 by FVC ratio, we can tell whether this is an obstructive disease or a restrictive lung disease. Okay. So then, in a case of normal, it will be more than 80%, or in a case of restrictive lung disease also, it will be remain normal or more than 18%. It will remain normal. Whereas in the case of restrictive lung disease, why this is normal? Because here the FEV1 also will decrease and FVC also will decrease. So since both of them decrease, so it will looks it is normal. Whereas in a case of obstructive lung disease, this will be decreased. So there will be decreased FEV1 by FVC ratio. Okay, yeah. So you should remember this. Next one, if you see, this is how a normal flow volume lobes looks like. If you see this normal flow volume lobes, and it is, and you saw this next lobe which is looking almost similar to this, but it is a smaller version of this normal one. It is which disease? Is it a restrictive disease or it is an obstructive disease? Yeah, Dr. Krish, yeah, it will be available for you for your lifetime. Okay, it will be available in this YouTube. Don't worry. So it is what? So just see guys, So it is the normal graph which is in small. Okay, it is in small. So it is what? It is the restrictive. Okay, restrictive. And I will tell you how will you differentiate. Yeah, good, Dr. Rohan Krishna. And I will tell you how will you differentiate this restrictive from an obstructive disease. If you are able to see this scoop, if you are able to see this type of scoop formation, it will be seen in a case of obstructive lung disease. Okay, they will give this image and they will give 4 options of obstructive disease, like 3 options of obstructive disease, and they will ask you which of the following condition will not seen. For example, they will give you COPD. The following graph will be seen in which of will not be seen in which of the following conditions. For example, COPD, asthma, emphysema, and fibrosis. Okay, so it is not in a scene in a case of fibrosis, which is a restrictive lung disease. Fine. And about this one, flattening of this spirometry graph. Flattening will occur based on the obstruction level. Okay, if there is any expiratory, if there is any extrathoracic fine guys, yeah, we'll start. Okay, there is a small lags. Okay, if there is a small lags, have some mind break. Okay, do some meditation and things. Okay, do revision of this subjects at the content. I hope there is no any more lags, right? Is there any lag? Don't say lie. Okay, tell the truth. Is there any lag? No, fine. Yeah, there is no lag. Yeah, good. Thank you, Dr. Trisha, Anna, Rahul, Amal, Konan. Okay, fine. Yeah, fine. We'll move ahead. Like as I told you, if there is any flattening of this extrathoracic, flattening of this inspiratory curve, extrathoracic obstruction, there will be a flattening of inspiratory curve. Okay, inspiratory curve. Okay, and if there is any fixed obstruction, it will cause flattening of this both. See here there is this expiratory curve also, expiratory curve flattening as well. of flattening. Yeah, that's it, Dr. Gautam. Like that's our main motto. Like at the end we should pass. Okay, fine. Like we are putting our maximum efforts to make this thing live without any lag. Okay, that is our main motto. Like because when this circles like जैसे गोल गोल घूम रहा है, like when this loading happens, I do feel very disheartened. Like I do feel like how this thing happens during the preparation part. Okay, so don't worry. So the things will be settled down. Fine. फिर उसके बाद आते हैं, if there is any fixed obstruction, then it will cause flattening of this both means both this expiratory and inspiratory curve. Whereas if there is only inspiratory flattening, it is because of, as I told, it is because of extra thoracic obstruction. If there is only expiratory curve for flattening, then it is what? Then it is the intra thoracic obstruction like foreign bodies. Fine. If there is both side flat like this, it is because of the fixed. For example, you did an intubation and the patient is intubated for a prolonged time. Then what will happen? This trachea will undergo ischemia. Then it leads to this stenosis part. So in a case of tracheal stenosis, this leads to this both side flattening. Okay, just remember guys. Right? With this understanding, we'll move on to the next part. फिर उसके बाद आगे बढ़ते हैं कि sarcomere and molecular motor की तरफ. If you see, mostly what they will ask you, they will give this image and they will ask you which of the protein is responsible for this band, and they will, or else they will ask you, since this image has been given, and they will ask you which of the following band which remains constant during muscle contraction. Okay, first we'll understand what is this sarcomere and how it looks like. If you see, remember जो भी midline है, remember it is midline. The thing which is on the middle or the midline, it is what? It is the M line. So M line है तो midline है. So M line, it is the midline. So M line, it is the midline. Okay, and adjacent to the midline. So remember, you are joining two lines. So if you joining two lines like this, there is a two lines and you are joining. So remember, it is H. Okay, so you are joining. So one line, two line. Okay, you are joining one line, two line. Okay, you are joining one line, two line, and you are joining them. So it is what? It is this H band. So it is forming this H, right? So it is what? It is the H band. So बीच में M line है, फिर one line another line joining है. So it is what? It is this H band. फिर उसके बाद there are two more zones. Okay, there are two more bands. One is what? If you see, there is band which is known as A band, and another one band, it is known as I band. You know, there are few important proteins, out of which we need to know two proteins. One is this actin, another one is myosin. So this actin, it won't goes with A. Okay, actin don't goes with A. So this actin will be present in the I band. Okay, in I band you will see actin, whereas in the case of A band you will see myosin. So myosin will be present in which band? Yeah guys, yeah, can you answer in the chat section? Myosin will be present in which band? Yeah, guys, yeah, good. It is myosin will be present in the A band, whereas this I band will be consisting of both actin and myosin. Just remember. So I band में actin रहेगा, or myosin will be seen only in A band. Okay, and after this you need to know this both of this, the ends of this I band. Okay, it will be connected by this line which is known as Z line. So initially, if you just for this understanding, midline it is the M line, and followed by which midline adjacent to it, it is known as H zone. Okay, and we have this protein which is known as myosin. Okay, this protein which is what? Which is this myosin, which is seen in the A band. And we know this I band will be consisting of two proteins. I band, it has two proteins. One is this, one is this. This one, it is what? It is the actin, and this is the myosin. Okay, the same myosin. Fine. And if you see, during a contraction period, this both I band will come together. Okay, so there will be during the contraction, I band, the length of I band will decrease. Length of I band decreases, and A band remains same. Yeah, good guys. Good Dr. Rituraj, good Dr. Anar, good Dr. Muhammad Ali, and good Dr. Rahul and Rohan. Okay, this is the thing you need to remember. And if you see, as I told you, the central line, it is the M line, and followed by this small area, it is the H zone, and this is what? This is the A band, which is having this myosin. Then followed by this is this I band, which is having this actin. Then followed by this is the Z line. Okay, this is the Z line. They will mark some of this point and they will ask you which of the following line is this, or which of the following protein is responsible for this, right? Then you need to know about these two molecular motor proteins. One is this known as actinin and another one is known as dynin. Okay, actin, no, kinesin and dynin. Okay, or kinesin also known as, which is causing this anterograde. So remember, this kinesin will cause us this anterograde. So what is the importance of it? Anterograde transport in the axons. And next one, it is the dynactin. Okay, remember dynactin and or dynanin. Okay, dynanin. In dynanin, remember this dynanin will cause us this retrograde. So remember, R for R, dynanin causes retrograde transport and it is responsible for transferring the rabies. So rabies, R&D. Remember, rabies and dynanin, R&D. Rabies will be responsible, will be transferred via this dynanin protein, via this retrograde transport. So it is the rabies virus which goes like this. Okay, we know this rabies will involve this retrograde involvement. Okay, itna to pata hai na, right? And we know in a case of rabies, what is the name of the bodies you will see in a case of rabies? Pathologically, what is the name of the bodies you will see in a case of rabies, guys? I will see the Negri bodies. We seen in a case of rabies. A good Dr. 𝗡𝗁𝗂𝗃, yeah, quinine, yeah, good guys. Good prototype, yeah, good. Fine. Next, about the movement of the GIT. If you see about this movement of the GIT, you need to know few movements. Yeah, good Dr. Rahul and Rohan and one more. Fine. If you see about the movements, you need to know about this peristalsis, segmental contraction, and MMC. Okay. Yeah, during autopsy, you will see, yeah, correct Dr. Gautam. Yeah. So there are few different movements. You need to know first movement, which is what is this peristalsis. And we know this peristalsis, it is responsible for pushing the food. Remember, peristalsis, we won't care about the absorption part. We need to transfer this food. We need to transfer this food from here to here. Okay, so for this, what we'll do two phenomena. One is what? One is this contraction part, and another one is the relaxation. Because if both side is constricting, how this food will move? So one side will be constricting, another side will be relaxed. Okay, relaxed. So what they will ask in this part is this: which of the following component is responsible for relaxation during this peristalsis? So if you see the component for causing the relaxation, so see, if you are not a VIP, then there will be no relaxation. So remember, if there is no VIP, so remember the relaxation causing things, they are this nitrous oxide and the vasoactive intestinal peptides. So remember, it is no VIP. So it is the relaxation. Okay, relaxation. It is the no VIP. Whereas for contraction, you see it is this acetylcholine, H3 and the substance P. So remember mainly about this acetylcholine and the substance P. Acetylcholine and substance P, it causes the contraction part. So it will cause contraction by this acetylcholine and substance P, whereas this relaxation, it will be done by this nitrous oxide and the vasoactive intestinal peptides. Fine. And if the same occurs in this opposite direction, we'll call them as vomiting. So vomiting will see this antiperistalsis. And about the next one, which is this migratory motor complex. Okay, I guess like, yeah, now you are hungry. Now I guess you are hungry. Fine. So because as you are hungry, then your stomach will be having the few movements. Okay, so this is known as what? This movement, they are known as migratory motor complexes. They are known as migratory motor complexes, and this migratory motor complexes will happen to erase or will happen to clean the stomachs or the bowels. So it is known as what? It is known as migratory motor complexes. Yeah, good Dr. Shanavaskan. And this MMC help in the cleaning of bowels before a meal. Okay, before a meal, you will be having them sounds, right? So it is this mmC, and this usually happens around 9 to 100, means about after 90 minutes this mmC will start and it will happen, okay, and it will happen and roam around after every 90 minutes. And once food comes, this mmC will decrease and it will promote the peristalsis. Yeah, good, Dr. Rohan. It is this 5 centimeter per minute. It will move for 5 centimeters. Yeah, good guys. Yeah, I'm really hungry. Yeah, we'll finish it up like just more 15 to 20 minutes. Okay, don't worry. Yeah, good, Dr. Gautam. Next, about this one more movement. As I told you, peristalsis, it will just move ahead. It will just moving the food particle. Whereas there is one more phenomena which is known as segmentation. There is one more phenomena which is known as segmentation. Or segmentation, remember, like this food which is being propelled by this peristalsis, it should be absorbed. So for absorption, what you will do, you will have this food and this bubble will come and it will cause contraction and it will cause absorption. So it is known as what? It is known as segmentation. It is known as segmentation, and segmentation, it is for absorption of the food. And next movement which is known as mass movements. For example, all our defecation movements, it is what it is, this in mass movements. All the bubble, it will react quickly. So it is known as in mass movements, which is seen in a case of defecation reflex. Fine. And there is one more reflex which is known as gastrocolic reflex. In question, they will reflex. There is a small child which goes to toilet, okay, or like especially fecal, okay, after a meal. Like just you feed a child a meal and the child now you need to use the toilet. So it is what? It is because of this reflex which is known as gastrocolic reflex. Once this food comes and reaches the stomach, it will cause relaxation of the sphincter, and this is known as what? This is known as gastrocolic reflex. It is most commonly seen in children's. Fine. And next, about this J hormones and secretions. And if you see about this J hormones, there are different families. One is known as gastrin family, another one is known as secreting family. So in the case of gastrin family, if you see, there will be two hormones, gastrin and CCK. Gastrin and CCK. We know gastrin, it is responsible for secretion of HCl. Okay. Can anyone tell me what is the name of this gastrinoma, means HCl secreting tumor, which is known as gastrinoma? It is associated with a syndrome. What is the name of the syndrome? Can anyone tell in the chat box, guys? Yeah, good, Dr. Gautam. Shanwas, come. Yeah, doctors. Is it men one? Like it can be seen in men one, but what is the name of this syndrome? Gastrinoma. Yeah, good, Dr. Harsh. It is what it is known as Zollinger-Ellison syndrome. Okay, so Zollinger-Ellison syndrome, it is what it is, the presence of this gastrinoma secreting tumor. Most commonly, it will be seen in a triangle which is known as Pezzaro's triangle, and most commonly it is at the duodenum. Okay, duodenum, and it is a gastrinoma secreting, and there will be more acids. Okay, there will be more acid secretion, so there will be a formation of ulcers. Fine. And CCK, it will causes what? It will causes this gallbladder contraction. Once you have a fatty meal, then it will be lysed by this biles. So it will be lysed by this biles because of this CCK, cholecystokinin. It will causes this gallbladder contraction. Right? And next, about this secretin family. In secretin family, we have the secretin, which will be responsible for secretions in the small intestines like duodenum, and we have this vasoactive intestinal peptides, also causing the secretions for absorptions and also GIP. Okay, all of these three will be come under this secretin family, and we know in a case of 𝗵𝗶𝗀 there will be a diarrhea will be presenting. Okay, yeah, correct. Yeah, ऊपर आग नीचे पानी. Yeah, correct, Dr. Shanwas Khan. Like achlorhydria means there will be absence of this one, absence of HCl. Whereas in a case of Zollinger-Ellison syndrome, there will be more acid. Okay, just remember those things. Next, just remember the most acidic secretion kya? It is what it is, this gastric secretion. Okay. Whereas most basic one kya? Bonner gland. Because we know once there is a food into the stomach, it will be digested by these acid secretions, and once this food, it will move into this duodenum, then this acid cannot enter into the duodenum because it can cause which one? It can cause this gastric ulcer, like, or this peptic ulcer disease, which will be causing this duodenal ulcer. So to prevent this, we have a gland which is known as Brunner's gland, which secretes this alkaline pH1. Will secretes this alkaline pH1. Fine. I guess you are getting it, guys. Next, simplest question. Okay, the simplest question which will ask in the exam, but make sure you are getting it correct. So one of your main motto of your examination is not getting the tough question correct. because tough questions will be 10 to 15 questions or maximum up to 20 questions, whereas the easy questions, it will be 150 to 180 questions. So main motto of your exam is to get easy questions to be correct. Okay, अगर आपने easy questions को आपने correct कर दिया, then you will able to come out with flying colors. तो आपका मेन मकसद यही रहना चाहिए, जो भी easy question पूछेंगे उसमें बिल्कुल गलती नहीं करना. Like if there is any easy questions, you should not miss it, you should make it correct, right? And there are different parts of the nephron. The parts of the nephron include PCT, the first part. Here it is the glomerulus, then it is the PCT. Followed by this, there will be this loop of Henle. There will be two loops, descending loop and this ascending loop. Okay, descending loop and ascending loop, followed by this distal convoluted tubule, and followed by this there is a collecting duct. Okay, this is the sequence. Okay, there will be this PCT, loop of Henle, and DCT and collecting duct. Now, in more advanced, what they will ask is where there is a maximum water absorption. Okay, can anyone answer the chat box? Like where in the collecting duct or proximal, where there will be a maximum absorption in if there is presence or absence of aldosterone. Okay, yeah guys, yeah, Shanwas Khan, yeah, you already got previously also, you already got my question. It is what? It is the PCT. So if there is presence of aldosterone, it does not matter. So the maximum absorption of water, it will takes place in the PCT. So it will takes place in the PCT. Yeah, good Dr. Harrison, Quenan, Prince. Okay, good Trisha, good Rahul. Like it is what? It is the PCT. So PCT, it will absorb the glucose, amino acids, and most of the ions and the water as well. It will absorb maximum water. Fine. And next, if you see about the loop of Henle, this loop of Henle, it is responsible for one mechanism which is known as counter current multiplier. Counter current multiplier. Okay. Once this comes, initially the water will go out. Okay, then they will, because of this water going out, there will be increase the sodium inside the loop of Henle, and this sodium, it will cause us this hypertonic, and this will cause us this high concentrated. So this is known as counter current multiplier system. So this counter current multiplier, it will be done by this loop of Henle, whereas this after once it being multiplied, or once you got this counter current multiplication, someone should maintain, right? So this counter current system, which will be maintained by this vasa recta. So the vasa recta will maintain the counter current, which is known as what? Which is known as counter current exchanger. Okay, just remember. Okay, counter current means we are making this urine, or we are making this inside, which is more concentrated. So it is known as counter current system. Okay, just remember, that is the thing. Okay. So mostly they will ask about these parts and about the absorption things and water absorption here, as I told you, then about this counter current multiplier and counter current exchanger. Okay, and after this we'll move on to this RAS system. Yeah, Dr. Ambika, like we'll discuss it. Okay, don't worry, because actually it is a kind of rapid revision, we cannot get in depth. So just remember for a sake, this counter current means like we need to maintain this osmolality of this urine. So to maintain this osmolality of the urine, we'll have two systems, like will the water should go out and the sodium should retain. So counter currently we are maintaining the osmolality. So that is what that is known as simply counter current system. Okay, I guess you got a bit overview. And next about the RAS mechanism. About the RAS mechanism, you need to know, like when there is a feature of this hypotension, this RAS mechanism activates. So they will ask you what is the origin of these components. For example, angiotensin, it will be secreted from the liver. Remember, angiotensin from the liver. Next, renin, it will be released from the kidney. Angiotensin from liver, renin from the kidney, and this enzyme, which is known as angiotensin converting enzyme, will be from the lungs. Okay, angiotensin angiotensinogen will be from the liver, and it will be supported by the renin, and it will convert into this angiotensin 1. This angiotensin 1 will be converted into this angiotensin 2 with the help of angiotensin converting enzyme. And this angiotensin converting enzyme, it will come from the lungs. Yeah, guys. Fine. So once this angiotensin 2 comes in, it will cause few mechanisms. One is what? One is angiotensin. The name itself tells it causes stents to the blood vessels. So it will cause constriction to the blood vessels, and it will increase the BP. It will cause tension and it will cause increase the BP. And what else it can do is that it can stimulate this adrenal gland, and it can make release of this aldosterone. Once it stimulates and releases this aldosterone, what will happen? Then this aldosterone will come and act to the collecting duct, and it will absorb this sodium, and we know wherever the sodium goes, it will absorb the water. So it will cause, first one, it will cause tension to the vessels. Next one, what it will cause? It will cause sodium and water reabsorption from this collecting ducts. Then next, what it will also cause? It will cause increase the thrust. It will stimulate the thrust center, and it will cause more thrust, so that it will drink more water. Yeah, good Dr. Gautam, and good Dr. Anar, and good Dr. Shanwas Khan and Anju. Right? Yeah, wherever sodium goes, the water will always follows it. Remember, okay? So this is how this RAS mechanism works. But in pharmacology, how they will integrate is that, you know, this angiotensin, it will cause constriction to the vessels, and it will cause hypertension. So we can use as a treatment, right? If we block this angiotensin, or if you block these receptors, or if we block any of these enzymes, then it can be used in a case of hypertension. So they will give this chart, like we told, this angiotensinogen, it will be from liver. Okay, fine. Then this renin, okay, this renin will be from kidney. So these two will come and will combine and will form this angiotensin 1. So if we block any of this above, then there will be no angiotensin, and if there is no angiotensin 1, then there will be no angiotensin 2, and it won't go and act, right? Okay, so this drugs which act on this kidney, they are known as direct renin inhibitors, and followed by which I told this enzyme which is ACE from the lungs. Okay, from the lungs we'll get this ACE. So if there is any blockers for this ACE, like pearls, if we give, then it will block, then there will be no conversion as well. Then we have blockers which will block this receptor as well, and will be blocking this degradation, which is known as what? Nephrolysers. So they are known as ARNIs. Okay, and we can even go and block to the receptors directly. They are known as angiotensin receptor blockers. Okay, and as I told you, what are the, how it will do? It will cause this vasoconstriction, and if there is no vasoconstriction, the blood pressure will drop. Okay, fine. Next, it will stimulate this thrust center. If there is no thrust, or if there is no thrust, there will be no water intake, there will be less water intake. So less water intake means less volume in the blood. Fine. And next one, it will cause the sodium and water retention, and if there is no sodium and water retention, there will be less blood volume and less blood pressure. Nice, yeah guys. The prill drugs like captopril, it will be what? It will be this ACE inhibitors. Whereas renin, like aliskiren, like they will be having this aliskiren, they'll be having this keren or ren in their ending. So they are what? They are this direct renin inhibitors. Fine. There are this valsartans, they are this ARBs. Fine. They are the ARBs. So these things you need to remember. Next one, we'll see about few nucleus. Okay, there is just few more slides, then we'll be done. Okay, there's this, we'll see the nucleus. So to remember about this nucleus, just remember about a car. So you see, you passed your FMGE examination. So what you do, you ask your father, like, Papa, मुझे एक गाड़ी चाहिए. Okay, you asked your father. So he bought you a decent car. Okay, he bought you a decent car. So once you bought a car, like you want to have a trips with your friends who have done with their FMGE examination. So all of you guys passed. So you are going for a trip to Goa. Okay, Goa or Manali. Okay. So if you are going for a trip, like obviously one will be driving, and there will be some other doors, and in which you and your friends will be sitting. Okay. See. Okay. You and your friends will be sitting. Okay. Yeah. BMW. Yeah. Cars. Okay. You got a BMW or some other cars. Fine. Fine. So imagine this scenario. Fine. There will be in a car, you know, like this small understanding, there will be this radiator. So radiator, it is the cooling. So if you see this anterior nucleus of this thalamus, anterior nucleus, it is for this cooling of body. Okay. It is for the cooling of the body. Fine. Next one, you saw this posteriorly will have this exhaust. Okay. This exhaust will be having this hot air, right? So the posterior nucleus of this hypothalamus, it is responsible for heating. Okay, it is responsible for, yeah, Maruti 800 भी चलेगा, कोई ना बस ट्रिप में जा रहे हैं, गोवा जा रहे हैं, मनाली जा रहे हैं, ठीक है ना? So posterior is responsible for heating, whereas anterior nucleus, it is responsible for cooling. Fine. फिर उसके बाद, then if you see this 3 people, I told you, right, you are 4 friends or 5 friends, you are going here. There will be a person who is sitting in the middle, and 2 of them, they are sitting on the window side. You see, who are sitting on the window side, they can explore a lot, right? They can explore more, and they can buy whatever they want. So they will eat more. So remember, they will eat more. So if in a case of sitting side, we'll call them as lateral. So lateral nucleus of this hypothalamus, it will be having this two centers, which is known as what? Thirst center and hunger center. So they will eat a lot, they will puke a lot, and they will drink a lot. So remember, so the lateral one they can eat, whereas you are sitting in the midline. Okay, you are sitting in the middle. So if you are sitting in the middle, means they won't give you good, right? So you should keep calm and you should tell yourself, no, I am not hunger, like I'm not having any hungry, no, I'm enough, I'm satiety. So the medial nucleus, it is responsible for the satiety. Okay, the medial, yeah, increasing hunger. Yeah, we'll go for the lunch in a while. Just hold your breath. Fine. Okay. So it is what? The medial one, it is for the satiety. Okay, the medial ventromedial nucleus, it is for the satiety. Fine. फिर उसके बाद you see, like you bought a BMW car, right? Obviously Maruti 800 में तो ऊपर छत तो नहीं मिलेगा. So you cannot get 800, you cannot get this shield from this Maruti 800. Whereas you bought a big BMW dude, right? So you will able to see while traveling, you will able to see the sky, right? If once you see the sky, you can feel it. So if you're able to see this, whether this is day or night, it is what it is known as circadian rhythm. So this circadian rhythm, it will be by this suprachiasmatic nucleus. So it is the circadian, it is the supra, it is above you. So this suprachiasmatic nucleus, it is what? It is the circadian rhythm. Okay, and don't forget this mnemonic, which is known as SOAP. SOAP. So remember, this supraoptic is responsible for secretion of ADH, which is the vasopressin. Whereas you just read it in opposite. Whereas paraventricular, it is responsible for oxytocin. Para, it is responsible for oxytocin release. Okay. Yeah, guys, I guess you are getting it right. So these are the mnemonics to remember. Remember the medial one, who is having always satiety. So it is what? It is the ventromedial nucleus. It is responsible for satiety. Whereas the lateral person who is eating and drinking a lot, it is what? It is this hunger center or thirst center, which is seen in this lateral hypothalamus. Anterior, it is responsible for cooling. Whereas posterior, it is responsible for heating. And in suprachiasmatic nucleus, it is for what? It is for your circadian rhythm. Okay, these are the nucleus. Yeah, good. I hope you remember this for your lifetime. Okay, that is the main motto. बस एग्जाम तक याद रखना, फिर उसके बाद हो सकता तो याद रखो, नहीं तो लेकिन एग्जाम तक तो याद रखना ही रखना. So just keep this thing remember till your exam. Okay. Next फिर उसके बाद आते हैं. Just about this nucleus of the thalamus. Just remember, it is as very VPM, very painful mouth. Okay, so remember the pain sensations of your mouth and the face will be carried by this VPM, ventro-posterior-medial nucleus, whereas this lateral one for this limbs, very painful limbs. So remember from the limbs, it will be what? It is the VPL nucleus. It is the VPL nucleus. Okay, बस ये दोनों याद रखना. फिर उसके बाद आगे बढ़ते हैं. Then you need to know this two, medial and the lateral. So याद रखना, like medial for music. So music के लिए तो सुनना. So remember this medial one, it is for what? It is for music. So for auditory impulses, it is the medial geniculate body, whereas for this lateral geniculate body, it is for the vision impulse. It is for the vision impulse. Okay, just you remember this 4 for the thalamus part, then it will be done. And about this cardiac cycle. Okay, it is one of this. Sometimes it will feel like it is very much complicated and things. Like let me tell you, don't think as a complicated part. Just इसमें थोड़ा बहुत याद रखो, so that if they ask you some point, you will be able to remember it. See, if you see initially whatever point is there, this is the pressure and this is the volume. Okay, pressure and volume. So see, there are only 2 curves. One is this curve and another one is this curve. Okay. If you see, this is the volume. If you see the volume of this ventricle, so mostly it happens in the ventricle. If the volume of the ventricle is increasing, then it is what? It is the ventricular diastole. Okay. In the case of ventricular diastole, क्या होगा? The volume of the ventricle will increase. फिर उसके बाद जैसे उसका volume will get increased, then what will happen? Then it will go for what? It will go for the systole. And there are different ways of systole, because we know the aorta will be having a more pressure, and there is some threshold. We need more pressure to open up the aortic valve. Okay, so what we'll do, there is a volume, but हमें क्या करना है? हमें pressure बढ़ाना है. You need to increase the pressure. So the first phenomena in the case of systole क्या है? It is what? It is the isovolumetric contraction. Here the volume remains same, whereas there is a contraction. Because of this contraction, there will be increased pressure. When there is this increased pressure, which is more than the aortic level, it leads to this phase which is known as ejection phase. Now the blood will eject from ventricle to the aorta. जैसे blood ventricle से aorta में जाएगा, means when the blood from the ventricle, it will go to the aorta. Okay, then it will happen what? Then the pressure will decrease, then it will lead to a phenomenon which is known as isovolumetric relaxation. Okay, so yeah guys, S1 S2, yeah, we'll discuss it. If you see this, so if the blood need to go, then the valve need to open, right? So aortic valve need to open it. Okay, and before this aortic valve open, there is one valve which is closes, which is the AV valve. So the first thing happen, it is the AV valve closes. So once this AV valve closes, it will produce this S1. So first the ventricle will be keep on filling. So there will be this ventricle will be keep on filling. Once it filled, the AV valve will get closed, you will get S1. Once you get the S1, then the ventricle, it need to increase the pressure. Once it will get increase the pressure by isovolumetric contraction, जैसे वो pressure को बढ़ाएगा, फिर once this pressure will increase, it will be more than the aortic pressure, then the aortic valve will open, the blood will go into the aorta. फिर जैसे aorta means सारे blood हो जाएगा, when all the blood will pass by, then this aortic valve will close. So this aortic valve will close, will cause which heart sound? It will cause S1 again or S2? Yeah, there's a small protodiastral space. Yeah, that's good. Yeah, when there is a closing of this aortic valve, it leads to what? It leads to this S2 heart sound. It leads to this S2. Okay, it leads to the S2. Fine. Here you'll be able to see the heart sounds. And after S2, then aortic valve opens, then the blood fills. So just remember to see these two graphs of this ventricle volume and the ventricular pressure. It is because of the closing of the valves. Heart sound, it is because of the closing of the valves. Like for example, when you open a door, like just imagine, when you open a door, does it sound makes, like for example, you are coming to your home at 12 a.m. in the morning, where you will get caught while opening or closing. Like while closing, you will get the sound, right? So while closing, you will get the heart sounds. Okay, and sometimes they will ask you what is the sequence of these events in relation with this JVP, in relation with this ECG, and along the cardiac cycle. So just remember by this mnemonic as P. The first one to come, it is the ECG P waves. Okay, it is because of this atrial contraction we know, and then the A wave in JVP, which is also because of the C. Then there will be this ventricular contraction, which is what like. Then there will be this initial QR in the ECG, then followed by this S1, then followed by the C wave, which is because of this isovolumetric contraction, cusp bulge, and followed by this X descent, and it is then the ventricular depolarization. Yeah, like in normally there is no sound. Fine. Then there will be this S2, then the V wave, then the S3. So remember, this is mnemonic PA QR1 CX T2 V3. Okay, just remember. It means sometimes they will ask you what is the sequence of this waves. Like for example, P wave, A wave, QRS complex, then first heart sound, then C wave, then X descent, then T wave in ECG, then second heart sound, then V, and then 3. So just remember this part. Okay. Then about few extra aids. So they will ask you like what are the things you will use to estimate this volumes. For example, if you want to measure the water, then you will use water. You will use heavy water like deuterium and tritium oxide or aminopyrin. You will use these three ones, which is deuterium, tritium oxide, and aminopyrin. And about this ECF measurement, we will use, remember, ECF extra. Remember, in childhood they told going outside, it is a sin. Who told mostly? Our mom will told. So remember, it is a sinma. So the ECF will be measured using this one. No, it is Dr. 𝗵𝗶𝗀, like the S2 will be after your aortic valve. It is the aortic valve closure, there will be S2. Okay, whereas AV valve closure, it will cause S1. Fine. And so remember, it is sinma. So remember, sucrose, it is used for ECF evaluation, I for inulin, and N for sodium, like radioactive sodium will be used, and Ma for mannitol. So sucrose, inulin, radioactive sodium, and mannitol, all of this will be used for measuring your ECF volume. And for plasma, you will use this iodine labeled albumin or Evans blue. So remember this for plasma measurement, you know there is a plasma protein which is what is albumin. So we'll use radio labeled or iodine 125 albumin and Evans blue. Fine. These are the things, just remember in sec. Fine. And about this next part, this is respiratory, you just remember this one mnemonic, this for bore. Okay, remember bore. So in a case of right shift, remember right shift. For right shift, remember as bore. So why it is bore? Because we know it is known as bore effect. Okay, bore effect. So remember it is Bohr's effect. If it is Bohr's effect, there is a R. So Bohr effect, it is seen in a case of right shift. And in right shift, everything will rise except pH. Except pH, everything will rise. So there will be increased rising of PCO2, rising of hydrogen ion means if there is increased protons, then there will be a decrease in pH. And there will be increased 2,3 dPg, and there will be increased temperature. Dr. Ambika, okay, fine. We'll repeat this cardiac cycle once I complete this. Okay, just have a patience. Okay, yeah, fine. So there will be this increased PCO2, and you can also remember R for R, it will cause release of oxygen from RBC to tissues. Okay, because the work of RBC is what? It is to carry the oxygen. So once it carries, it need to release into the tissues. So if it releases the oxygen, if RBC releases oxygen, it is known as Bohr's effect. And in Bohr's effect, everything will rise, like PCO2 will be more, protons will be more, 2,3 dPg will be more, and temperature also will be more. Whereas it is opposite of left shift. Okay, it is opposite of left shift. It is known as Haldane effect. It is known as Haldane effect. And in Haldane effect, everything will decrease except your pH. Okay, except your pH, everything will be decreased. Just remember these two concepts. If they ask you, all of the above are seen in right shift, all of the above are seen in left shift, except, you should be answer to it. Okay, next one. About this regulation of respiration, like mostly if there is any respiratory changes, or if there is any increased PCO2, it will be sensed by two levels. Or if there is an increased carbon dioxide, or you are respiring less, or you are in coma, it will be sensed by two receptors. One is known as peripheral chemoreceptor, next one is known as central chemoreceptor. As I told you, there are this simple diffusion. Simple diffusion takes place in lungs, whereas this tight bound barriers like blood-brain barriers, I told you, it will be bound by this claudin and aclodin, because in such a cases, these gases won't permeate over that. So remember, in a case of central chemoreceptors, it will be stimulated by this increase in hydrogen. Okay, increase in the protons. Okay, whereas the peripheral chemoreceptors, it can sense this increase in partial pressure of the CO2. Okay, increase in partial pressure of the CO2. And we know this peripheral chemoreceptors, it is located in the two phases. They are known as aortic body. Yeah, that is pre-Bötzinger complex. That is a different entity. That is for respiration part. Okay, fine. About for this peripheral chemoreceptors, if you see, there are two peripheral chemoreceptors. One is this carotid body. Next one, it is known as aortic body. Remember, carotid body, it will be carried, means the stimulus from this carotid body, it will be carried by this 9th nerve. Whereas for this aortic body, it will be carried by this 10th nerve. So 10th nerve will carry this aortic body stimulus, whereas this carotid body stimulus, it will be carried by the 9th nerve. So don't get confused. If they ask you, just make sure you are getting it correct. Fine. Then about this few reflexes. Okay, then about this few reflexes. If you see about this few reflexes, one is the CVS reflex, which is known as Bainbridge reflex. For example, you saw a 80-year-old female. Now you passed your FMGE examination. You passed FMGE and you are doing your internship. Now you allotted a PHC. In PHC, there will be this old age female who will be asking to give the fluids because she is feeling weak. She wants fluids. So, but you refuse because you know this concept, which is known as Bainbridge reflex, but you know that giving more fluid, it can cause cardiac decompensation. So imagine, like, you are not there. Means that day you went for a party. Your assistant was there. He has given more fluids. So if there is any more fluids, then what will happen is there will be cardiac chambers. This atria will get stretched. Okay, more fluid, it will cause stretching of atria. Yeah, correct, Dr. 𝗏𝗏𝗀𝗀𝗀𝗀. Yeah, see. So there will be this stretching of atria. So once there is this stretching of atria, this Bainbridge reflex will activate. Once there is this Bainbridge reflex will activate, it will cause what? It will cause increased heart rate, and it will cause increased contraction. Okay, to pull out this fluids or push out this fluids, there will be increased contraction. So it is what it is, the increase in heart rate. So tachycardia, it will be caused, and this tachycardia due to this increased or this distension of this atria. It is known as what? It is known as Bain bridge reflex. Okay, the first thing. Next one, it is known as ภิsols-Jarvis reflex. Imagine you got a breakup. Okay, like unfortunately, like you got a breakup. Unfortunately or fortunately, you got a breakup after FMGE examination, not now, after FMGE examinations. And so your heart felt very, very hard and it released some toxins. Okay, it released some toxins like serotonins. Okay, serotonins. Once this serotonins released in extraordinary amounts, it can come and cause damage to your heart and the other vital tissues. So in such a case, like your pretty heart, it will sense, yeah, you had a breakup. Okay, it's okay, it's normal, no issues. So your heart also will feel like, no, I am suffering, but I should not make others to suffer. So what it will do, this heart, it will cause tachycardia and it will cause less cardiac output, so that these toxins will not be transferred to other tissues. So there will be toxins in the heart. In a case of like myocardial infarction, there will be toxins, but this toxin should not be shared to brain and the other structures. So there will be a bradycardia and less cardiac output. So it is known as ภิsols-Jarvis reflex. Okay, it is known as ภิsols-Jarvis reflex. There will be this bradycardia, hypotension, and along with this apnea. So ภิsols-Jarvis reflex if there is any toxins. Okay, like if there is any serotonins, capsaicin and veratridine. Okay. So this is what this ภิsols-Jarvis reflex. Next one, it is the Cushing's reflex. Okay, if there is an increased intracranial tension, means then the blood should go to the brain, right? Blood should go to the brain. So what will happen is this brain is not getting enough blood because there is more pressure. If there is more pressure into the brain, if there is more pressure, how the blood can go freely, right? The blood cannot go freely. So the body will think the brain is not getting enough blood, so will increase the BP. Okay, but this increased BP will be sensed by this brain. So which is a miscalculation. So because of this increased BP, the brain will sense there is increased BP, so I need to decrease the heart rate. So in a case of increased ICT, there will be increased BP to help or to increase the perfusion, but at the same time the brain will decrease the heart rate. Okay, the brain will decrease the heart rate. So in Cushing reflex, there will be increased intracranial tension, there will be increased BP but decreased BP. Okay, decreased BP. And remember one point, that which of the following reflex will be having a tachycardia? It is what? It is the Bain bridge reflex. So the Bain bridge reflex will be having the tachycardia, whereas most other reflex, it will be having the bradycardia. Fine. They will give this image and they will ask you what are the phases. It is the phase 1, phase 2 and phase 3. Remember phase 2, there will be increase in volume. The volume will be increased but the pressure will not increase, because I told this bladder will be having a different type of epithelium. Can you tell me what is the name of the epithelium or what is the type of the epithelium you will see in a case of bladder? Yeah, Anash, that is Starling ulcers, that is seen in a case of bones. That is the gastric ulcer, that is a different entity, that is Cushing ulcer and Starling ulcer. Yeah, good Dr. Gautam, good Dr. Quinen, good Dr. Ansh and Shanavas. Yeah, fine. It is what? It is the transitional epithelium. This transitional epithelium, as I told, it will undergo a thing which is known as plasticity. Plasticity or adaptation. Because of this plasticity, this bladder will distend, but there will be no pressure. There will be increase in volume. And in phase 3, there will be this voiding phase, there will be increase in pressure. So initially there will be increase in volume and increase in pressure, and there will be a stagnant level. There will be where this phase 2 there will be increase in volume but no change or no change in pressure. So it is what? It is the phase 2. It is because of this plasticity of the bladder. It is because of the plasticity. A good Dr. Harsh and Rituraj, right? Next we'll move on to the final part. After that we'll take a break. Fine. Then about this ABG analysis, you know there are multiple ways to solve this ABG analysis. Let me decode, and if you see ABG analysis from after this session, you will decode in just 30 seconds. Okay, you can decode in just 30 seconds. Yeah, if you know this well and good, that is what? That is the Rome. Okay, this is the normal values. To remember this normal value, remember this 35-45. The normal pH is 7.35 to 7.45, whereas normal PaCO2 is 45 and 55. Okay, 45 and 55. So remember these two concepts, and HCO3, if you are able to remember, well and go. It is what? It is 22 to 26. Fine. So remember it is Rome. Respiratory means opposite. If you see, first you need to check two things. One is what? One is pH, next one is PaCO2. pH, PaCO2, both of them they will be having the same value, 7.35 to 7.45, 35 to 45. So you remember 35 to 45 for PaCO2, 7.35 to 7.45. Okay, and see, like if pH increase, if there is increase in pH and decrease, okay, if it is C, if it is increase and decrease, is it is on same side? No, they are on opposite sides, right? These two arrows, see, if two arrows on the same side, it is, we'll call them as equal. If it is one on this side, one on other side, it is what? It is the opposite one. Okay, so remember, if it is respiratory, it will be always opposite, either increase decrease or decrease increase. Okay, fine. Whereas in a case of metabolic, both will increase or both will decrease. Okay, this is the thing you need to remember. Fine. First you see respiratory opposite, I told you, right? If there is any respiratory alkalosis, okay, respiratory alkalosis, first you see here the pH is increased, then PCO2 you see alkalosis, so the pH will be decreased. Okay, whereas we know the PCO2 it is an acid substance. In the case of acidity, this PCO2 will increase. In the case of alkalosis, PCO2 will decrease. Okay, okay, you just remember this concept. If you unable to remember, just remember first see, if a pH is increased and PCO2 decreased, both of them they are in opposite side, so it is a respiratory. And you see the pH is increased, so it is, we'll call them as alkalosis. We'll call them as alkalosis. Next you see the pH is decreased and PCO2 decreased, both of them in opposite direction, so we'll call them as respiratory problem. And since the pH is decreased, we'll call them as acidosis. So it is what? It is the respiratory acidosis. Fine. And I told metabolic will be equal. You see pH here is increased, and we can take this to also, we can take this to also, or we can take PCO2 also. Like if you see pH increase and bicarbonate increase, or mainly if you just look into the PCO2 part, okay, PCO2 part, if both of them they increase, okay, so if you see this, both of them increase for bicarbonate, it is what? It is the metabolic problem. It is the metabolic one. Okay, and we know it is pH increase, so it is what? It is the alkalosis. And if both of them is decrease, then it is what? It is the acidosis. Then again it is the same side, so it is the metabolic one. And we need to see the pH. The pH is decreased, so it is what? It is the acidosis. So if you have some confusion, we'll do some questions. See, I told you the pH is decreased here. Like I know there will be a few point of confusion. So I told the normal pH is 7.35 to 7.45. The pH is decreased here and PaCO2 is increased. If both not are in if both are in opposite directions, then it is what? Then it is a respiratory one. Then it's a respiratory. You know, if it is pH is decreased, we'll call them as respiratory acidosis. Okay, we'll do one more question. If you see the pH here, it is what? It is more than 45.45. So it is pH is increased. Okay, and then PCO2 if you see, it is decreased. So if both in opposite direction, then it is what? Then it is a respiratory problem. Then we'll see the pH. अगर pH को देखेंगे ये क्या है? Acidosis है, alkalosis. If the pH is less, we'll call them acidosis. If pH is more, we'll call them as alkalosis. So pH इधर ज़्यादा है तो we'll call them as respiratory alkalosis. Respiratory alkalosis. Yeah, good Dr. Anar. Good Dr. Shanavas. Yeah, good. Yeah, guys, we're getting it correct. Then फिर उसके बाद आगे बढ़ते हैं. Then here you can see two things. See here the PCO2, the pH is decreased, and bicarbonate is also decreased. So दोनों in same direction. So क्या है? It is what? It is metabolic acidosis. Yeah, you got Ash and Shnavaska. And here you see this pH is increased and bicarbonate is also on increased side. So it is the metabolic condition. फिर उसके बाद if you see this pH, so it is what? It is the alkalosis pH. So it is the metabolic alkalosis. It is the metabolic alkalosis. So if you are unable to get it, just this recorded session will be available one more time. You can just watch one more time so that you will not having any confusion. फिर उसके बाद when you will say that it is a compensated, if the pH becomes normal, then we'll call it as compensated. If you see, this is the normal pH. Whereas if you see PaCO2, it is decreased. and bicarbonate is also decreased. So if there is any PaCO2 is decreased and bicarbonate also will be decreased. If you see the decrease, it is less decrease when compared to this one. So it is what it is, a metabolic acidosis. Okay, it is a metabolic acidosis. Okay, a cardiac cycle will repeat. Okay, fine. That is the final part I will do, and I will repeat the cardiac cycle part also. Don't worry. Fine. So, and it is what, see, the pH is normal, so it is a compensated. It is a compensated. Okay, so the final note point is that if it is on the different side, then you call them as respiratory. Then once you call them as respiratory, then you need to see the pH. If pH is more, it is what? It is alkalosis. If pH is less, it is acidosis. Then if it is both of them on the same side, then it is metabolic. Then if it is pH is more, then you call them as alkalosis. If the pH is less, we'll call them as metabolic acidosis. If the pH is normal, then you'll call them as compensated. And final part, it is the anion gap. Usually we'll measure this anion gap with the formula of sodium minus chlorine and bicarbonate. Okay, sodium minus chlorine and bicarbonate. Okay, so just remember, we'll use this anion gap between this positive and negative ions will be measured using this formula, which is known as anion gap formula. Fine. And the normal range, it is 8 to 12. Okay, there will be few conditions where there will be acidosis, but there will be normal anion gap. So this condition, they are called as 𝗔𝗔. Yeah, mentioned it. Yeah, good, Dr. Ansh Shanavas, yeah, good. Fine. Yeah, good. And so it is what is known as 𝗔𝗔. So it is seen in a case of diarrhea, renal tubular acidosis, and renal failures. Whereas there will be increased anion gap will be seen in a case of methanol, uremia, diabetic ketoacidosis, and then paraldehyde, then iron poisoning, lactate, increased level of lactate, and ethylene glycol poisoning, and salicylate poisonings. So all of these conditions you can remember as mud piles. Okay, mud piles for this increased anion gap. Okay, means increased anion gap for this methanol, uremia, DKA, paraldehyde, and iron, lactate, increased, and ethylene glycol and salicylate. So iron, lactate, ethylene glycol, and salicylate poisoning. So all of them will be having this increased anion gap. Okay, just see this anion gap and the ABG one more time so that you can be well versed with it. Okay, fine. Like we'll discuss this cardiac cycle, but others who have understood this cardiac cycle part, you can have a break. Just remember, like before moving to the next day, just remember one thing: whatever you are doing, it is for you. Okay, and don't compare yourself with anyone else in the world, because you are unique in your own way. So just have this mindset in your thoughts that you are doing it for yourself and how you are better from yesterday to the today. Okay, just remember. Okay, so just you should be better than anyone else, but you should be better than how you used to be. If you do this thing and if you keep this thing in your mind, you will shine in your life and you will come out with flying colors in your upcoming FMGE examination. And we'll take the lunch break for around an hour. Like we'll get back to you at around 3 o'clock. Okay, our session will resume at 3 p.m. Okay, and whoever didn't understand the cardiac cycle will check it out. Fine. This cardiac cycle, there is few phases. Like I'll give you a small glimpse. There will be, like initially there will be this ventricular filling. There will be ventricular filling followed by this ventricular contraction and followed by this ventricular diastole. So ventricular filling, it is what it is, this ventricular diastole. So during ventricular diastole, the blood should come and it need to fill. Okay, the blood should come and it should fill. Okay, and during this ventricular diastole, there will be atrial contraction. Okay, there will be atrial contraction. Okay, and once the ventricle is filled, then it need to contract and it need to send the blood to the tissues or the body organs. Fine, it is known as ventricular systole. But just blood, it cannot go like that. We need to increase the pressure. So first phase of increasing pressure is what it is known as isovolumetric contraction. There will be a blood, you need to increase the pressure. Fine, so you need to increase the pressure. So once you increase the pressure, it is known as isovolumetric contraction. But make sure before increasing the pressure, you should close this aortoventricular valve, which is connecting this atrium to the ventricle. Fine. Once you closed it, you will increase the pressure. Once the pressure is more than the aortic level, then the aortic valve will open. The blood from the ventricle will move into the aorta. Once the blood moves, then the valve will close. Then the ventricle will relax. then it will go into the diastole phase. This is the simple explanation of this cardiac cycle. So that is what initially there will be this diastole part, followed by this systole, and followed by this diastole part. So these are the parts you should remembering of, and this is how this cardiac cycle works, and this will be coordinated with this electrical movements and this jugular pulsations. So initially when there is this atrial contraction, then it will what? Then during this atrial contraction it will be causing this P wave, and followed by this ventricular contraction will cause this QRS complex, and followed by this during the depolarization you will able to get there is a formation of this T wave. The same thing will this JVP, will understand JVP in our medicine session. JVP initially the A wave is due to this atrial contraction, then C wave it is due to the cusp bulge, then followed by this atrial relaxation and this ventricular filling. Okay, these are the few phases you need to remember. Just remember superficial about this cardiac cycle, and S1 it is due to the closure of the AV valve, and aortic valve closes will causes this S2 hot zone. Okay, that's it guys, that's it for this physiology end. We'll have a good and great break for an 1 hour till 3 p.m. and we'll meet at around 3 p.m. and we'll continue on the session for the biochemistry. It will be for around 1 hour 30 minutes to 1 hour 45 minutes. And thank you for waiting this long, and I hope you have a good dinner, good lunch. Okay, yeah, meet you, see you guys, miss you. Yeah. Hello doctors, welcome back to the biochemistry part, and this is our game-changing session by Dr. 𝗍𝗶𝗀𝗀, and I guess you had your dinner. Like, could you please confirm me in the comment section like whether you were able to see me? Yeah, hello Dr. Anna. Yeah, lunch done. Yeah, that's good. Dr. Rahul, Dr. Anna. Oh, yes, good. Like, by the way, how is your preparations going on? Is all well? Okay, good, Dr. 𝗶𝗍𝗀𝗀. Yeah. Have you ever given any GTs, or how is your GTs going on? Hi, Dr. 𝗵𝗵𝗶 H. I do remember someone asked about the GT part, right? Like about GT, just remember one thing. Like make sure you are giving GT and make sure you are reading your volatile topics before giving a GT. And you know that like most of the GTs will be coming from this most important topics. Like you just go through these topics or make them a mock in your main notes. And once you mark them into your main notes, and once you revise or before going to your GT, attempting your GT, make sure you are reading this PDF once more. It will improvise on your strongest topics or the easy topics you will get for sure. No, royalty, yeah, Dr. Royalty, like if you ask me, like if you are between 120 to 122 marks, then you should focus on the high yielding subjects like ENT, ophthalmology, pharmacology, microbiology, pathology, forensic medicine, pediatrics, and obstetrics gynecology. If you make this subject stronger, for sure you will be able to cross the marks. Okay, just make sure you are doing them on high. Like I guess so, like most of us have been joined. I guess we'll start our session with biochemistry. Like yeah, the expected time duration is 1.5 hours. Like mostly we'll finish between 1 hour 15 minutes to 1 hour 45 minutes. That is our average duration, and this is our biochemistry. If you do with this biochemistry, there will be around 18 to 20 questions from biochemistry part only, and it is few interlinks with PSM and some infections as well, but mostly it is core biochemistry. There will be around 15 to 18 questions will be there. If you read this gold standard one, it will be help you in solving this 15 to 18 questions mostly, and the most important topics in this biochemistry is what it is, the vitamins. So without delay, we'll start with the biochemistry part. Okay, yeah, hello Trisha, hello Mohammed Ansh, hi Harsh, Kwan, Rahul, Priti, yeah, hi rest of you. Fine, then yeah, we'll catch up. First, we need to know the classification of vitamins. We know there are two types of vitamins. There are this fat soluble vitamins and the water soluble vitamins. Like water soluble vitamins, like remember the gali, which is what? Which is this BC. If someone give you gali, like don't think always to repay them back. Just wash out from your minds. So the things, the water soluble vitamins, they will be washed off when you wash them. For example, if you wash this polished rice or if you wash rice more, then the vitamin B will go off. Okay, the same with the citrus fruits. If you wash them, this water soluble vitamins will go off. Just remember. Okay, so it is one of this simple things. So remember, so water soluble vitamin is vitamin B and C. The rest A, D, E, and K, they are what? They are this fat soluble vitamins. So Surya, like I told you, right, I have given you the unnoted PDF and I will give this unnoted PDF after my session. Okay, like don't worry, I won't take this into my home and I will just won't keep them in my locker and keep it safe. No, it is to be safe with you. Okay, so don't worry, I will give you, don't worry. Fine. Next, we'll move on to the vitamin A. Vitamin A, there are different components of vitamin A. They are retinol. So the most common one for us, it is what? It is the retinol. Okay, and we know this retinol. Remember, this is for all. So retinol, that is be for vision and reproduction. It will be for this vision and reproduction. So retinol, it will be for vitamin A, which is for vision and reproduction, and deficiency. If you see about this deficiency of vitamin A, initially it will start with few things. For example, it will start with a symptom of, correct Dr. Mohammed Ansh, it is what? It will start with a symptom of night blindness, yeah, yeah, nyctalopia, which is night blindness, followed by this there will be dryness. Initially there will be 𝗃𝗓𝗏, then followed by which dryness, conjunctival xerosis will be there, and once this xerosis forms, then it lead to this condition, which is what, which is known as, already most of you answered, Zoe, Dr. Soy, and yeah, like Mohammed Anash, Gautam, yeah, you got them, and Dr. Anar, it is what, it is the white hot spot. And can anyone tell me, under X classification, it will be classified as which of the following class? Yeah, good, Dr. Rahul, Dr. Kaunim. This is what it is, X1b. It is classified as X1b, and this is the typical feature of this white hot spot. Okay, and there will be, initially there will be this conjunctival xerosis, and followed by this corneal xerosis, means there will be dryness of this cornea, and followed by this, sometime it can result into the ulcer part. Fine, yeah, good guys, good Hush, good Surya, good Anar, good Anash, good Hush. Fine, well said. Fine. Then if you move ahead, like what is the treatment prophylaxis? We know for treatment we'll give vitamin E, but for prophylaxis we do this. Sorry guys, like for treatment prophylaxis of this vitamin A deficiency, we give this prophylaxis mainly for the children. So if the children is around 6 years 6 months of age, the children of less than 6 months, then what is the dosage we'll give? Yeah, good Anash, it is what, it is 50,000 dose, 50,000 international units if it is less than 6 months, and if it is less than 1 year, how much will give? Yeah guys, will give 1 lakh international units. Whereas if it is equal to, or if it is more than 1 year, okay, remember it is equal to or more than 1 year, then we'll give, remember this equal symbol. Okay, if you see here, I didn't put equal, right? It is just less than 1 year. Less than 1 year means 11 months. Okay, whereas here if you see, it is more than or equal to 1 year, means if it is, the child is 1 year, or if the child is more than 1 year, then we'll call them, and then we'll give them 2 lakh international units. 2 lakh international units. Yeah, group Dr. Unwanted, yeah, like Dr. Zoe, Preeti, Prince, Anna, Quen, yeah, you were getting it correct. So it is the 2 lakh international units. This is the vitamin A prophylaxis. Okay, vitamin A prophylaxis. Okay, yeah, we can give both orally and IM as well, and we can give 0, 1 and 14th day. Okay, 0, 1 and 14th day. And we know this vitamin A, like now let me ask you a question. This vitamin A is given along with which of the following vaccine? Yeah guys, yeah, that is, yeah, correct. Yeah guys, glitch, oh, I guess there is no glitch. See, this vitamin A will be started mostly from the 9 months. So 9 months we know it will be started along with MMR. No, it's not BCG. BCG we give only 1 dose, right? BCG will give only the birth dose. So birth days you won't put vitamin A. In birth, which vitamin will give? While means on birth, on when the baby is newborn, or on the first few days of newborn, which vitamin will give? Yeah, good Dr. Gautam. We give vitamin K, we won't give vitamin A, whereas around 9 months we'll start giving this vitamin A, and along with this MMR vaccine, remember. Fine. Next one is the vitamin B1. A good Dr. Psychiatry, Mohammed Anash, Chiku, and Dr. Anna, and Kishley, and Preeti. Fine. We'll move on to the next part. You say a male, you say a alcoholic male is presenting with features of giant disturbances like ataxia. Okay, he is presenting with 3 features: global aphasia, ataxia, and ophthalmoplegia. So which condition you will think of, guys? If alcoholic male, yeah, it is what? Yeah, it is, this 3 will be seen in a case of Wernicke's encephalopathy. बस इतना याद रखना. Next, we know there is usually this vitamin B1 deficiency will be seen in a case of polished rice users, like polished rice users, or it will be seen in a case of alcoholics. And we know this deficiency of this vitamin 1, which is what, which is actually this thiamine, and this leads to this condition which is known as, what is the name of this condition? It is what? It is the beriberi. It is the beriberi, and there are two types of beriberi. One it is the wet beriberi and another one is the dry beriberi. Remember, the wet beriberi, it involves the blood. So if it involves this cardiovascular system and causing this congestive heart failure, then it is what? Then it is the wet beriberi. Wet beriberi. So if you are able to see, there is this congestive cardiac failure and along with this vitamin deficiency, it is what? It is this wet beriberi. Okay, it is the wet beriberi. Whereas in the case of dry beriberi, you will be able to see this neurological manifestation. Neurological manifestations. You will be able to see neurological manifestations. Yeah, good, Dr. Naresh Chiku, Anash, Trisha, and Rituraj. Good, good. Okay. Then what are the clinical features you will be able to have? Like as I told you, there will be this involvement of cardiac involvements, and we know there will be one more syndrome which is known as what? Korsakoff psychosis. Sometimes can be associated with this Wernicke's encephalopathy. Okay, Wernicke's encephalopathy. So in such situations, we need to know whether this vitamin B1 level is sufficient or not. So in such condition, first we'll measure a drug, or first we'll measure with this enzyme, which is what? Which is this 𝗵𝗶 transcatalysis. Can anyone tell me in which of the following pathway you will see this 𝗵𝗶 transcatalysis? Yeah, guys, which pathway? Glycolysis, Krebs cycle, like pyruvate dehydrogenase pathway, or HMP shunt? Yeah, guys, you will see this type of this 𝗵𝗶 transcatalysis in this HMP shunt. Remember, in the HMP shunt. Okay. Yeah, good, Dr. Chiku. Good, Dr. Gautam. It is, you will see in the case of HMP. Okay, remember. And so vitamin B1, it is also known as thiamine, and it is deficiency will cause this beriberi. There will be two beriberi, wet beriberi and dry beriberi. Wet beriberi causes this cardiac manifestations and congestive cardiac failure, whereas dry beriberi will manifest with this neurological manifestations. So that's what you need to know about vitamin B1. To measure the level of B1, we'll use this 𝗵𝗶 transcatalysis. 𝗵𝗶 transcatalysis will use for vitamin B1. Fine. Next one, it is vitamin B2 deficiency. If you see about this vitamin B2 deficiency, vitamin B, we'll call them as what is the name of this vitamin B2? Yeah, it is what? It is the riboflavin. And we know if there is any deficiency of this riboflavin, it leads to this features of glossitis, ileosis. It is what? It is the inflammation around this corner of the mouth or inflammation around the lips, and one, the itching and burning of the eye. Remember one thing, vitamin A deficiency, I told, if there is any deficiency, it leads to this conjunctival xerosis and dryness. Fine. Whereas in a case of riboflavin deficiency, remember this riboflavin deficiency, it causes neovascularization over the cornea. It causes this vascularization over cornea. Okay, vascularization over cornea. So this is the classical or one of the few conditions where you will be able to see this neovascularization over cornea. Fine. Yeah. And to measure this level of this deficiency, we'll use this 𝗵𝗶 glutathione reductase. The deficiency will lead to this glossitis and ileosis. Just remember. Fine. Then we'll move on to the vitamin B3. What is the other name of vitamin B3? Yeah, guys, what is the other name of vitamin B3? Yeah, it is what? It is known as niacin. It is known as niacin. And niacin deficiency will lead to this disease which is known as pellagra. Yeah, good, Doctor. Yeah, everyone is good. Yeah, Bharat, Dr. Kishley, Pooja, Trisha, Chiku. Yeah, fine. Yeah, you are good. Fine. In pellagra, you will be able to see this type of features like D features, dementia, diarrhea, and dermatitis. And this type of dermatitis, mostly in question they will be given, like there is a patient on exposure to the sunlight. On exposure to the sunlight, the patient is presenting with the rashes, and mostly this exposure, these rashes are on this exposed aspect or this sun exposed aspects. We'll call them as which necklace? We'll call them as Cazals necklace. Okay, we'll call them as Cazals necklace, and all of this thing will be seen in a case of niacin deficiency. And we know which of the following amino acid will lead to the formation of niacin? Which amino acid which forms the niacin? Yeah, guys, it is the tryptophan. tryptophan forms this niacin. Okay, so 60 milligram of tryptophan will form this 1 milligram of niacin. ठीक है, इतना याद रखो. फिर उसके बाद what are the clinical manifestations? There are this dementia, diarrhea, dermatitis, and finally it can lead to even death. Okay, and mostly will make this diagnosis based on the clinical features. And what is the one more disease? Yeah, good, Dr. Anash, I was about to ask this thing. Like, there is a disease which is mimicking this niacin deficiency or this pellagra. It is what? It is the 値 disease. It is the 値 disease. Okay, which is due to this due to this passage or overflow of this tryptophan into the urine, leading to this deficiency which is known as 値 disease. Yeah, even in carcinoid syndrome, there will be overusage of this tryptophan and it can lead to this features like pellagra like features. Yeah, good. Yeah, guys, correct, Chico. Fine. Then we'll move on to the next part. What is the name of this vitamin B5? What is the name of this vitamin B5? Remember, P for punch or P for pan. Okay, pantothenic acid. Okay, pantothenic acid. And this deficiency will have a typical features of burning feet and burning hands. We'll be having the features of burning feet and hands. The patients will come and complains that the patient is feeling of burning feet and burning hands of features. Fine. And we know this disease can mimic, or there is an enzyme deficiency which is associated with this vitamin B5, which causes this eye of tiger sign. Eye of, like, if here you are able to see, right, eye of tiger sign, like that is a kind of eye. So if you are able to see this type of eye or tiger sign, you will see in which disease? Yeah, guys. Yeah, it is the pantothenate kinase deficiency. It is seen in a case of pantothenate kinase deficiency. Okay, yeah, guys, correct. Fine. And then just for niacin deficiency, it can also be seen in case of mice eaters. It can be seen in a case of mice eaters. Okay, there will be, if there is a history of mice eater and along with this feature, then you need to think of this niacin deficiency or this pellagra association. Okay, remember, because there will be excess of leucine which causes this tryptophan not to be uptaked and will present with this features of pellagra. Okay, yeah, correct, Dr. Nash. Fine. Next, we'll move on to the next. This is the one-liner type of questions. Which of the following vitamin deficiency is associated with this isoniazid? Like, we know the regimen for this tuberculosis, like H or ZE. Okay, here there is this isoniazid. So which of the following vitamin deficiency will happen in the case of isoniazid deficiency? Yeah, guys, it is what it is. Remember, as I6. Yeah, correct. Kishli, Ansh, and Arfat. Yeah, it is what it is. The I6. Remember, it is I6. So it is the isoniazid deficiency causes vitamin B6 deficiency. Okay, so that's why in such cases what we'll do, we'll give supplementation with vitamin B6, which is the pyridoxine. Okay, yeah, good, guys. Okay, next, if you're able to see next condition, which is the vitamin B7, and vitamin B7 will be named as, it is named as biotin, and it is responsible for this coenzyme of this following enzymes like pyruvate carboxylase, propyl CoA carboxylase, and acetyl carboxylase. So all of this thing, it will require vitamin B7, which is the biotin. And we know there is a gym trainer. There will be a history of consumption. There is a gym trainer there is a history of consumption of raw eggs, and we know this raw eggs consumption will lead to the formation of this component which is known as avidin, and if there is any formation of this avidin component from this biotin won't get absorbed and lead to the deficiency of this biotin. Just remember. Yeah, good, Dr. Ansh. Fine. This is this vitamin B7. Remember. Then next we'll move on to this vitamin B9. In the case of vitamin B9, what is this vitamin B9? What is the name of this vitamin B9? Yeah, guys, what is the name of this vitamin B9? Yeah, good, Dr. Rahul. Yeah, good, Dr. Anna, Naresh, Preeti. Yeah, it is what? No, it is not histamine. I guess Arfat, you are not in live. Kindly press this live one. Yeah, good, Dr. Anju Chiku and Dr. Quinin. Okay, if you see vitamin B9, which is this folic acid. Folic acid, and we know this folic acid will lead to this formation of this neural tube defects. Okay, yes, today we studied, right, spina bifida. Okay, in the spina bifida, if you are able to see this nerves or this meninges along with this myelocele, like are this nerves, what you will call this? As I told you, if there is a spina bifida where you will able to see this both meninges and along with this nerves from the spinal cord, what it is? Is it myelocele or myelo-meningocele? Yeah, it is the meningo or myelo-meningocele. It is the myelo-meningocele. This is how this looks like, and we know the clinical features will be non-closure of this posterior or anterior neuropores, and you know this folic acid, this can lead to the condition of anemia, especially the megaloblastic anemia. Okay, yeah guys, yeah, correct, Dr. Anna, Parul, Dr. Quinin, Trisha, 𝗚cie𝗁𝗀𝗀𝗀, yeah, you are getting it correct. Okay, fine. And for diagnosis of this folic acid deficiency, we will use this test which is known as Figlo test and this histidine loading test, and this test which is known as histidine loading test are also known as Figlo test. Fine, and it will lead to this type of megaloblastic anemia. And now you need to differentiate between this megaloblastic anemia of folic acid and the vitamin B12 deficiency. How will you differentiate? We'll do a test which is known as serum methylmalonyl-CoA levels. So if you see this serum methylmalonyl-CoA levels, it will be elevated in a case of vitamin B12, and along with this there is an elevated level of homocysteine. Whereas this homocysteine will be elevated in the case of both vitamin B9 deficiency anemia as well as vitamin B12 deficiency anemia. Whereas the driving factor or this factor which causes the differentiation, it is what it is, the serum methynyl-CoA or serum methylmalonyl levels. Just remember. Then we know what is the other name of vitamin B12. I guess what is the other name of vitamin B12? This is what it is, the cyanocobalamin. It is the cyanocobalamin. Okay, cyanocobalamin. Okay, and it leads to this deficiency of megaloblastic anemia. So obviously there will be a features of anemia. Okay, there will be the history. There will be written history of fatigue. Okay, shortness of breath. Okay, in a pure vegetarian female. Okay, it will be mostly suggestive of which anemia? It is what it is, the vitamin B12 deficiency megaloblastic anemia. And here you will be able to see this, there is a presence of neurological manifestations as well. Whereas in a case of folic acid deficiency, there will be no neurological manifestations. No, like kindly Anju, please check it, like the isoniazid consumption, I'm sure that it will cause this pyridoxine deficiency, which is this vitamin B6. Okay, isoniazid, it will cause us this deficiency. Whereas folic acid, it will be seen, or the deficiency will be seen in a case of methotrexate. Methotrexate usage, you will see this folic acid deficiency. So that's why if you are giving a female who is presenting with features of this ectopic pregnancy, and if you are giving single shot, it's okay. But if you don't want to recur, then you will give alternate days of methotrexate. Along with this, on alternate day, you will give what? You will give this folic acid. Okay, you will give this folic acid. So just make sure, don't get confused. Okay. Then about the next condition, which is what? Which is this vitamin C. Vitamin C, it is what? It is the ascorbic acid. Yeah guys, yeah, you are correct. Yeah, vitamin B12 absorption will takes place in the jejunum. Yeah, right. Yeah, correct. Yeah, vitamin C, it is what? It is the ascorbic acid. Fine. And we know this vitamin C deficiency, which is the scurvy. And we know in a case of scurvy or vitamin C deficiency, there will be manifestation of bleeding. We know this vitamin C, what it will do, it causes a thing which is known as hydroxylation of proline and lysine, and this will help in the formation of collagen. So if there is no vitamin C, there will be no proper hydroxylation of proline and lysine. If there is no proper hydroxylation of proline and lysine, and there will be no proper formation of this collagen, and if there is no proper formation of this collagen, this can lead to this bleeding episodes. That's why the patient will present with the features of gum bleeding. Okay, there will be features of petechiae. Okay, petechiae as well, and there will be this periosteal bleedings. Okay, we'll see this more also. So there will be a presence of this periosteal bleedings, and this periosteal bleedings will be manifested as painful limbs in children. Like the child will, like as of the child had a fracture, it won't even allow you to touch the limb. Okay, because it is that much painful. Just remember. Okay, it is painful because of this periosteal bleeding. Then in vitamin D deficiency, if we see vitamin D, it is what, there are different forms of vitamin D. Okay, there is this vitamin D1 which is known as calciferol, D2 it is ergocalciferol, D3 it is cholecalciferol. Okay, yeah, correct. Arfat, vitamin C required for the wound healing, and to increase this absorption of this vitamin C, we need to give citrus fruits or any citrus containing thing will increase the absorption of it. Yeah, deficiency of this vitamin D will cause us two things. One is what? One is this osteomalacia in adults, whereas in children it causes rickets. In children, yeah guys, correct, it causes rickets in children, whereas this vitamin D, it is very painless. Whereas we saw vitamin C deficiency, which is the scurvy, it is painful in nature, whereas vitamin D deficiency, it is painless in nature. And we know this vitamin D, it is responsible for absorption of the calcium, and if there is no vitamin D, and there will be less or no calcium, and if it is no calcium or less calcium, it will manifest in where? It will manifest in our bones. So it will be presented with the features of valgum and wind-swept deformity. Yeah guys, and there will be the features of craniotapes, also known as ping pong skull. Okay, there will be a soft skull will be there, and here you will be able to see these painless nodules. They are known as ricketic rosary. Okay, they are known as ricketic rosary. Yeah, on X-ray you will be able to see three features, which is what? Cupping, flaying, and spraying. Okay, cupping, flaying, and spraying, that I will teach you later on, don't worry. Okay, here you just remember vitamin D, what are the names? And mainly vitamin D3, it is the cholecalciferol, fine, and deficiency leads to osteomalacia and rickets, and for management we'll give this vitamin D supplementation by a regime which is known as Stowe's regime. Okay, Stowe's regime, just remember. Okay, and next we'll move on to some other elements. For example, here there is a patient who is presenting with features of CNS features like chorea due to basal ganglia involvement, right? And along with this is elevated liver enzymes, and on evaluation we found his ceruloplasmin levels were decreased. So in which of the following conditions all of these will be coexisted? There will be decreased level of ceruloplasmin, and there will be this CNS involvement mainly because of this basal ganglia involvement, and there will be elevated liver enzymes. And you plan to do a ophthalmologic examination, and on ophthalmology you will be able to see this type of rings. Yeah guys, what is what? Yeah, Godansh, Coin, Dr. Rahul, Gautam, Dr. Anar, Naresh, Kishley, and Barad, and Anju. Okay, all of you are getting it correct. It is what it is, this KF rings, which is seen in a case of Wilson's disease. And we know, don't confuse these mutations, it is what it is, this ATP7B. So remember, if you make this B, make this W, and if you make this W into like this, it is B. So it is ATP7B which causes this Wilson's disease. And we know in a case of Wilson's disease, the copper will be excess. Remember, the copper will be excess. There will be copper levels increased, whereas the copper binding protein, which is the ceruloplasmin, these levels will be decreased. And in eye finding, you'll be able to see there is a thing which is known as KF rings. And can anyone tell me? Yeah, already Dr. Chiku has already answered. The KF rings, it is due to the deposition of copper deposition in which number? Which layer? It is the copper deposition in the Descemet's membrane. Descemet's membrane. Yeah. Okay. And in MRI, yeah, good, Dr. Ansh. And in MRI, we'll able to see that is what it is, the face of panda sign. Face of panda. It is the face of panda sign. Just remember. And these are the things you need to remember about this Wilson's disease. Okay. Remember about the Wilson's disease. Next. What is the name of the cataract you will see in a case of Wilson's disease? Okay, guys, what is the name of the cataract you will see in a case of Wilson's disease? A good, Dr. Pratap. Yeah, it is what? It is the sunflower cataract. So you will see this sunflower cataract. Okay, yeah, good, Dr. Anar, Dr. Naresh. Yeah, good, Dr. Rahul, good, Ansh, good. Then if you see, there is a child who is presenting with these features of kinky hair. Okay, there is this features of kinky hair. This type of kinky hair is seen in a case of, it is seen in a case of kinky, it is seen in a case of Menkes disease. Menkes disease. And we know it is due to the deficiency of copper. A good, Dr. Ansh, Gautam, Rahul, Kaunin, Naresh, Anna, Dr. Chiku, Dr. Preeti, and Dr. Pratap. So it is due to the deficiency of copper. And we know here the mutation is ATP7A gene. It is due to the mutation of ATP7A gene. Yeah, good. Yeah, good, Ragna. Next, this rate limiting enzymes. There is no way out, so that you can remember this. You should mug up it. If you are unable to remember these things, just make this note and make this note in a small paper or a sticky note and paste into your walls. See them on everyday basis, because mostly they tend to ask on this very much often. Okay? Yeah, Ratta Marna. Correct, Dr. Chiku. So if you see this glycolysis, हमें पता है कि it is what? It is due to the rate limiting enzyme क्या? It is the phosphofructokinase 1. Okay, it is the phosphofructokinase 1. Pep cycle, remember, it is the ICD, isocitrate dehydrogenase. Isocitrate dehydrogenase. फिर उसके बाद gluconeogenesis, you just remember, it is the fructose 1,6 bisphosphate. It is one of the new things and difficult to remember one. फिर glucogenesis, हमें synthesis करना है. We need to produce new. So we'll use this glycogen synthesis. Whereas next one, which is the glycogenolysis, we need to break them out. So for break them out, we'll use this enzyme which is known as glycogen phosphorylase. We'll use this enzyme which is known as glycogen phosphorylase. So glycogen synthase will be used in the case of glycogenesis, whereas glycogenolysis will be using the glycogen phosphorylase. Fine. Then HMP shunt will use this enzyme which is known as glucose 6-phosphorase dehydrogenase. We'll use this enzyme which is known as glucose 6-phosphate dehydrogenase. Yeah, good, Dr. Ansh. And can you tell me in which of the following anemia you will see this G6PD deficiency? What is the name of it? Yes, it is what? It is the G6PD deficiency. The name itself, it is the same. It is the G6PD deficient anemia. It is a G6PD deficient anemia. Fine. And there are a few other yeah, here you will be able to see this white cells and this Heinz bodies. Fine. And there is a few other things you need to remember of. For beta oxidation, remember. Okay. Okay. Beta. Okay. Beta loves cat. Okay. Remember this beta oxidation. The enzyme is what? It is carnitine acyl transferase. Beta, it is cat. Okay. It is the cat one. Next, ketogenesis. It is the HMG-CoA synthase. Ketogenesis, it is what? It is this HMG-CoA synthase one. Okay. Next one, for fatty acid synthesis, it is what? It is the acetyl-CoA carboxylase. For fatty acid synthesis, it is the acetyl-CoA carboxylase. Ketogenesis, it is the HMG-CoA synthase. Whereas for cholesterol synthesis, it is not HMG-CoA synthase. It is cholesterol synthesis, but it is not HMG-CoA synthase. It is the HMG-CoA. Yeah, guys, it is what? It is the HMG-CoA reductase. Remember. And to inhibit this, we'll use this drug which is known as statins. We'll use the statins to inhibit this HMG-CoA reductase. Next, for this urea cycle, we'll use this caramel phosphate synthase 1. So we'll use this CPS1 enzyme. Okay. Whereas for pyrimidine synthesis, what is the enzyme we will use? Yeah, guys. Yeah, good Dr. Runner. Statins will act by inhibiting this 𝗏𝗵𝗀𝗀𝗃 reductase enzyme. Yeah, that's the spread. Next, purine and pyrimidine. In pyrimidine, what is the name of this enzyme? Yeah, guys, it is what it is. The another variant. It is the CPS2. Yeah, good Dr. Hansh. Good Dr. Quinin. Yeah, good. Good Dr. Priti. Next, we'll see some of this glycogen storage diseases. Usually, this glycogen storage disease, it will be manifested in childhood. The child will be having this classical features of. There will be this classical features of hypoglycemia, hepatomegaly, and lactic acidosis. Hypoglycemia, hepatomegaly, and lactic acidosis. And along with this, there is a features of this hyperlipidemia and hyperuricemia. Okay, so in it is not 𝗏𝗏𝗀𝗃𝗀. Just see. We'll read 𝗏𝗏𝗃𝗀 in pediatrics. Don't worry. Okay, fine. Just listen. That's what. You don't get confused with simple things, and don't mark an answer once you see it. Just read all the 4 options. For example, like it is looking like 𝗏𝗏𝗃𝗀. I do agree, but see first. Read all the options in which it is related to. Okay, here the questions will describe. There is a 5-year-old child or 6-year-old child is presented with features of or complaints of failure to thrive. On evaluation, the mother tells is exercise intolerant. Okay, intolerance, and while checking your blood glucose level, his blood glucose remained low. Okay, blood glucose remained low, and when you did this workup, you will able to see this hepatosplenomegaly, and there is a features of this hyperuricemia and hyperlipidemia. Okay, so itna yaad rakho. So it is the keywords. So there will be the child with failure to thrive, and there is a features of this hepatomegaly, and on examination and on evaluation you will be able to see there is a features of hyperuricemia and hypoglycemia. Okay, so the most common cause of this type of features or most common cause of this glycogen storage disease is what is the type 1, which is this von Guericke disease. Okay, von Guericke disease, and we know this mnemonic like type A, like von pumped Cori. Okay, von pumped Cori and made her to work out. Just remember, made her to work out or made her to study. Okay, पढ़ने के लिए आए हैं, बस पढ़ने जाएंगे. ठीक है? So just remember, he made like von pumped Cori and made her to walk. Just remember. Okay, so if you are able to see, okay, yeah, just remember like okay, 2 for here, tired, and study. Okay, just remember like however you want you can keep. It's up to you. Okay, there is no any harm in it. Okay, it's at the end of the day whether you are getting the questions correct or not. However you want you can remember, but if you remember but you get these questions wrong, then that is the point where you are making mistakes. Okay, good. Yeah, good Dr. Gautam. Yeah, like if you see this type 1, which is this von Guericke disease, it is the most common one, and it is due to the deficiency of glucose 6-phosphatase. Yeah, there will be affected, there will be both liver and kidney. We know this glycogen, it will be stored in the liver and kidney as well, so there will be affecting of this liver as well as the kidney. Whereas in type 2, remember this is 𝗵𝗵𝗃𝗃. there is a O, right? Don't make it into a heart. Remember, 𝗵𝗵𝗃𝗃 disease, it will affect heart. Along with these features, there will be a features of this cardiac manifestations as well. Okay, if the questions describes there is a child who is presenting with features of failure to thrive, and on examination you will able to see there is a presence of cardiomegaly on X-ray, and on further evaluation you will able to see there is this presence of this hypoglycemia. So all of these things will be suggestive of acid maltase or this alpha 1,4 glycosidase deficiency, which is this 𝗵𝗵𝗃𝗃 disease, which is the 𝗵𝗵𝗃𝗃 disease. Yeah, okay. Then next about this 𝗵𝗃 disease. Remember this 𝗵𝗃 disease also known as limit dextrinosis, because here there will be absent of this enzyme which is known as debranching enzyme. So remember this CD. So 𝗵𝗃 disease is due to the deficiency of debranching enzyme. Debranching enzyme deficiency. We know while formation of this glycogen, like you cannot store the glycogen like this, so we need to make them branch. Okay, because of if you make them branch, then you can store them more appropriately. But once you make a branch, make sure you need to break them also in later on, right? So you need to break from branch then to the stem. If you cannot break the branch, you cannot break the stem even. So here it is due to the absence of the deficiency of this enzyme, which is this debranching enzyme. So 𝗵𝗃 disease is due to the deficiency of debranching enzymes. Yeah, Dr. Ansh, Dr. Gautam, you got it correct. Next one is Anderson enzyme. Anderson disease, it is due to the deficiency of branching enzyme. Okay, it is due to the deficiency of branching enzyme. And fifth one, see remember fifth one, it is the McCardle's disease. Remember M for M, it is involves this only muscles. There will be history of only what? There will be a history of exercise intolerance. Exercise intolerance. Okay, just remember there will be a history of exercise intolerance in a case of McCardle's disease. Fine. And finally, it is this Hirsch disease. Hirsch disease is due to the deficiency of this hepatic glycogen phosphorylase. So remember, her for hepatic, her for hepatic. So Hirsch disease is due to the deficiency of hepatic glycogen phosphorylase. Okay. So 𝗏 it is due to the deficiency of glucose 6-phosphatase. 𝗵𝗵𝗶 disease, it is due to the deficiency of acid maltase. 𝗵𝗵 disease CD, it is due to the deficiency of debranching enzyme. And Anderson disease, it is due to the deficiency of branching enzyme. And McCardle's disease, it is due to the deficiency of muscle glycogen phosphorylase. And Hirsch disease, it is due to the deficiency of hepatic glycogen phosphorylase. Okay, so just remember all these enzymes, they will ask you like 𝗵𝗵𝗶 disease is due to the deficiency of which of the following, like that. Okay, next about few other conditions. If you see this condition, which is this essential fructoseuria. Okay, in essential fructoseuria, remember it is this fructose excretion in urine. Okay, we studied in physiology which of the following GLUT is responsible for uptake of fructose. Yeah guys, yeah doctors, which of the following GLUT is responsible for uptake of fructose? Yeah, wow, awesome. Wow, like it's really well played. Like I really trust you that you can do it, because you will able to remember and you can able to revise and you can tell them in a few seconds. Yeah, good. That really good. That gives me immense motivation to proceed ahead, and for sure, like I'll bless you. Like you will get this exam cleared and you will come out with flying colors. Yeah, that's really good, Dr. Anna, Chetan, Ansh, Rahul, Kishli, Kon, Parul, Preeti, Gautam, Sai, Teja, and Chiku. Okay, good. That's really good. Well played. Then you say a child with like there will be a classical history. If not a child, they will tell like there is this 7-month-old child started on extra feeding, okay, or additive feeding, where you started to give the fruits, okay, or the sugar containing drinks, and now the child is presented with features of vomiting. So if there is any feature which is starting when you give this juices or this fruits containing juices which contains the fructose, then if the child is having this manifestation, then it is what? Then it is the fructose intolerance. Whereas you say a child who is just a newborn, who is just few days old, okay, now he is presenting with features of failure to thrive, and there is a features of vomiting, and there is a features of mental retardation and cataract. All of this thing will be seen in a case of galactosemia. If there is newborn within few days of presentation due to exposure to breast milk. Yeah, good, Dr. Naresh Cohen. Yeah. Okay, yeah, thank you, Dr. Gautam. Like I feel very good. Thank you. Yeah, good, Dr. Anna. That is what the next question I want to ask. Whether this condition, galactosemia, is a contraindication for breastfeeding? Yeah, that is what it is, the contraindication. It is one of this contraindication for breastfeeding. Remember, okay. And here there will be features of this hepatomegaly, oil drop cataract, and there is a features of this mental retardation as well as this reversible mental retardation. Just remember this fructose intolerance, it is due to the deficiency of this enzyme, which is this aldolase B. It is due to the deficiency of aldolase B. Whereas this galactosemia, it is due to the deficiency of this galput, which is what? Which is this galactose 1-phosphate uridyl transferase. It is due to the deficiency of galput deficiency. So if a child who is just 6.5 months or 7 months old and you started with additive feeding, okay, you started with extra feeding other than the breast milk, especially these fruit juices, now the child started vomiting, they will ask you which of the following is the deficient. Here the aldolase B will be deficient, which is what? Which is this galactose intolerance. Whereas you say a child who is just 4 to 5 days old, now he is presenting with features of vomiting and features of dehydration. okay, and he's not taking up this breastfeed. Now he will think of this galactosemia, and it is due to the deficiency of galactose 1-phosphate uridotransferase, which is also known as GALPAT. Okay, so itna yaad rakhna. Yeah, good, Dr. Kishlik, Dr. Ambika, Dr. Gautam. Yeah, good. Okay, fine. With this understanding, we'll move on to the next part, which is this mucopolysaccharidosis. Most of the cases, in the case of mucopolysaccharidosis, they will be roaming around this few things. Here, they will be having this child with the features of coarse face along with this corneal clouding and organomegaly. All of these things will be suggestive of the coarse faces, this corneal clouding, and along with these features of this organomegaly, it will be suggestive of this condition, which is known as mucopolysaccharidosis. Okay, in mucopolysaccharidosis, they will just roam around between these two syndromes. One is Hurler syndrome, and another one is the Hunter syndrome. Remember, Hurler syndrome, it is due to the deficiency of alpha L hydrogenase. Okay, hydrogenase. Okay, it is due to the deficiency in a case of Hurler syndrome, whereas in a case of Hunter syndrome, it is this hydrogenate sulfatase. It is the sulfatase Hunter. It is the sulfatase deficiency. And one more thing is that they will give these classical features. There is a child who is presenting with this coarse faces, organomegaly, and it is found to be a disease of Hurler syndrome. What is the enzyme deficient? You will answer as alpha L hydrogenase deficiency. Whereas in some cases they will give this. There is a child who is presenting with these features of this coarse face or organomegaly, and is found to have deficiency with hydrogenate sulfatase. Whether this corneal clouding will be present in this case or not. Okay, yeah guys, will corneal clouding will be present in a case of Hunter's disease? Yeah, correct, Dr. Naresh. Hunter maybe, yeah, here Hurler there is a L, and this enzyme also L, so LL. Okay, LL, yeah. Okay, no, yeah, remember in the case of Hunter, agar aapko Hunter banna hai, means if you want to become a hunter, then your cornea should be clear, right? Agar cornea mein kuch dekh raha hai, matlab if there is something in your cornea, you cannot see it clearly. Okay, then if you are not able to see clearly, how will you hunt, right? So in the case of Hunter's disease, the cornea will be clear. And remember, as I told you, most of these enzyme deficiencies, they are autosomal recessive in nature. Whereas remember, Hunter, he should aim. So to aim, what you need to do? You will to do best in the FMGE examination. Before examination, you should practice. So likewise, Hunter will practice. Okay, and he will aim. So aim, okay, he will be having this clear cornea. So when someone is aim or hit, will mark them as X. Okay, when he aims and when he need to throw it, will mark them as X. So remember, it is this X linked recessive disorder, and here the cornea will be clear. Okay, here the cornea will be clear in nature. Okay, whereas this disease, like if you can just remember this names itself, just type 3 it is Sanfilippo disease, type 4 it is Murray disease, type 6 it is Maratiux-Lamy disease, type 7 is Sly disease, 9 is Natovich disease. Just remember these names, whereas this first two conditions, it is more than enough to get the exams correct. Right? Next, about this lysosomal storage diseases. In lysosomal storage diseases as well, there is the classical presentation. There will be a child with features of failure to thrive, and sometimes they will be having these additional features as well. There will be features of this hepatosplenomegaly. And on evaluation, if you are able to see this type of crumpled tissue paper appearance, it will be seen in a case of which condition, guys? This type of crumpled tissue paper, or this tissue paper, if you just crush it, how it looks, right? So the same, if you are able to see this type of crumpled tissue paper appearance, it will be seen in a case of, yeah, good guys, it is what it is seen in a case of Gaucher's disease. It is seen in a case of Gaucher's disease, and we know this Gaucher's disease, it is due to the deficiency of beta-glucocerebrosidase. It is due to the deficiency of beta-glucocerebrosidase deficiency. Okay, next, remember about this crab, okay, or Krabbe's disease. Remember, there is a B. So if there is a B, remember, it is the beta. Okay, it is the beta. Okay, there is two B's. It is not just one B. You can ask me like, Fabry also there is one B. What is the big deal? So here if you see 𝗵𝗵𝗃, there will be two B's. This 𝗵𝗵𝗃 disease, it is due to the deficiency of beta-galactocerebrosidase deficiency. Okay, okay, yeah, Bakra, yeah, you can remember it as, yeah, Bakra. Okay, so remember it is beta, which is seen in a case of 𝗵𝗵𝗃 disease. Bakra means sheep. Okay, okay, so this is the Bakra, remember. Then this Fabry's disease, it is due to the deficiency of alpha-galactosidase deficiency. Fine. And next you need to know about this two disease. One is this 𝗧𝗵𝗃𝗀𝗃 disease, okay, and another one is this 𝗧𝗵𝗃 disease. Why? Because both of them, they will be having the deficiency of hexosaminidase A. So remember, T, it will be having this only A, T, so 𝗧𝗵𝗃𝗀𝗃 disease only having the A, whereas 𝗧𝗵𝗃 disease will be having this deficiency of both hexosaminidase A and hexosaminidase B. Okay, hexosaminidase A and B deficiency will be seen in the case of 𝗧𝗵𝗃 disease. And remember, in both of these conditions, you will be able to see a findings in eye, which is known as cherry red spot. Cherry red spot. Okay, cherry red spot. And if you draw this T will be lean. So in a case of 𝗧𝗵𝗃𝗀𝗃 disease, there will be no organ involvement. No organ involvement. Okay, so we told usually the child will be having this features of hepatosplenomegaly, whereas in a case of T, so like a thigh, you remember, thigh will be lengthier, right? See this thigh, how it is, T is simple. Okay, it is slim. So if it is slim, then it will be lean, there will be no organ involvement. So instead of no organ involvement, there will be these features of neurological manifestations. Neurological manifestations. Yeah, good, Dr. Anna, Ishli, Naresh. Yeah, good. Yeah, if there is, yeah, correct. That is what my next question. If there is a features of this cherry red spot, and along with this organomegaly, so cherry red spot we have seen, it is seen in a case of 𝗧𝗵𝗃𝗀𝗃 disease and 𝗧𝗵𝗃 disease. You know, 𝗧𝗵𝗃𝗃 disease, it is T. The patient will be lean. So if he is lean, then he will be having this brain, right? So he will be having these features of neurological manifestations with no organomegaly. Whereas if you see this cherry red spot along with these features of this organomegaly, it will be seen in a case of which condition? A good, Dr. Ansh, it is what it is seen in a case of 𝗵𝗵𝗃𝗃 disease. 𝗵𝗵𝗃𝗃 disease. And remember this Neyman, if you flip this N into like this, it is the Z. So you will see this zebra bodies. Okay, you will see this zebra body. So remember, just flip this. This is N, right? Like this is N. Yeah, kindly. Yeah, I'll just write it up. This is N. So if you flip this N into like this, it is the Z. So it is the zebra bodies which you'll see in a case of 𝗵𝗵𝗃𝗃 disease. Okay. And 𝗵𝗵𝗃𝗃 disease, it is due to the deficiency of sphingomyelinase. It is due to the deficiency of sphingomyelinase deficiency. And this is how this zebra bodies, which is seen in a case of 𝗵𝗵𝗃𝗃 disease. Okay, so this is this zebra, like, you know, like zebra, it will be having this alternate bands of black and white. So it is the zebra bodies. Fine. Next one about this ETC, electron transport chain. In electron transport chain, for sure there will be asking one question. So you know this mnemonics, right? Like complex 1, remember complex 1, it will be ending with 1. So there will be this barbiturates, which includes this phenobarbitone and rotenone. Okay, phenobarbitone and rotenone, they have this 1, so it will be affecting this complex 1. But this complex 2, it will be affected by this malonate. It will be affected by the malonate. So it is just a few more pages, like we'll finish it in another half an hour, dude. Okay, half an hour or a maximum of 35 to 40 minutes. Okay, that's it. Fine. Next, if you see this complex 3, okay, complex 3, remember there is this 3-letter word, which is this ball. Okay, ball. Who is having this ball? Anti. Ball means hair. Remember, it is ball. Anti is having a long hair. Okay, so remember, it is this ball anti. Okay, remember. So in case of complex 3, it will be affected by this antimycin and this British anti-leucite. Okay, remember. Okay, these two. Okay, so ball and antimycin, it will be affecting this complex 3. And complex 4, it will be affected by this carbon monoxide, cyanide, and hydrogen sulfide. So all these hormones like carbon monoxide, cyanide, and hydrogen sulfide, all of them, they affect this complex 4. Okay, yeah, we'll be continuing short. Then complex 5, it will be inhibited by this oligomycin. Okay, it will be inhibited by this oligomycin. You know the plus 5, which is this F0 to F1, which leads to the conversion of this ADP to ATP. Okay, and this conversion will be incubated by this oligomycin. Fine, oligomycin. And sometimes we know this hydrogen, it need to come in. Hydrogen, we need to come in and need to couple it. Sometimes this hydrogen cannot come in, and this is known as uncoupling reactions. And one of this pathological uncoupler, it is what it is, the 2,4 dinitrophenol. It is the 2,4 dinitrophenol. It is the 2,4 dinitrophenol. Fine. And next about this amino acids. If you see about this amino acids, there are different classification of this amino acids. First one, this aliphatic amino acids. They are, to remember this aliphatic amino acids, remember as GAVLI. Okay, GAVLI. That is glycine, alanine, valine, leucine, and isoleucine. Okay, that is glycine, alanine, valine, leucine, and isoleucine. Okay, next one, the aromatic amino acids. Remember, it is the tyrosine, tryptophan, and phenylalanine. Tyrosine, tryptophan, and phenylalanine. Okay, there is this hydroxyl group or this OH containing groups. This include serine and threonine. Okay, this includes serine and threonine. So remember this aliphatic, remember as GAVLI. Okay, glycine, alanine, valine, leucine, and isoleucine. Whereas aromatic, remember as PTT. Okay, phenylalanine, tyrosine, and tryptophan. Okay, whereas hydroxyl, serine and threonine. Serine and threonine. Okay, then sulfur containing amino acids, just two, remember as MC or CM. Cysteine and methionine. Cysteine and methionine. Okay, then acidic amino acids like include like glutamic acid, aspartic acid, and the component of them is same, or is aspartame and glutamine. And basic, remember as HLE. Histidine, alanine, and lysine. Histidine and alanine. No, it will be having this overlap, Chico. Okay, and amino acid, proline is an amino acid. Proline, it is an amino acid. Okay, just remember. So if you can just remember this essentially amino acids as well, like tryptophan, valine, threonine, isoleucine, leucine, lysine, phenylalanine, and methionine. Okay, and there are a few things you should remember for must. One is this basic amino acids, which include this histidine, lysine, and arginine. And next one, it is the semi-essential amino acids. The semi-essential amino acids include arginine and histidine. Arginine and histidine. Okay, from these classifications, I know it is difficult, but you should try to remember it off because a question to pakka aayega hi aayega. Okay. Next about this ketogenic amino acid. This ketogenic amino acids include leucine and lysine. Leucine and lysine, they are this ketogenic amino acid. Fine. And this both glucogenic, and ketogenic include PET. Okay, PET. Phenylalanine, isoleucine, tyrosine, and tryptophan. Phenylalanine, isoleucine, tyrosine, and tryptophan. Fine. And next we need to look into this. Yeah, it is difficult. I know it is difficult. If you found itself very difficult, just let me tell you. Sulfur means just break them into parts. For example, you know, sulfur containing, it is just two amino acids, CM. Okay, acidic, it is this two acids. Two acids, what are this? Aspartic acid and glutamic acid. It is very simple. Basic amino acid, remember as HLA. Histidine, leucine, histidine, lysine, and arginine. Fine. Next one is what? Hydroxyl groups. You know, serine and threonine. So just try to split them up and remember. And aromatic, they are this GAVLI. Glycine, alanine, valine, leucine, isoleucine, and leucine. Okay. So it is difficult. I agree to the point, but if it is asked in the examination, then you cannot tell it is difficult how you can ask in the examination, right? There will be some point of elevation between this 149 and 150. And this level of difficulty and this level of dedication, you put effort, and all of this will manifest in converting this 149 into this 150 mark. And once you get this 150, there is lot of way ahead and you're just entering into the new universe. Fine. Whereas if you're stuck at 149, you will be roaming around, or you will be into the same vicious cycle again, and it will be difficult to come out once you get into the vicious cycle. So just there will be few difficult things that make you to get this 1 mark, which is from 149 to 150. Okay. Then there are few derivatives of this tyrosine. If you see about this tyrosine will give rise to the, we know one thing, which is the melanin. हमें पता है कि tyrosine, yeah, that's true, yeah, Chico, yeah, glycine बहुत ज़्यादा पूछते हैं, yeah, बिल्कुल, glycine में उनका प्यार है, okay. Then if you are able to see this derivatives of tyrosine, one is what, one is this melanin. फिर उसके बाद then you should know there are few hormones like catecholamines, thyroid hormones like thyroxine and triiodothyroxine, and catecholamines में dopamine, norepinephrine and epinephrine. all of them, they are the derivatives of tyrosine. All of them, they are the derivatives of tyrosine. Okay. So let's about tryptophan. We told 60 milligram of tryptophan. 60 milligram of tryptophan will give rise to 1 milligram of niacin. Okay. So it can produce niacin and nitromic acid, and it also produces this serotonin and melatonin. That's why we see in a case of carcinoid syndrome, there will be overproduction, so that this tryptophan will move towards the serotonin line, so that there will be less production and leading to this formation of this niacin or pellagra-like deficiencies. Okay, just remember. Then about this few more amino acids, if you see arginine, remember just one thing, arginine will be producing this nitric oxide. We studied, right? Where we studied? In the case of peristalsis, during peristalsis, which of the following component will cause us constriction? It is what? It is no VIP. It is no nitrous oxide. It will be produced from this arginine. So arginine produces this nitric oxide. Okay, and it also helps in the synthesis of creatine. Okay, just remember all these things from this amino acid perspective. Then we'll see some amino acid disorders. Just few more. Then we'll move on to this molecular biology, that is very simple and small, and after that we'll conclude it. Okay, that is our plan of action. If you see about this amino acid metabolic disorder, there is a child, yeah, princemental angina, yeah, that's true, guys. We'll give this nitric acid increasing drugs so that the dilatation will take place. Okay, there means incubating drugs so that the dilatation should take place, so that the vasospasm which is already happened will remove. Fine. And if there is a child who is presenting with features and complaints of urine which is turning black and prolonged exposure to air, or the mother complains that his or her diaper will becoming black after, means while removing, because after exposure to air this diaper is turning into black color. It is what? It is seen in a case of classically alkaptonuria. And in alkaptonuria, it is due to this deposition of this pigment, and this pigment even go and deposition into this cartilages, like your ear cartilages, your articular cartilages even. So this can be deposited into this ear cartilage, into your sclera, and into your joints. Okay, and on exposure to air, this will cause the discoloration of this normal color into the black color, because on oxidation this alkapton particles will get oxidized. Okay, and this type of bluish coloring of this eye and the ear, it is known as ochronosis. Fine. And we know this alkaptonuria, it is due to the deficiency of homogeneous oxidase. It is due to the deficiency of homogeneous oxidase. So alkaptonuria, it is due to the deficiency of homogeneous oxidase. Okay, homogeneous oxidase. Fine. Next one, you see a child who is presenting with feature of urine which is being mimicking like a brown sugar, or urine smelling like a brown sugar odor. So this urine smelling like a brown sugar odor, which will be seen in a case of branch chain BCKD. Remember, it is BCKD. It is branched chain keto acid deficiency. This is what this is seen in a case of maple syrup urine disease. It is be seen in a case of maple syrup urine disease. Fine. Here the child will be presenting with features of vomiting, poor feeding, and the urine smells like a maple syrup or a burnt sugar. Okay. Yeah. Correct, Dr. Shanwas Khan. Correct, Dr. Mohammed Arfat. Okay. Fine. Well, just few more things. Next, you say a child, like you say this child, this, like just see for a child, like they will be having this, they will be more fair in complexity. Fair complexion means they will be more white. Okay, and if you are able to see, there will be three things, like there will be fair complexion, there will be this blonde hairs, and along with that there will be this mental retardation, and one more typical urinary finding, it is what it is, this mousy or musty odor. So mousy or musty odor, hypopigmented skin, blonde hair, also known as what? Golden hairs. Okay, कितना प्यारा प्यारा hair है, ठीक है ना, कितना प्यारा प्यारा बाल. Okay ना, तो it is what it is, the golden hairs, and there is a mental retardation, along with sometimes can be mimicking with microcephaly and some features of seizures. And in this condition of phenylketonuria, what is the enzyme deficient? Guys, what is the name of the enzyme which is being deficient in a case of phenylketonuria? Yeah, guys. That is what it is, this phenylalanine hydroxylase. Yeah, good, Dr. Anas. It is what it is, the phenylalanine hydroxylase. fine. And in this case, we can use this test which is known as perichlorate test. Okay. Let's see the 𝗏𝗏 test. It is positive for most of the ketone bodies. In a case of diabetic ketoacidosis or in a case of starvation, then what we'll do? We'll do a test which is known as 𝗏𝗏 test, which will be positive for this ketone bodies. Yeah, good, Dr. Kamanna. Okay, good, fine. Next, about this competitive and non-competitive inhibitions. So in questions they will give you which of the following will be seen in a case of competitive inhibitions and non-competitive inhibitions. Okay, just don't mug up all these three. Just strike on this uncompetitive. That is not much important. You want to differentiate between this competitive inhibition and non-competitive inhibition. Remember, okay, if there is a competition, okay, if there is a competition, the velocity will be same, whereas you need to run more. Remember, it is you need to run more. Okay, if there is no competition, okay, if there is no competition, your velocity will be reduced. So there will be reduced velocity. Okay, if you are able to remember, well and good. If not, just see the chart. If you are able to see, in a case of competitive inhibition, there will be a cross. So cross will be seen in a case of competitive inhibition. Competitive inhibition क्या करता है? Cross करता है. Okay, good guys. Benetics text, it will be used for most of this carbohydrate disorders. For example, in a case of any fructosuria, any lactose intolerance, we need to detect whether is there any presence of this glucose or not, any glycosidic compounds or not. There we use this Benedict test, guys. Okay. Yeah, this competitive inhibition will be crossing. So because this Vmax will be, there is this no inhibitor stage and this is the inhibitor stage. There is no inhibition here. Whereas here, if you see, there is the incubation. So in a case of competitive, I told the Vmax will remain same. So Vmax will be same in a case of competitive inhibition. That's why these two graphs will passes at this point. That is known as crossing. That is known as crossing. Whereas here the Km will be increased. It will be Km will be increased. Okay, Km will be increased. Whereas in a case of non-competitive, you see the Km will remain same. Whereas this velocity will be decreased. The velocity will be decreased. Okay, velocity will be decreased here. Okay, that is the differentiation you need to do from competitive inhibition from the non-competitive inhibition. Okay, then we'll move on to this apolipoprotein receptors. This apolipoprotein receptors you should know for sure. Okay, why? Because they will ask you in a case of pharmacology and biochemistry perspective as well. We know this HDL, it is what? It is the good cholesterol. Why it is good cholesterol? Because this HDL, what it will does, you know, this HDL, it will take cholesterol from the tissues and it will bring back to the liver for metabolism. Okay, it will absorb cholesterol from the peripheral tissues and bring back to the liver. So the opposite of this, it is done by the LDL. The LDL takes cholesterol from the liver and it will deliver to the tissues. So that is the LDL. So the HDL, it will, what it will do? It will take from tissues and deliver to liver, whereas LDL, it will take from liver and deliver into the tissues. Fine. Whereas chylomicron, it is the absorption. Like whatever we eat which contains this lipid, okay, which is containing these lipids will be what? Will be the lipid forms, and this lipid should be absorbed, right? It will be absorbed in the form of chylomicron, and in between these intermediates will be have this IDL and VLDL. Okay, and this chylomicron will be having this B48. This B48 will be positive for LDL, chylomicron. Then chylomicron, you will be able to see all of these things, B48, 𝗍𝗏 and 𝗍𝗏, all of these three will be positive. Whereas HDL, you will be able to see this typical 𝗍𝗏. So it is a 𝗍𝗏 will be seen in a case of HDL1, okay, whereas in a case of LDL, okay, in a case of LDL, you will be able to see 𝗍𝗏B48. Whereas chylomicrons, you will be able to see 𝗍𝗏B48 along with this C and D, along with this C and D, okay. Yeah, good. You can remember HDL, it is ACED because there will be CED, whereas here main differentiating factor, it is the 𝗍𝗏. Fine. Now they started asking about this table. Okay, they will mostly ask like there is a child who is presenting, there is a child or a female who is presenting with features of this tendinopathy, pancreatitis, and there is now it is found to be the patient is having a features of increased cholesterol. Okay, increased cholesterol, and is due to the mutation at the level of LDL receptor. This LDL receptor mutation, it is seen in a case of type 2 type of hyperlipoproteinemia, and it is seen in a case of it is named as hypercholesterolemia. It is named as hypercholesterolemia. Okay, whereas in the case of Type 1, remember, it is due to the deficiency of this lipoprotein lipase. They will tell if there is any deficiency of this lipoprotein lipase deficiency, it will be classified as hyperchylomicronemia. Here there will be this triglycerides will be elevated along with this chylomicrons. Okay, just remember these 2 points, it is more than enough. If we can, then remember this beta lipoproteinemia, this will be the type 3 one. Okay, and hypertriglyceridemia, it is the type 4 one. Okay, just remember. Next, we'll move on to this rings, and just 2 more pages will conclude it off. Okay, do you need any break? Yeah, guys, do you need any break? Just more 10 minutes it will take. No, right? Yeah, good. We are good to go. Yeah, fine. Yeah, good, Dr. Naresh, Preeti, Bharat, Sky, yeah, Rahul. Yeah, good, Dr. Anna. Yeah, fine. Yeah, okay. We'll continue. Just 2 more pages. Yeah, then we are done. Just this 2 more pages. Okay. If you see about this purine, you need to know about this composition. That's it. You know this purine and pyrimidine. Okay. Here there will be the source you need to know. Like mainly the amino acids which is forming this purine ring. They will ask you. It is this glycine, aspartate, and glutamine. Glycine, aspartate, and glutamine. Glycine, aspartate, and glutamine. Here they will ask you, what is the source of this nitrogen? N1. This N1 it is because of this aspartate, and N3 and N4 it is because of this glutamine, and here N7 it is because of the glycine. Okay, if you know this only, it is more well and good. If not, you can remember all these things as well. Next, about this rate limiting enzyme for this purine synthesis, it is what it is, this glutamine PRPP aminotransferase. Okay, it is the glutamine PRPP aminotransferase. It is a rate limiting enzyme for this purine metabolism. Whereas in the case of pyrimidine, we already discussed, it is this carbamoyl phosphate synthase 2. Where will we saw that carbamoyl phosphate synthase 1? Hey guys, where will we saw this carbamoyl phosphate synthase 1? In which pathway? Yeah, CPS1 will be seen in a case of urea cycle. We saw in a case of urea cycle. Fine. Here also you need to see, like here it is aspartate, the same aspartate is here, it is giving this N1, and here the glutamate gives this N3. Okay, that's it. Next, we know there is a syndrome which is known as Lesch-Nyhan syndrome. It is due to the deficiency of HGPRT deficiency, and here you will be able to see this hyperuricemia, mental retardation, and self-mutilation. Yeah, self-mutilation behavior. So all of these features, hyperuricemia, self-mutilation features, and along with these features of mental retardation, all of these things will be classically seen in a case of Lesch-Nyhan syndrome. They will tell the child is biting his own lips, the child has eaten his own finger. So all of these things, it will be suggestive of Lesch-Nyhan syndrome. Right? And then we'll come to the types of RNA. In the type of RNA, just remember one RNA, which is this mRNA. So messenger RNA is the only one RNA, which is this protein coding RNA. So protein coding RNA, it is the mRNA. Fine. Next, there are other RNAs like rRNA, means like INC-RNA, tRNA, and snRNA, microRNA, and silencing RNA. All of them, they are this non-coding. They won't code for any proteins. Okay, they won't code for any protein. Just remember, only protein coding RNA, it is the mRNA. That's why if you see, this is the image of a tRNA, and this tRNA, it will go and attach to this mRNA, and it will code for this protein. So it need a help of mRNA to code any proteins. Okay, fine. And the parts of tRNA included is the acceptor arm. What it will accept? It will accept your request. No, it will accept what? It will accept the amino acid. So it is the amino acid acceptor arm. It is the amino acid acceptor arm. And there is few more arms which is known as 𝗚𝗏𝗃 loop. Okay, it is one of the modified arm. It is the 𝗚𝗏𝗃 arm. Then another one is the D arm, and another arm which is being in attachment to this mRNA. It is known as what? It is known as anticodon. It is known as anticodon. And sometimes this small bulge-like arm which is known as variable arm or variable loop will be present. Okay, so just remember tRNA, it will be having this acceptor arm where it accepts these amino acids, and it will be in attachment to this mRNA by this arm which is known as anticodon arm. They will just ask you which of the following codon or which of the following arm of this tRNA will be in attachment with this mRNA. What is the answer, guys? Yeah, Ambika, what do you want to repeat? Could you please brief? So if you see this tRNA, it will be having these parts. Like for example, one is the acceptor arm where it will accept this amino acid. Fine. Next one, there is one more arm which is known as 𝗃𝗍 arm. Then another arm which is known as D arm. There are 4 arms. Like usually they will be having this 4 arm. Acceptor arm. This is the acceptor arm. Then this D arm, then T arm, and then anticodon arm. Okay. And there is one more arm which is this variable arm. And remember this is the tRNA structure, and this tRNA, it will be attached to this mRNA to produce an protein. Okay, guys, it will produce an protein. And remember, this attachment will be made at the level of anticodon arm. It is made at the level of anticodon arm. Okay, can anyone tell me which of the following component, like antimycin and BAL, inhibits which of the following ETC component? As it inhibits this third complex. It is the third complex, ETC third complex. Yeah, good, Dr. Ansh. Okay, it inhibits third complex. If it is one like barbitone, it inhibits 1. Okay, then if it is melanite, it inhibits 2. Whereas antimycin and BAL, it will inhibits what? It will inhibits the 3. Okay, remember. And whereas 4, it will be inhibited by this cyanide, then hydrogen sulfate gas. Okay, cyanide, hydrogen sulfate gases. Okay, just remember. Next about this stands. Okay, yeah, good, Dr. Shanavas, Dr. Ambika, Dr. Ansh, and Dr. Anna, Dr. Isli, Dr. Chiku, Dr. Dronographic, and Dr. Lahul. Like, yeah, we're getting it correct. Okay, yeah, good, guys. Okay, and carbon monoxide, yeah, carbon monoxide as well. Next about this template and non-template stands. Okay, this, if you see, like, it is very easy, but it will be very confusing. So first you need to know this codon arm, template stand, and mRNA stand. Okay, just first you need to know. If they give you this coding stand, or whenever they give you something, it will be usually in the direction of 5' to 3'. It will be in the direction of 5' to 3 direction. Right? Remember about this coding stand. If they give this coding stand, and they ask you to make it into a template stand, okay, means template stand means it is the opposite of it. Then you know, if this coding stand, it is in the 5' to 3' end, and this complementary, it will be in the opposite direction. So here it will be 3' and here it will be 5'. So if it is T, it will be paired with A. Okay, and C, it will be paired with G. Okay, so remember, if the pairing is like this, then the pairing will be like this. Like T will be paired with A will be paired with T, C with G, CG, CG, GC, then TA, CG, and AT. And now they are asking what is the template stand. Then what you need to do, you need to make this into 5' to 3', and you need to answer it. Okay, first, right, the coding stand, it is the same. You need to make this complementary pairs like this, and you need to write from this direction to this direction, and you need to write that is the template stand, because whenever we mention them in the 5' to 3'. Okay, and just imagine, now they have given you, yeah, good, Dr. Mohammed Ansh, like it is known as Chagaff rule. Yeah, good, Dr. Ansh. So if you see, they given you this coding stand, and they are asking you about this mRNA. And if they given you this coding stand and they are asking you to find out this mRNA, now just simple things you need to do. It is already in the 5' end. Okay, now what you need to do is that you need to replace this T with U if only coding stand is given. So remember, see, this, remove this T by U, then everything is same. Okay, everything is same. Remove this T by U, then it is the mRNA. Okay, then it is mRNA. So from coding stand to mRNA, it is just remove this T or replace this T with U. Fine. Whereas template stand, you need to make this complementary stand, and you need to convert into 5' direction to the 3' direction. Okay, if you get it, well and good. If not, I will show you an example. If the template stand is like this, given as GA, TC, TAC. Okay, fine. Here they will ask you to find this complementary stand. How will be this complementary stand? Means if the template stand is given here, what will be the complementary coding stand will be, or non-template stand will be. So remember, it will be written, I told you, usually it will be written in 5' to 3' direction. It will be written in 5' to 3' direction. Okay, then write this 5' GA, TC, 𝗡𝗵𝗃. Okay, then you need to, I told you 5' to 3' if it is written, the complementary arm will be 3' to 5', 3' to 5'. Okay, so we need to write the answer. So when we need to write the answer, we need to write them as 5' to 3'. Either we can create this complementary strand, like for example, if it is like this, we can create this complementary strand and then we need to turn. At those moments, there will be few point of confusion. So what we'll do is that we'll just convert this strand sequence into this 5' into this 3'. Like now what we are doing is that we are converting this 5' to 3' of this template strand into 3' to 5' of the template strand. So obviously the next non-template strand, it will be what? It will be 5' to 3' in nature. So it will be what? It will be 5' to 3' in nature. So first what you do, we'll flip it up. So you put 3 here, you put 5 here. So it is, you just flip them off. T here, A here, T, then C, then T, then A, then G. So you just made it out, right? Then what you do, you just complement it each other. So we know C, it will go with which of the following? It will go with G. Okay, and if they are asking in a case of mRNA sequence, then we know A will be pairing with what? A will be pairing with T. We know we cannot use T in mRNA, so we'll use U. Fine. Then T will be pairing with A. C will be pairing with G. T will be pairing with A. A will be pairing with T, but will replace with U, and G will be pairing with C. Okay, this is how you need to understand and you need to answer if they ask you to prepare an mRNA from a template strand. Okay, I think like I think you got this thing correct. Okay, did you got it, guys? Yeah, I know you hate this topic, but you try to do this way. It will be help you, because like actually like in unfortunate situations they won't ask you, क्योंकि last bar like in I guess in December, like in July 2024 they asked this coding stand wala. ठीक है ना, simple है. Means that's what, like you just see this video one more time of this template stand, nothing but this video will be available. See this video one more time, आपको ही समझ में आ जाएगा. Like don't worry, don't panic. Like few concepts will be like this. Like for example, your ABG analysis, it looks simple, but you make much confusion in it. Just see those pointers in means one more time. You will able to get these things correct. Okay, if any, write me out. Okay, we'll catch up also. Right. Next you need to remember about this few DNA errors. This include base excision repair. This base excision repair, it includes this myths. It will cause this myth associated polyposis. There will be associated of myth associated polyposis, and remember this MMR. So MMR, it will be associated with this hereditary non-polyposis colon cancer, H and PCC. Then there is this nucleotide excision repair. Remember this N nucleotide. Okay, nucleotide excision repair will be seen in a case of xeroderma pigmentosa. Okay, remember mismatch will be seen in a case of H and PCC. Nucleotide excision repair will be seen in a case of xeroderma pigmentosa. And homologous DNA repair you will see in a case of Fanconi anemia, Bloom syndrome. Okay, Bloom syndrome and Werner syndrome. Okay, Fanconi's anemia, Bloom syndrome and Werner syndrome. Whereas this non-homologous will be seen in a case of, mainly you need to remember one thing, this SCID and 𝗡𝗚𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃 it will be asked in your pathology and biochemistry as well. Guys, like Sam, like you study your already studied notes. For example, you revised your notes. It will take like every notes of mine. This notes is just 11 pages. It is just 11 pages, and I didn't wrote huge informations. It is very small informations that you can revise it off. Revise these notes for 10 to 15 minutes, and along with this do PVQs. That is more than enough. Okay, that is more than enough. Okay. Fine. Yeah, 𝗵𝗵𝗶 is the main syndrome. Yeah, guys. Then just read about this few enzymes. What is their role? If you see this heligase, it will cause unwinding of the DNA. So it will separate this DNA. It will cause us this unwinding of the DNA. Next one, that is the synthase or this primase. It will cause synthesizing of this RNA primer. So we know that when there is a strand forms, initially it will be placed with RNA. So this RNA primers, it will be formed by this primase. Then DNA polymerase 3. This DNA polymerase 3, it will be helpful in this proofreading, and also it will added base for this. It will help in DNA synthesis as well as proofreading as well. Okay, and DNA polymerase 1, it removes RNA primers and it also replaces this Okazaki fragments. They will ask you which of the following DNA polymerase will replace this Okazaki fragments. It will be done by this DNA polymerase 1. It will be done by this DNA polymerase 1. Fine. And next one, ligase. We know ligase means binding. So ligase will help in the binding. Next one is DNA gyrase. Okay. This DNA gyrase or 2'-isomerase helps in removing of the supercoilings. To remove the supercoilings, we will use this DNA gyrase or this 2'-isomerase. So these are the enzymes you need to remember from the biochemistry perspective. And that's it, guys. That's it for the biochemistry, and that's it for the day. Just remember one thing: if you are consistent with your efforts, okay, and if you are consistent with your studies, you can cross this examination. And remember, you don't need to be perfect in all the topics. You need to be perfect in the topics which are being asked like this. Okay, and remember, you should be consistent from the day one, and if you are consistent from today itself, from today onwards till your date of examination, you can crack this examination. Right? Yeah, Dr. Sam, like I'm open for your queries. Yeah, is this enough? Yeah, it is more than enough. If you read this thing and if you attempt your PVQs, you will get at least the minimum number you will get is 90% correct. Okay. Yeah, thank you, Dr. Rituraj. Yeah. Yeah, like there are thousands of chances. That's why if you see, your notes will be of curated in a way of PVQs, and if you see PVQs, it is always being repeated. At least 50 to 60% of this PVQ and PVQ topics will be repeated. That's why I'm here. Okay, thank you, guys. We'll see you tomorrow. Thank you, Dr. Anjit Ojo and Dr. 𝗵𝗵𝗀𝗀𝗀. Yeah. Anything else? Yeah, thank you, Dr. Preeti. Thank you. I really love you guys. Like, you know things much better. What you need is this: you just keep this hope alive, keep these things alive for a few more days, and you will execute this in the examination for sure, and you will come out with flying colors. Fine. Okay, guys. Thank you, Dr. Hassan. Thank you, Dr. Naresh. We'll see you in tomorrow's session, and I'll be eagerly waiting to see you guys. Okay. See you guys. Thank you. Bye.